Sir. Very good morning to all of you. Today I will be speaking on post-menopausal hormone replacement therapy. I would, before starting, I would say that I would interchangeably use the term hormone replacement therapy and monopostomal hormone therapy, MST. Because after the 2002, people thought this is not a replacement, so this is a menopausal hormonal therapy. So, and the recent articles, they have replaced the term HRT and they are now using MST. So, few of the slides I would also show with MST. So, don't get confused, both are same. So, menopause, no need to say about how to diagnose menopause because it's a clinical status after the final menstrual period, and this is diagnosed retrospectively. If somebody is amenorrheic for more than 1 year, then you say patient in stage of menopause. There is no clean-cut biochemical data or FSS level to say that this FSS cutoff is menopausal or pre or post-menopausal. It just reflects complete permanent cessation of ovarian function and fertility, and the average age is 51 years, and everybody in this crowd would agree with me that this is the Western data. But the Indian data by Dr. Ahuja, published in Indian Menopausal Society, this is a pan-India survey. They did the pan-India survey, found that the average age of menopause is about 46 years in Indian population. However, the urban, rural, the age differs, but the median age in Indian population is 46 years. But if you look at the manifestation of estrogen deficiency, that differs from perimenopause to the advanced stage. As you can see in the perimenopausal phase, primarily they present with vasomotor symptoms like hot flushes, sweating. As you know, the hot flushes are increased sensation of heat over the chest and face. They last for maybe 5 minutes to half an hour, maybe sometimes prolonged to 1 hour. And this all leads to insomnia, difficulty in sleep, and some psychosocial symptoms like depression, loss of memory, loss of concentration, and irritation. And this is the primary reason why they come to the physician or endocrinologist, gynecologist, that my mother or wife is getting more irritated nowadays, she is getting violent. And so that is the reason that many times people approach to the physician or gynecologist or endocrinologist. As you all know that the superficial layer of the vagina and uterus are all estrogen dependent. With the declining estrogen level, there occur atrophy of the superficial level. That leads to vaginal dryness, burning sensation, irritation, vaginal atrophy, and there is this intrauterine size of the vagina becomes smaller. That's lead to dyspareunia, some urinary symptoms like urgency, frequency, incontinence, repeated urinary tract infection, and in a long period there was increased risk of osteoporosis, cardiovascular disease, and Alzheimer's disease. So it's all lead to reduced quality of the life. And if you look at how prevalent is this vasomotor symptoms, if you look at the problem, about 70 to 80% of the perimenopausal female, they develop, they have these vasomotor symptoms. And if you look at any disease, no disease has prevalence of 80%, 90%. So it's a very common clinical problem, and there has been lots of confusion regarding how to treat, whom to treat, how long to treat. I'll speak about that. In spite of the problem being very prevalent, hardly 20 to 25% people seek for the help. And coming to speaking about the hormone replacement therapy, I would divide into two parts. So before the publication of the result of Women's Health Initiative trial in 2002, and after that, what happened to hormonal replacement therapy after that? Initially, when in 1942, the conjugated equinestrogen that was approved by FDA for menopausal symptom treatment. In 60s, 70s, 80s, it was a very popular treatment. So many influential ladies, even general population females, they were taking hormonal menopausal treatment because of primarily they think that there is an erroneous concept of that they would remain feminine forever. So that is very popular. In 1988, the FDA approved that HRT is approved for the prevention of osteoporosis. Then it further become very popular. So in 90s, it was very popular and very commonly prescribed by the gynecologists and endocrinologists. But however, and they had the idea of the few observational studies showed that gives cardiac protection and reduces mortality. So few studies they directly did on postmenopausal women having cardiovascular disease, how the estrogen is doing. They found there is no benefit. So these are smaller randomized studies. Even the HER study, that is heart estrogen progesterone replacement study, they said if you give estrogen, then that is going to harm you. There is a cardiac event even increasing, even occurring within 1 to 2 years period. So there is a large trial that was done by the NIH in USA during those time in 95, 96. They followed a large number of postmenopausal healthy women to see for the chronic disease prevention. So in that trial, they wanted to see about how the estrogen progesterone combination giving cardiac protection or cancer risk. And the trial has two arms. One is estrogen arm, another with estrogen and progesterone. They used conjugated estrogen and 2.5 for medroxyprogesterone. And majority were 50 to 79 years old, they were the participants' age, but the majority were elderly. And the most disheartening thing is the result of WHI 2002, that the result first published. And before that, people thought that this is very protective, very good for hormonal treatment for the vasomotor symptoms, but the result was very disheartening. That said that actually the estrogen progesterone, the arm was stopped, terminated early because it increases the risk of cardiovascular disease and breast cancer. Mind you, both estrogen and progesterone combination. So bottom line message was that it's more harmful than it's doing good. But however, and this data NIH directly disseminated to the print media, and print media published very negatively about the hormonal replacement therapy. And even you can see that there is significant and mildly significant increased risk of breast carcinoma of 1.24, and the media published in the paper that there is 24 times higher risk of breast carcinoma with hormonal replacement therapy. So, but they never gave the absolute risk involved with for the breast carcinoma. And after few years, 2 years, the estrogen trial continued. And after 2 years, in 2004, the estrogen trial result published, and it has good outcome that it didn't increase the risk of breast carcinoma, coronary artery disease. However, the trial was stopped because estrogen increased the stroke. So the overall message was negative, but however, some good outcome from this WHO trial was that it reduces osteoporotic fracture, it reduces colon cancer, and estrogen alone also reduces breast cancer. And the result of that is The prescription of HRT reduced by 80% after 2002. As you know in your clinical practice also, very rarely now the HRT is being used because of this WHO trial study. But however, the later publication of the WHO trial was very encouraging. In 2006, they reanalyzed the WHO data by age stratified weight from 50 to 60, 60 to 70, and 70 to 80. And that they saw that they found that estrogen is having protective effect in younger women, and it is detrimental only in the older population. Again in 2007, another publication of younger population or less than menopause of less than 10 years, they found it reduces mortality by 30%, both estrogen and estrogen progesterone arm. And finally, the 13-year follow-up published in 2015 that this primarily benefit, it's cardioprotective in 50 to 59 years old female, and the protective is more in estrogen, and it is less favorable in estrogen and progesterone combination. So again, there is an article published in the Wall Street Journal with the entitled that how NIH misread the hormone receptor hormone study in 2002, and the article stated that some aspect that was reported were misleading and just wrong. And women in their 50s are 30% low risk of dying if they are prescribed hormonal therapy. And coming to the different aspect of hormonal therapy, it's primarily being indicated for the vasomotor symptoms. All estrogens are useful in reducing hot flushes, and both placebo and meta-analysis has clearly proven that. And for that, Endocrine Society has come, there is recommended Endocrine Society guideline has come in 2017 that said that the menopausal women of less than 60 years or 10 years, less than 10 years past menopause, within 10 years of menopause, if there is no risk of cardiovascular disease or breast cancer, they recommend estrogen therapy without uterus, and estrogen and progesterone therapy in presence of uterus. So this is a recommendation, present recommendation of the Endocrine Society guidelines. And coming back to coronary artery disease, and when they looked into the data in the age stratification group, in a younger group less than 60 years, they found that hazard ratio of coronary heart disease is 0.65, and myocardial infarction is 0.60. So this all are beneficial as the cardiac part is concerned. However, the effect is less favorable for estrogen and progesterone combination as far as the cardiovascular risk is concerned. So Endocrine Society guideline says that if you want to give MST, you assess the cardiovascular risk by the AHA or ACA, the cardiovascular risk estimator. If the risk is low, less than 5%, absolutely you can give hormonal replacement therapy. If the risk is 5 to 10%, then you better to use transdermal preparation. If the risk is more than 10%, you should avoid giving hormonal replacement therapy. And breast cancer risk, I clearly showed that the estrogen group significantly decreases breast cancer risk. Only the breast cancer risk is increased when you are prescribing both estrogen and progesterone preparation. But when they did reanalyze those data by adjusting the confounding variables which normally increases the breast cancer, they found even the estrogen progesterone is not increasing the breast cancer risk. So if you look at the breast cancer risk, you can, the right hand bar you can see those who are having highest breast density. Those patients having highest breast density have highest risk of breast cancer. So other risk factors like obesity, even the flight attendants have a very increased risk. But just look at the two small bars on left hand side, that denotes the estrogen, and that is decreasing the breast cancer risk, and estrogen progesterone, the relative risk is only 1. So compared to the other risk factor of breast cancer is very negligent with the estrogen and progesterone preparation. And Endocrine Society guidelines are there to how to assess the risk and how to prescribe medical hormonal therapy. And osteoporosis, there is a clear-cut benefit. The meta-analysis has shown the hormonal replacement therapy is clearly beneficial as far as the bone part is concerned, and mostly it is helpful if it is started less than 60 years. There is risk of thromboembolism with estrogen. There is twofold increased risk of thromboembolism with estrogen, and the risk is further increased with the progesterone. However, in spite of that, if you use observational data set, if you use transdermal estrogen, that doesn't increase thromboembolism. And there is another benefit of that HRT would reduce the diabetes incidence. You can see there is 35% and 21% reduction in the WHI trial. So just to say that estrogen, you can see the cardiovascular and breast cancer risk, the blue line denotes the estrogen, that is the most beneficial coronary heart disease part is concerned. And if you look at the invasive breast cancer, it's more beneficial on the right hand side, and it's only detrimental if you combine estrogen and progesterone. So how to approach this patient? So if age is less than 60 years and less than 10 years of menopause, you give MST. Just be careful in some condition with unexplained vaginal bleeding, history of TIA, history of endometrial carcinoma, liver disease, or diabetes. You should be careful with hypertriglyceridemia or history of migraine. Then you evaluate cardiovascular risk, as I mentioned in the Endocrine Society guideline, or breast risk, cancer breast risk. And then if it is all okay, then you go ahead with estrogen. If uterus is present, then you give estrogen progesterone or estrogen vasodoxepin or tibolone where is available. In FDA has approved in 2013 estrogen and vasodoxepin in 20 milligram doses. So you can use where there is uterus is present, in the right hand side you can concentrate that the estrogen and progesterone combination has to be given. If in the perimenopausal, you choose sequential therapy, means estrogen, progesterone in a sequential way. Means few days you should not give progesterone. And in the postmenopausal, you give continuous estrogen and progesterone preparation. And these are the various estrogen preparation available. I won't go into detail because of shortage of time. The micronized estradiol and estradiol is commonly prepared. Estradiol patches, gel, spray are available. The dose which is a gel spray are available are almost equivalent to the estradiol oral tablet. Similarly, many progesterones are available, a synthetic progesterone like medroxyprogesterone, non-ethidrone. But now the dydrogesterone is very popular because of the lesser side effect. It's a retroisomer of natural progesterone, so it's more commonly absorption is good, and it doesn't have more progestogenic effect as like the synthetic progesterone. And various combinations are also available like CEA, MPA, and estradiol with dydrogesterone, which can be used. And transdermal progesterone is also available, but these are not very useful as far as the MST is concerned. How to monitor? Every year you call your patient, do the physical examination, do some basic investigation like blood sugar, triglyceride level, do assess for the endometrial thickness, do assess for the breast cancer risk. And this is my last slide. That MST is very effective for the symptomatic control. It's a IMS International Menopausal Society guideline, and North American Menopausal Society guideline says that MST is very effective for symptoms, and you need to individualize the treatment. Who needs treatment depending on the symptoms, and what is the expectation of the female? What does she expect from the treatment? You need to assess, and you need to assess the family history. You need to assess the personal history of cancer and the cardiovascular risk. And the lowest effective dose should be used, and maximum safely can be used up to 5 years of the time. And the bottom line is benefit will mostly outweigh the risk in symptomatic women if it is used very early, less than 60 years or less than 10 years of onset of menopause. Thank you.
Thank you. It was really nice deliberation, beautifully explaining what are the exact indications. Yes, it has to be less than 60 years of a menopause age of the female and less than 10 years of female. These are the groups of patients who really are benefited, and all aspects you have covered nicely. So
thank you.
Thank you.
Thank you, Dr. Kanwar. I think that was very important, and yesterday we discussed about andropause, and today we are discussing about menopause. And andropause, though it's not clearly defined, menopause is very well defined. As he has told, less than 60 years with less than 10 years of menopause, I think we can jolly well give a hormone replacement therapy, but individualization is the most important thing, and we have to see other factors. Thank you.
Thank you. Thank you.
Any question from the... So if there is no question, we'll proceed for the next session. Sir?
That is individually you have to decide. If somebody having severe vasomotor symptoms and really troublesome vasomotor symptoms, and their age is less than 60 years and less than 10 years of menopause, then absolutely you just look at do a breast examination and cardiovascular risk, and you should give it. And the low doses of estradiol and low doses of progesterone are available. Now the estradiol 1 milligram, dydrogesterone 5 milligram is available. So if you are confused what dose to be given, just start with a low dose of estradiol of 1 milligram and 5 milligram dydrogesterone continuously in the postmenopausal. If it is perimenopausal, you can give sequentially. Both things are available with the different companies. As I said, there is very good data regarding for can be used up to 5 years of age, 5 years of duration, and after the 5 years, if that is very absolutely individualized. Data are not there to continue beyond 5 years, but if you feel that there is no risk, if you feel it's safe, and still patient is continuing to have, if he's stopping the estrogen, progesterone or any MST preparation, you are stopping a patient having similar symptoms, you can continue. That depends on the logic or IQ of the physician who is prescribing the medication.
If you stop prematurely or something.
As you know that the postmenopausal symptoms, the perimenopausal symptoms, this occurs up to 5 years of the postmenopause. So that is the reason why 5 years. But as far as if you want to feel there is a risk of cardiovascular disease, or even the risk of you want to prevent osteoporosis, then you can continue for a long time. If you find the risk is higher, if you do a FRAX score, if it is find is very high risk, then you can continue with the low doses.
My question is, if you give for 1 year, patient feels better, you stop the medicine, what is the chances of recurrence of the symptoms?
That exactly, sir, what the percentage I cannot say, but depending on whether the patient is having the similar symptoms again, you can continue up to the 5 years. But exactly I cannot say what is the percentage, how many would recur.
Thank you.
Thank you.
Thank you, sir. Thank you, ma'am. It was really a very wonderful session. Coming to the next talk, may I invite the chairpersons, Dr. Pitambar Prusti sir, Senior Endocrinologist, Apollo Hospital, and Dr. Sandeep Sahu, Assistant Professor, Endocrinology, High-Tech Medical College, Bhubaneswar.
A very good morning to all of you. We will be talking about again coming back to diabetes. As we know, there are many dimensions of achieving a target in type 2 diabetes mellitus. What we learned is that it is the hemoglobin A1C which should be controlled at least up to 7% or below. So to prevent the long-term complications in type 2 diabetes. But hemoglobin A1C measurement is not enough, that we knew, because there are many dimensions which have come up. Even though hemoglobin A1C may be similar in some individuals, the complication rate may vary. So what are the other dimensions that we should target? So these are called triune of hypoglycemia, the glucose variability, and the time in range glucose, that is the time period in which a person with a type 2 diabetes when treated remains of having a good control of blood sugar. So that I think is the discussion of today's morning diabetes session. I will request my co-chairperson to introduce the speaker.
Thank you very much, sir, for your kind words. So without much delay, I would like to invite Dr. Ritesh Agrawal, sir, on stage to have his lecture on his topic. So sir is an eminent endocrinologist from Odisha and known for his contribution to the field of diabetes and thyroid disorders. And now he is practicing at Amri Hospital and NFFC at Bhubaneswar. And he has 12 number of publications and in various journals. Over to you, sir.
So, thank you, Chairperson, for your kind words. Good morning, everyone. After a good discussion on the hormone replacement therapy, now come to the daily routine practice on the management of diabetes. Yesterday we had a great session on the diabetes in hospital management and the different use of the different type of insulin analogs. So with the availability of the newer insulin, we are addressing some of the pitfalls what we face with the older generation insulin. In the same way, the topic of second generation basal insulin, how we are giving justice to our patient. So with this, the concept of glycemic variability, time in range comes now, review of the global recommendation, addressing the hypoglycemia, glycemic variability and time in range, and comparing the second generation basal insulin analogs in the light of this time in range. We know about the triad in the management of diabetes, that is fasting blood sugar, postprandial blood sugar and HbA1c. So in spite of having the normal HbA1c, we are not able to control the micro and macrovascular complications. I will show how the HbA1c control also shows the different glycemic variability. So now the concept of hexad come, where along with the triad, we need to address the nocturnal hypoglycemia, overall hypoglycemia and the glycemic variability in the management of type 2 diabetes. So glycemic variability can be divided either as a intraday glycemic variability, that is within day, or interday variation, that is in the within the day. It leads to the oxidative stress, which leads to increased risk of severe hypoglycemia. So this glycemic variability, which is associated with this diabetes related micro and macrovascular complications, which leads to the poor quality of life. And it has been proved that this glycemic variability is responsible for the endothelial dysfunction, which is most responsible for the common soil hypothesis in the various microvascular complication. It also associated with the cognitive impairment and increased risk of mortality is observed where the patient have with increased visit to visit glycemic variability. So what I was saying, here you see there are way where the HbA1c is below 7%, but the times in range is 18% in the first, 63% in the second and 3% in the third category. So those group of patients who spent maximum time in range, they have a lesser risk of micro and macrovascular complication with lesser risk of peak and trough in the diabetes. So this HbA1c alone will not give us an idea about the throughout the day glycemic variability, and where the glycemic variability by means of continuous glucose monitoring system comes, and now ADA also endorsed the criteria of time in range in the management of type 2 diabetes. So the time in range, what's above or below in range, so it is defined as the time spent in the target glucose control, that is 70 to 180, but it can vary according to the elderly population, type 1 diabetes, pregnancy and others, while aiming at reducing the time spent in hypoglycemia. And it can be divided for hypoglycemia, it is level 1 hypoglycemia if the blood sugar below 54, level 2 if the blood sugar is below 54. In the same way, high blood sugar more than 250, more than 180 to 250 as level 1 and level 2 hyperglycemia. And the blood sugar between 70 to 180 is the time in range, and which can be, if we take 100% in the 24 hour, the blood sugar 70 to 180, the time period is the percentage of time in range, above which is the time above range and below which is the time below range. And it has been shown in our Indian study where the Kalra et al. They found that even 10% decrease in time in range, let me say if we target the time in range is around 70% throughout the day, if it decreased by 10%, the retinopathy risk increased by around 64%, nephropathy by 40% and neuropathy by 25%, even if the HbA1c is under control. So this initial evidences show increase in the surrogate marker of the macrovascular complication like carotid intima thickness also. And this is the way how this time in range evolved, and in 2021 ADA endorsed the continuous glucose monitoring as an important tool for the hypoglycemia prevention and day-to-day practice management. So what I was saying, the ADA 2019 recommendation time in range for the different diabetes patient, here I was saying the type 1 and type 2 diabetes, older people where the high risk of hypoglycemia, pregnancy with type 1 diabetes and gestational diabetes mellitus, where in type 2 diabetes where what we are routinely see the time in range target should be more than 70%, time below range should be below 5% and time above range should be below 25%. But in type 1 or type 2 with elderly or high risk, you should maintain a time in range above 50% is also sufficient to prevent the complication. In pregnancy type 1, we have to maintain a time in range is around more than 70%, and in pregnancy, gestational and type 2 diabetes, where the time in range should be more than 80%. So this is the ADA recommended time in range you have to maintain in your day-to-day practice to prevent the future micro and macrovascular complication along with the HbA1c. In the same way, in adolescents, adult, pregnant and elderly, what I have told, elderly more than 80% time in range allowed, in pregnant women more than 80%, adolescent more than 70% in type 2, more than 80% in type 1, and in adults more than 70% and the tighter control more than 80% without risk of hypoglycemia is the need. And this suboptimal clinical utilization of the TIR in day-to-day practice, though it is a new concept, it is very difficult to find out the time in range by utilizing the continuous glucose monitoring system. So to address this issue, at least if we are able to give the treatment which in some way address the glycemic variability and more time in range the patient will able, then it is also a good and the welcome criteria, where the second generation insulin specially is helpful in decreasing the glycemic variability and more number of patients are in more time in range. So the basal insulin can effectively address the hypoglycemia, glycemic variability and time in range, where the peak and troughs can be targeted and it gives a lesser risk of hypoglycemia in glargine, lesser risk with glargine versus premix and co-formulation. And if you see the peaks, basal insulin, glargine control little bit of PPG by targeting the fasting plasma glucose. And we know the hypoglycemia erodes patient confidence on insulin. Yesterday also we discussed it about. So 1 in 5 patients of the type 2 diabetes achieve only HbA1c of less than 7%. 2 in 5 patients have hypoglycemia risk and 77% patients experience hypoglycemia after 6 months of insulin initiation and they discontinued insulin for after 1 year. So it is the need of the hour to give the best insulin to our patient to prevent the risk of hypoglycemia, either it is nocturnal or overall. So second generation insulin evolved keeping patients in mind. Here you see glargine 100 versus the NPH, insulin detamir versus the glargine 100 graph, insulin digludide versus the glargine 100 and glargine 100 versus the glargine 300. The pharmacokinetic and dynamic of the second generation glargine 300 will give peakless insulin and less glycemic variability, which is responsible for the less risk of nocturnal and the overall hypoglycemia. And this is the BRIGHT study which gives the head-on trial between the glargine 300 and insulin digludide, where you find in terms of HbA1c reduction, they are equally efficacious in HbA1c reduction, but in terms of the anytime risk of hypoglycemia is also similar. But in the initiation period of the initial 3 months, where the frequent up titration of the insulin or the correctional doses of insulin required, where the insulin glargine 300 shows lesser risk of hypoglycemia compared to the other second generation basal insulin, and overall risk of hypoglycemia and HbA1c reduction are H par in the second generation insulin. Here also you see the risk of nocturnal hypoglycemia in the second generation glargine 300, it is better with the glargine 300 compared to other in the total events rate. So if you compare this glargine 300 with the digludide 100 during the most critical phase of the insulin therapy, that is the titration phase, it shows 24-hour confirmed hypoglycemia risk is reduced by 26%, confirmed hypoglycemia at any time of the day reduced by 37%, confirmed hypoglycemia, event rate anytime 23%. So overall decrease what we want to decrease in our patient with the second generation insulin. So early hypoglycemic event during titration are associated with increased risk of treatment discontinuation, which can be addressed by the second generation basal insulin. So let's examine how this second generation insulin address our glycemic variability and helps the people to be in range. Here you see in the type 1 diabetes study where the glargine 300 has lower within day-to-day variability compared to Digludac, and it shows 20% lesser within day variability with glargine 300 compared to Digludac. And here you show the pharmacokinetics and dynamics where the mean glucose infusion rate and the peak are lesser in the glargine 300 arm compared to the Digludac 100. Here also see the further data demonstrating lower variability in the glargine 300 with 22% greater peak found in the Digludac 100 compared to the glargine 300, with 23% lesser glycemic variability you will get with the basal insulin glargine 300. I think this will address what we are need now. In the same way, in the continuous glucose monitoring study also, to compare the efficacy of the glargine 300 on glycemic control using the continuous glucose monitoring system in terms of the efficacy endpoint between time in range around 70 to 120. And here you see the time below range was markedly lower in the glargine 300. Anytime risk of hypoglycemia statistically significant, nocturnal hypoglycemia, severe hypoglycemia is lesser in the glargine 300 R, which shows the time in range with the glycemic 300 and versus Digludac 100, the total markedly lower in the glargine 300 across the category of the hypoglycemia. And this time below range is markedly lower in the glargine 300 across the risk of hypoglycemia. In the same way, if you see the significantly lower risk of nocturnal hypoglycemia within the glargine 300 arm compared to Digludac, where this is the time period midnight to 1 o'clock, and in the initial 4 or 5 graph where the dark bar is the Digludac arm and the hologram is the glargine 300, the maximum risk is observed in the Digludac arm nocturnal hypoglycemia, which is again statistically significant. So one care real world evidences in the type 1 diabetes with the continuous glucose monitoring system also to see the primary endpoint of percentage of time in range, and secondary endpoint is the time above range or the below range to find out. And in this also they found there is a similar time in range profile between the glargine and the Digludac, but the difference favor glargine 300 for time in range and time above range with the glargine 300 arm. And in this real world setting, they conclude the patient with type 1 diabetes, the effectiveness and safety of glargine 300 is similar to Digludac. In those switching from first generation basal insulin, that is the glargine 100, however, more people on glargine 300 remained within target glucose range at night versus Digludac 100. So in range comparison also there where the glargine 300 is compared to Digludac 100 in person with type 1 diabetes using continuous glucose monitoring system. So the key message which comes to us, the glucose variability and time in range is associated with increased risk of severe hypoglycemia, diabetic complication and reduced quality of life. Now recent trial also the conclude trial where the Digludac 200 and glargine 300 has also been studied, and a lot of different trial for the senior population where the senior trial or the extend trial for type 1 diabetes with the glargine 300 are available, which shows the decreased risk of glycemic variability and better use in the elderly population with the lesser risk of nocturnal or overall hypoglycemia. Glycemic variability and TIR is important yet seldom measured. It is recommended go-to for treatment solution which take care of TIR even though not regularly monitored in our day-to-day practice. Second generation basal insulin demonstrated lesser risk of hypoglycemia and improved glycemic variability, time in range than other insulin regime. And among this second generation, glargine 300 has demonstrated lesser risk of hypoglycemia during the titration period, that is the initial 3 months of the titration, and better glycemic variability with time in range profile. So thank you for your kind and patient hearing.
Thank you, Dr. Ritesh, for a very lucid presentation and talking about the newer dimensions of good glycemic control, time in range and glucose variability. But I will tell you these two are newer concepts. Now to bring it into practice will be really difficult in present circumstances. You have to have the facilities of a technology to implement into day-in-day practice. Whatever you told about Glargine 300 or 2GO available by this Advantage and the degludate. You see these studies and results we have to take by a pinch of salt. These are company driven studies. Now to saying that there is various differences in forms of nocturnal hypoglycemia, degludec is inferior in the titration period with the U300. So I think our experts are here, they will also give comment, but I think we have to take into consideration all these points. All said and done, I will ask you a simple question. In many circumstances, talk of variability, talk of time in range not available to a general physician or clinician. If you go by the older 7-point blood glucose monitoring by a simple glucometer, how helpful it will be?
Sir, self-monitoring of blood glucose is again helpful. Where the continuous glucose monitoring system is not available, the self-monitoring of blood glucose is an indirect way to give the idea about the glycemic variability. But again, continuously measuring the 7-time blood glucose level is very difficult for our, where the, as you said, the materials are not available, or where the paramedical staffs are not available, where the knowledge about the 7-point monitoring is not available. If the patient will not able to adjust the insulin dose by himself or herself, it is very difficult to say the risk of hypoglycemia, where to manage with the self-monitoring of blood glucose. If at any point of time the patient will monitor the blood glucose of 70, if he or she will not know how to connect or how to adjust the dose of the insulin, then it is difficult. But definitely yes, after HbA1c, self-monitoring of blood glucose, but where the facilities are available, continuous glucose monitoring are again superior in terms of helping for glycemic variability.
Thank you, sir.
If we are doing continuous, like as I have said, in terms of different studies are there, in terms of HbA1c or the glycemic control, efficacy wise all the basal insulins are same, either it is 300, degludec or 100. But in terms of risk of nocturnal hypoglycemia or overall hypoglycemia, if any of the patient document or come to the clinic and say the hypoglycemia is there, or especially where the high risk population like elderly or in the chronic complications case where we are more fear for the risk of hypoglycemia, I think if the patient is on U100, we can switch over through 300 where the risk of hypoglycemia will decrease, or initiate with the second generation basal insulin, as I have told, where the facilities are not available to monitor the continuous glucose monitoring, but with the data available we can at least give lesser glycemic variability with the newer onset of insulin.
Would you sit somebody on 14 unit of U100 to 14 unit of U300?
Initially I will buy, but gradually titration will required by seeing the glycemic efficacy.
No, no.
Look at the cost effectiveness of both U100 and U300. And if somebody is doing well with the U100, what is the situation we will stick to U300?
So as I told, if the patient is doing well without any risk of hypoglycemia or no documented hypoglycemia, we can continue, because compared to efficacy both are same. If the patient is doing well with the 100 without hypoglycemia or high risk, we can continue. But where we think that the risk of hypoglycemia is more with the U100, we have an option to switch over to the second generation basal insulin to decrease the risk of nocturnal or overall hypoglycemia. So the only benefit is decreased risk of hypoglycemia. If any of the patient with U100 is doing well without hypoglycemia, you can continue.
Okay, Ritesh, the last.
Okay, thanks for your nice talk. We have been discussing about glycemic variability for the last so many years. But so far as hypoglycemia is concerned, I agree with our chairperson. So far as hypoglycemia is concerned, definitely the TIR is very good and we should see it. But the other benefit, the cardiovascular benefit, there are many trials, but till date, the level of evidence is not that robust so far as the cardiovascular benefit is concerned. That's why, okay, it's good for the hypoglycemia part, so it can use as a complement to the HbA1c, but we have to wait and see how the cardiovascular benefit will come out in the near
By control of
yeah,
glycemic
yeah.
variability.
But still date, there is no robust evidence so far as CV benefit is concerned.
Yeah. Thank you, sir.
Can I request Professor Dr. S.R. Patnaik to please give a comment?
CGM is a tool which is for the future. At the present time being, it is not widely available and we are not very conversant with it. So, how to monitor our patients? Is it with only blood sugar? It will not do. We know that. Is it with A1C? You know, A1C is a dressed up test. Dressed up in the sense, it tells us something, but it also hides something. He showed some beautiful slides that even with different time range, that means with blood sugar control over different percentage of time in a day, still then you can have same glycated hemoglobin. So naturally something else is required. Now what is that? For the time being, we need to tell our patients, especially the educated ones who can afford to have a meter and go for frequent blood sugar testing. He says 7 points. It is okay, it's 7 points, may not be 7 points. We know at what time the catch is. Let us say midnight, 2 o'clock. While waking up to go to the toilet, most of our patients, they wake up once or twice in the night to go to the toilet. You take a blood sugar, measure a blood sugar, you find out whether the patient is having hypo or hyper for that matter. So for the time being, I feel repeated blood sugar measurement is really required. We are harping on so much about A1C, but what is our experience in A1C? American Diabetic Association says A1C has to be conducted as per DCCT protocol or National Glycated Hemoglobin Protocol. Is it available? I was asking some of our laboratories. Many laboratories are conducting A1C measurement which costs only 50,000. But in MKC Medical College and also in SCB Medical College, the machine we are using costs around 50 lakhs. So just imagine, is it possible to get good quality A1C reports from the different laboratories? So let us not blindly go with A1C, let us stick to plain simple repeated tests of blood sugar. Thank you all.
Thank you very much, sir. We'll conclude the session here. Thank you very much. Thank you very much, Rita sir.
Thank you, sir. I would request you to please proceed to the presentation area.
Hello.
For the next session,
Hello,
I would
hello,
like to
check,
request
hello,
our
hello.
chairpersons, Professor Dr. L.K. Meher sir, Professor Medicine and Director Vimsar Burla, and Dr. Bharat Panigrai sir, Senior Consultant in Internal Medicine and Rheumatology, Care Hospital, and LV Prasad, Bhubaneswar.
Hello, 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 check, hello.
Good morning, everyone. So at the outset, I must convey hearty thanks to Sambit for giving this opportunity to be here with you in this great conference. Now the topic is a very beautiful one and a very practical one, that is diabetic painful neuropathy. We all know that diabetic painful neuropathy is a very prevalent condition affecting somewhere around 20% of the diabetic population. It is very, very disabling condition, and treatment is also equally challenging. Our aim is to halt the progression of the disease, relieve pain, and manage complications. We have a number of drugs or a class of drugs in our basket to manage this condition, like SNRI, tricyclic antidepressant, the gabapentinoids, the anti-epileptic drug, anti-arrhythmic drugs, also topical agents like capsaicin, lidocaine, isosorbide dinitrate, etc. Apart from this also, we have got some non-pharmacological treatment like TENS, spinal cord stimulations, acupuncture, etc. But still the outcome is not very satisfactory. As you have got a number of drugs, how we choose the drug, what should be the algorithm, and how far we'll get the result. All these things will be, I think, dealt in detail by Dr. Rastogi. So with this small introduction, now may I request our co-chairperson, Dr. Bharat Panigrai, to introduce the guest.
Okay, friends. So I think Dr. Rastogi is well known to the audience also, because he is an eminent endocrinologist of India, and he is associate professor in Department of Endocrinology from PGMR Chandigarh. But I know him better as the Vice President of Food Society of Diabetic Food Society of India, because I am also involved in that. So I know him in that way. So Rastogi, please start your topic.
Yeah, thank you, sir. Thank you. And thanks for the introduction. So let me take you to a very different kind of presentation of a patient of diabetes who enters into your clinic. And you can have a patient who comes to you crying. I don't know how many of you see patients who cry when they enter into your OPDs, but believe me, I see many patients of diabetes, and I have a diabetic foot clinic at PGI, and I have seen patients who come to me crying. And the cause of that cry is severe pain, because he is not able to sleep for past 1 month just because of pain in the foot or pain in the limbs. And this is typical of diabetic neuropathy, and that is painful diabetic neuropathy. So it's not uncommon as we commonly believe. It's quite common, and we should be more passionate and compassionate to our patients. So dwelling on this topic, I come from northern part of India. This is the Dr. Sambit might be remembering, this is the OPD where we have our at least 1,000 patients a day we see. That's a huge number, and that is the typical OPD gate. This is PGI. So I'll discuss the presentations of diabetic neuropathic pain, the pathophysiology of painful diabetic neuropathy, something about evaluation. If a patient presents with painful neuropathy, how can you evaluate? And finally, management, as our chairperson were alluding to. So before that, we should be very clear about the anatomy and the physiology of the nerves. And what is more important is that we should know that the lower limb is blessed with so many nerves, but sometimes either they get misfiring that leads to pain, or there is complete insensate foot, and both of them are wrong for our patients. This is because of this limb is loaded with large myelinated nerve fibers as well as unmyelinated nerve fibers. So you can have the A alpha fibers and A beta fibers, which are large myelinated fibers, and you can have a thinly myelinated fibers which are A delta. And what is more important to the topic that I am alluding to is the unmyelinated fibers, which are also known as the C fibers. So this is the diagram that characteristically mentions this, and this autonomic sensations and autonomic neurological functions are predominantly carried by the C fibers and the A delta fibers. And the large myelinated fibers, we know that they carry the sensation of touch, the vibration, and the perception of position. And it is the smaller myelinated fibers that carry the sensation of temperature and the pain. So this is the most important fibers that we will be studying. Remember, in a lifetime of a diabetic patient, he will have diabetic neuropathy, almost 50% of patient would have. And remember that if he had diabetic peripheral neuropathy, half of them would also have pain. So sometimes patient might not complain if he does not have severe pain, but what is more important, we have to ask the patient, are you having good quality of sleep at night? So that is most important, because he might be having pain in the foot. He might attribute it to just because I had a long day today, therefore I am having pain. But it can be because of diabetic neuropathy also. And it is the most common reason for seeking medical aid, and this is also one of the reasons that we diagnose patient with diabetes on the very first day because of diabetic neuropathic pain. So this is the classical definition of pain, which is being given by the society. They say that pain which is arising as a direct consequence of abnormalities in the somatosensory system in a given patient with diabetes is called pain-filled diabetic neuropathy. And remember, unfortunate to say, but yes, I have seen a patient who committed suicide because of severe neuropathic pain, and it was intractable and it was not responding to treatment. So this is the story of the pain. Just to understand what kind of pain you can have, this is the stimulus intensity on the x-axis, on the y-axis we have magnitude of pain. So this is a normal person. So as the intensity of the stimulus increase, you will have more of pain. Now what happens is, green line, what do you think that this is? This is hyperalgesia. That means even a small intensity of stimulus leads to significant amount of pain. This is hyperalgesia. And this is hypoesthesia. That means you give lot of stimulus, but still the patient does not feel anything. This is hypoesthesia. And on the other thing is red line. Now what is this red line? I am not even giving any kind of stimulus. Like the patient is just wearing his pant and he feels severe pain. So this is allodynia. So this is the presentation of diabetic neuropathic pain. So remember these terms, these are very interesting, and we should know how to treat these kind of things. Coming on to mechanistic insights, this is a typical peripheral pathway of the nociceptive drive, which is by A delta and C fibers, which goes to the DRG, that is dorsal root ganglion, and then on to the higher centers. Remember, this is all because of misfiring of all these, the channels, whether it may be sodium channel, the potassium channel, the chloride channel, which leads to misfiring and lot of pain that the patient has. I'll also tell you a few things that you might have also come across in your practice. A patient comes to you with A1C of 12%. Definitely you will start insulin on the very first day, and just after 8 weeks or 1 or 2 months, the patient comes back to you and he says, doctor, you have made my life hell. Now I am having severe pain in my limb just because of insulin. So this is called insulin neuritis. This is quite common, and this is acute painful neuropathy after starting insulin, also known as diabetic neuropathic cachexia, and it presents with severe pain in the limb, and it also associated with autonomic symptoms, and it is also characterized by allodynia, and it is defined as sudden onset of severe pain in the limb, which is more at night, and this is we usually use in a clinic Likert scale. This is an objective scale to understand the pain what the patient is having. And it says that if you reduce A1C by more than 2 points within 8 weeks, this is more likely to have acute neuropathic pain. So this is more common in type 1 diabetes patients, who is more common in the female, more common in the young age. And what they say that this is because of vascular steal or regeneration of the damaged axons. But remember, it usually is self-limiting. It goes off by around 5 to 6 months. So in this next 6 months, you have to treat your patient who come with severe neuropathic pain. Another cause of pain in the limb would be entrapment neuropathy. Like we see carpal tunnel syndrome in the hand. Same way I see patients who come with severe pain in the foot. Now you will say this is because of claudication. This is because of peripheral vascular disease, but it might not be. This might be because of the entrapment of the tarsal tunnel These are posterior tibial nerve in the tarsal tunnel. So this is called tarsal tunnel syndromes. So this is called entrapment neuropathy. So remember these small things in some diagnosis that can help you in deciphering the proper treatment. And if you misdiagnose, probably you might lose the patient as well. So for a treatment of successful neuropathy, what they say, it's very difficult to have 100% relief in the pain. So what is more important is at least a 50% relief in the pain is said to be a successful treatment. And this has been defined by American Association of Neurology, that just if you can objectively measure the pain by Likert scale or the VAS scale, and if you can have a 50% relief, that means patient, you have done a successful treatment for the patient. Moreover, patient should be able to sleep at night, should have a good quality of sleep. And what they say that almost 50% of your patients, whatever you add, might not have any relief. So you have to juggle the medicines, as our chairperson were also mentioning too. So this is a simple diagram that mentions that what you can do when a patient comes to you with a neuropathic pain. So first you have to definitely diagnose the patient that this pain is because of diabetic neuropathy. It's not because of insulinuritis, it's not because of tarsal tunnel syndrome. And once you have confirmed that it is because of the diabetic peripheral neuropathy, so what the guidelines say that you can choose any of these, like for ADA, ESD guidelines for diabetes, you can choose any of the add-on after metformin. Same is the voltage-gated alpha-2 delta ligand, which is calcium channels. So that is pregabalin, that is most commonly used. Gabapentin is not so commonly used, it is more favorite of neurologists, but not of endocrinologists. You can also use SNRIs like duloxetine or venlafaxine, and sometimes the TCAs. Now TCA has gone into disrepute, maybe because of a lot of the side effects and contraindications, and in my clinic I see many patients have autonomic neuropathy, bladder dysfunction, which can lead to lower urinary tract symptoms and all if you use a TCA. So you can choose any of these. Be honest with the dose of the medicine. So you have to start with a proper dose before saying that it's not working. I'll tell you the dose in the near future. So clinically relevant response is said if you can have at least a 30 to 50% response, yes, the drug is working. So stick with the drug, increase the dose of the drug and call back the patient. Robust response, anybody who has more than 50% response is a very robust response. And lack of efficacy is said that if a patient is having no response, still is having severe pain over a period of maybe 4 to 8 weeks, you might have to switch the drug to some other agent. So this is the guidelines by ACE, that is American Association of Clinical Neurology, the NICE guidelines and AAN. And what you can take from these guidelines is almost all the guidelines say that pregabalin is the drug of choice. This is just because of its efficacy, which has been well proven in the randomized trials. It's all because of its side effect profile as compared to maybe other drugs. So pregabalin you can use, and then if the patient is not responding to pregabalin, you might have to shift to maybe SNRI like duloxetine in good doses, or you might have to shift to maybe opioid analgesics also. So in my clinic, I would be very honest in saying that around 15 to 20% of patients are also on opioid analgesics. I know that they are habit forming drug, but sometimes they need to be used in our patients. So this is the standard dose, because I see many prescriptions of pregabalin used in a dose of 75 milligram, but still the patient is not having any relief. That means something is wrong. You need to hike the dose. In whatever trials that have been done till date, the median dose was 200 milligram. So they usually use a higher dose of 225 or 300, but I understand our patients might not tolerate the higher doses of pregabalin, but most of our patients who are having a severe neuropathic pain, they usually are on a dose of 150 milligram. So up titrate the dose, or better would be rather than treat to fail, so treat to target would be a better choice. If the patient, you can make the patient understand, start with the higher dose, make him understand the side effect of the drug, and then see the effect. And if it's not responding, you might choose some other drug. The dose of duloxetine, we usually start with a dose of 15 milligram, but the guidelines say that start with 30 milligram, but there are many patients who might respond to even 30. So we have to give a dose of 60 milligram also. So these are the standard dosing of these drugs. And few people say that why not to combine both of these drugs? Give pregabalin and duloxetine together. That would be a good idea if the patient is not having relief with a single drug. So that is also can be done. But this was trial that we did in PGI, and that was published in Diabetes Medicine. We compared the TCA with the pregabalin, And we found out that pregabalin 150 milligram, which was given in higher doses, is having almost the same effect but lesser side effects as compared to amitriptyline. So this can be one of the strategies that you can use. Another question is that what are the contraindications and in which class of patient we will prefer which drug, as sir was also mentioning. So this slide mentions that if your patient is depressed, try to use a TCA. If the patient is obese, definitely a drug which cause weight gain like TCA and pregabalin are known to cause weight gain. So I will choose a duloxetine rather than a pregabalin. If his patient is having some kind of very high blood glucose, I will choose a drug which do not cause in hyperglycemia. So I will choose pregabalin again and not a TCA. If the patient is having a hepatic failure, I will again choose pregabalin and not duloxetine or TCA. And renal failure, you can use pregabalin, that is found to be useful rather than giving maybe a duloxetine. In elderly patients, TCA is a no-no because there are a lot of contraindications regarding the TCA. So I would prefer a pregabalin, and I will explain him that there is increased chance of somnolence with pregabalin, but that needs to be advised to our patients. So we need to understand the characteristics of the patients also before deciding on a drug for diabetic neuropathic pain. This, also be aware about the side effects. Somnolence is the side effect of almost all the drugs that we use. But there are more significant side effects like constipation, dry mouth. All these side effects, these effects are already present in our patient. You might see many patients with diabetes who have constipation. So don't use TCAs in these patients. Don't use TCA in patients who is having dry mouth or urinary retention or BPH because that might worsen it. So try to choose a pregabalin in these patients. So this was the trial that studied the combination of these two drugs. So this was a 8-week combination versus high dose monotherapy treatment. They used duloxetine in a dose of 120 milligram, and in the other arm they used duloxetine plus pregabalin, and in the third arm they used pregabalin. They found out that combination therapy is not superior to a high dose monotherapy. So in my clinics we are not using combination as such, and we have found that usually the side effects are much more and the efficacy is not much. So it's better to switch rather than to add. This will add to the pill burden. So that is a dictum in treatment of painful diabetic neuropathy. And overall it has been seen that duloxetine has better efficacy than pregabalin in this study when it was used in high doses. Coming on to the newer agents, as you were mentioning, it is strange that neither the Indian government nor the US FDA has approved any drug for the treatment of diabetic neuropathic pain over the past 2 decades. The last drug that was approved for diabetic neuropathic pain was tapentadol, that was in 2012. And I don't know how many of you use tapentadol for patients of diabetic neuropathic pain. I use tramadol but not tapentadol. So that's the thing, and this was a paper that we wrote about all novel treatment modalities for painful diabetic neuropathy. It was published in DMCRR, and we just collated all the data, what is happening with tramadol. So yes, tramadol we are using in our patients, and it is a centrally acting synthetic opioids. I usually use in a dose of 100 milligram to start with, and then up titrate to 200 milligram. And there are significant symptomatic relief that is seen in our patients, but that is for a very short time. Usually we don't extend the use of this tramadol for more than 3 to 6 months, because again it is a habit forming drug. So we have to be very cautious about this. And tapentadol, as I was mentioning, it is FDA approved in 2012. But still in India it's not so frequently used. Those people say that if you want to use a drug for pain for more than 6 months, tapentadol would be a better option rather than tramadol. So this is by many of the studies. This was one of the studies published by Dr. Aaron Wennick in Diabetes Care, and he showed that the pain intensity is significantly reduced if we are using tapentadol maybe as compared to a placebo. Coming on to some newer agents like the SNRIs like venlafaxine. So I haven't used venlafaxine any time, but my psychiatry colleagues are very fond of this drug. But it has been shown to cause significant improvement in the neuropathic pain, but still it's not FDA approved, and also it's not approved by the Indian guidelines. Coming on to the last part of my presentation is about some topical therapies. Yes, we are using topical therapies in our patients who have severe burning pain in the foot. I have been using capsaicin creams. They have been found to be useful in our patients. And the lidocaine cream, though not frequently available, but they have also been shown to be useful in the clinical trials. As the chairperson was also mentioning about some non-pharmacological therapy, so we have experience with the non-pharmacological therapies also. And this is the trial that we published in Neurology India. This is about the anodyne therapy. I don't know how many of you know anodyne therapy, but this is an infrared therapy that we use in our patients who are having severe intractable pain, and we followed these patients. In one arm we gave the anodyne therapy. So this is a therapy which is a non-invasive, a kind of pads which are applied on the foot where there is having severe pain, and on the other arm we just applied the sham treatment, and we followed these patients and we found that there was significant improvement in the pain. So the VAS score was significantly reduced by the anodyne therapy, and the Norfolk quality of life was also improved. We also did the biopsy, skin biopsies from these patients, because we wanted to understand the nerve fiber densities, whether they are also improved by giving this anodyne therapy. So it didn't improve. The last slide is about vitamin D, because there are some papers who have highlighted if a patient is vitamin D deficient, he is more likely to have diabetic neuropathic pain. But are there any studies which have supplemented vitamin D and seen whether there is any improvement in pain? So unfortunately the answer is no. So supplementation does not lead to the improvement in pain. So does that mean that all patients who are having neuropathic pain should be given vitamin D? Answer is no. You can give vitamin D if the patient is vitamin D deficient, but not for this clinical indication. So I'll conclude by saying that be passionate with your patient and have a compassion when he comes with severe neuropathic pain. I understand it's very difficult to treat disease. We should know what is the etiology of this pain, and also remember it can be a tarsal tunnel syndrome also. So you need to diagnose this etiology. Make realistic targets. If you can have just 50% relief in the pain, that's good enough. The patient will be happy, you will also be happy. And the choice of the drug depends upon the patient characteristics. That's more important, what kind of comorbidities he is having, and the treatment should be very individualized and tailored. And remember, the best treatment, whatever you give, is only slightly better than the best, and you have to play in this window of slightly better. Thank you.
Thank you, Dr. Rastogi. So actually, I was about to ask you, but you showed the slide that about how this diabetic neuropathy is being neglected in comparison to nephropathy and retinopathy, because no treatment is available for the last so many years. Not only treatment, but also in the preventive side also. You see, retinopathy, we do screen yearly, and for nephropathy, we also do screen with SCR, but we also don't have definite screening procedure. Whatever the screening procedure, that is the clinical procedures are there, but again, you will find it very late stage. We are not able to diagnose early, even if with the clinical procedures, whatever they are. So why not? You have shown the skin biopsy. That is again an invasive procedure. So I will ask you, why not the corneal confocal microscopy is used for the screening of diabetic neuropathy, which you can screen in the subclinical stage?
Exactly. So Dr. Sujay probably is not here. So he was the one who did original work on confocal microscopy, and we are using confocal microscopy in our clinics. So it's a very simple instrument. Only the software is costly. Like you will be sending your patients for diabetes for diabetic retinopathy evaluation. So there is a very simple instrument. The patient has just to see in that instrument, and it will map all the corneal nerves. Because remember, cornea is an avascular organ. It is not supplied by any vessel, but it is richly supplied by nerves. And these nerves are unmyelinated, very thin nerve fibers. So it is believed in diabetes that unmyelinated fibers are affected first. So this was initially championed by Dr. Andrew Bolton, and Dr. Sujay was also there. So probably we are using corneal confocal microscopy. Maybe you can ask your ophthalmology colleague to provide you with a corneal confocal microscope and diagnose neuropathy early. Why not? It's available. It's just we have to take a stand.
Thank you.
Sir, I have a catch. Exactly. Sir, I have a catch. Like you are giving all the doses, half doses of 3 medicines. So I don't believe in it. I believe first you have to give an uptitrated dose of a single drug to the maximum and then you shift on to the other drug. See the effect and the side effect. So I'll give a 150 to 225 milligram pregabalin before jumping on to duloxetine. And I was mentioning in one of the trial, the combination therapy is not so effective as compared to a single drug given in high doses. So I don't use and we don't use combination therapy or cocktail therapy.
Dr. Rastogi, just I want to know, actually what is the usual dose of pre-gab you use? Because many times in my experience it is very difficult to go beyond 150. Beyond. Very few only they do tolerate a little bit more, and if the patient is elderly then again a problem. Most of these problems have the as such problem of fall and all that, and so it's really difficult.
So there are two things. One is the age and other is the symptoms. So those who have Likert scale more than 8, we usually use a higher doses. High dose means 150 or more than that. But you are absolutely right, most of our patients, 90% of our patients are on a dose of 150 or less. So 50% are on 75, they have a good pain relief, and rest 30% are on 150 and hardly 10% are beyond that. So you are absolutely correct. But sometimes when the patient first time presents with you with severe pain with Likert scale more than 8, try to use a higher dose, because then he will shift, this doctor is not working, so I will shift to another doctor. So better to give a higher dose.
In your experience, which is the best?
Pregabalin.
Not duloxetine?
Pregabalin, sir. My experience is more with pregabalin.
So any other question?
Sir.
From your experience that a patient will commit suicide, the case you are telling, could it be because of the medication being used for the neuropathy treatment?
Exactly. So you're absolutely right. Suicidal ideations are also one of the side effects of these drugs. But what was the last word, what I remember, because this was in my SR-ship, during my SR-ship was there. He had severe pain, and when we talked to the attendants, he had not slept for a month. So that may be one of the reasons. Please.
So as you mentioned, entire topic, what I understand that very, very difficult to treat this neuropathy. Mostly, even if this, unless we control the mind for pain relief, at least if you control the mind, at least 50% pain will be controlled. Do you agree to this?
I agree.
You agree to
I
this?
absolutely
so
agree.
What are you going
yoga
to do?
therapy.
So what, not yoga. So
Many
what
things.
we are going, so we must highlight this point that if you control the mind, you will control the pain at least by 50 or more than 50%. And with this, all these drugs which having lot of side effects, very, very difficult to treat this neuropathy pain. Very, very difficult.
True.
What is your idea actually?
I absolutely agree with you, sir. No second thoughts.
So
everything is in the mind. Everything is in the mind.
So just to conclude, Dr. Rastogi has passed a very clear message that will be effective only in 50% of the patient in controlling pain with adequate therapy. And while designing the drug, we must take into consideration the comorbidities of the patient, and accordingly we have to give. If not controlled with one drug, better to switch on to the other drug than to use the combination of therapy. And there are lack of actually sufficient trial which drug to use and which combination is the best. And this is our, I think we need more research in this aspect. With this, we conclude the session. Thank you very much.
Thank you, sir. Thank you, sir. Now it's time for the Dr. R.J. Das Memorial Lecture. I'd request our Now it's time for the Dr. R.J. Das Memorial Lecture. I request our organizing secretary, Professor Dr. Sambit Das.
Indian College of Physicians. Being the founder member of Endocrine Society of India, he served the organization in various capacities for nearly 2 decades. Professor Das achieved what he was destined to, becoming the youngest head of department and the first dean research and chairman of institute's academic committee amongst the few serving professors. He is survived by his wife, Professor Dr. Sumitra Mishra, and we are fortunate that Madam is there amongst us. So I'll request Professor Sumitra Das ma'am to kindly come over the dais. Yes. though he left us, but his legacy will continue and it will continue. So Professor Vansali has already joined. So I'll request Chairperson sir to introduce. Unfortunately,
learned from the junior faculties. So he was the person who was all along behind us, teaching us, and whatever we have learned, it is because of Professor Anil Bansal. He is not only a good teacher, he's a perfect human being, and is the recipient of many awards, notably Professor B.C. Roy Award. So he is here to deliver the first Professor Adidas Memorial Lecture on Adrenal Insufficiency. So over to Professor Anil Bansal.
Organizing committee for inviting me to deliver this talk. I feel honored and privileged to deliver the Professor R.J. Memorialization 2022.
At the outset,
and I will be talking about
insufficiency
the
may
adrenal
appear to be a very rare
insufficiency
disease,
clinical pulse.
but it is not rare, especially the modern use of rampant use of glucocorticoids. We are seeing these patients so often, and this is
so I am presenting two interesting cases, and then followed later.
Dr. Bansali will be discussing about this topic. Dr. Bansali, please, sir. Sir, can you hear me? You have to unmute, sir.
A 31-year-old male who presented
Sir, you have to
with vomiting for 3 months, which was not preceded by nausea, pain, abdomen, and salt craving. Weight loss around 3 kg. He had a history of tanning after sun exposure. He had no history of any disease, spells, or symptom, and no family history of any autoimmune diseases. And recently presented in emergency with altered sensory. On examination, he had a blood pressure of 100/70. He had a tanning over face and mild gingival pigmentation. He did not have a goiter, vitiligo, or mucocutaneous candidiasis. His pubertal stage. For inviting me to deliver this talk. I feel honored and privileged to deliver the Professor R.J. Memorialization 2022. And I will be talking about the adrenal insufficiency clinical pulse. I think, yeah. So I will be presenting two interesting cases, and then followed later, we will have a discussion. A 31-year-old male who presented with recurrent vomiting for 3 months, which was not preceded by nausea, pain, abdomen, and salt craving. Weight loss around 3 kg. He had a history of tanning after sun exposure. He had no history of any disease, spells, or symptom, and no family history of any autoimmune diseases. And recently presented in emergency with altered sensory. On examination, he had a blood pressure of 100/70. He had a tanning over face and mild gingival pigmentation. He did not have a goiter, vitiligo, or mucocutaneous candidiasis. His pubertal staging was normal. On biochemistry, he had anemia, microcytic hypochromic anemia. He had no sodium, 120 or 122 milliequivalent per liter. Potassium was towards higher side. He had a albumin adjusted calcium, which was normal. His blood glucose was also normal. Serum cortisol was 25 nanomole per liter, which is low. In a stressful state, it should cross around 700 nanomole per liter. His ACTH was 2000 picogram per ml, which was sky high. He had a low DHES. His thyroid function showed the TSH of 13.8 with a normal T4, suggestive of a subclinical hypothyroidism. He had a TPO positivity. MRI brain was normal. CT adrenal shows unilateral adrenomegally with calcification, and HRCT thorax was normal. FNSE from the adrenal gland showed kidney granuloma consistent with tuberculosis. So this was the CT scan. You can find the right adrenal seems to be slightly enlarged, but otherwise looks maintaining a normal shape. While there is on the left side, there is a mass and there is a calcification. Diagnosis was primary adrenal insufficiency, tubercular adrenalitis, Hashimoto's thyroiditis, subclinical hypothyroidism. His treatment, he was started with hydrocortisone 10-5-5 3 times a day, along with fluorocortisone, and levothyroxine was added 75 microgram, and he was started on anti-tubercular therapy. I'll present a second case, which is also interesting and show the vividity in adrenal insufficiency. He is a 35-year-old male who presented in emergency with altered sensorium. There was no history of seizures, headache, and visual impairment. He had a history of head injury 3 months prior with normal CT brain. On examination, his GCS was E3, B4, M4. His blood pressure was low. He had no signs of dehydration. Fundus was normal. No neurological deficit. No cutaneous or mucosal pigmentation. On investigations, his sodium was 121, so he had a hyponatremia. His potassium is 3.8. Osmolality serum was 260. Urine was 300. Urine spot sodium, which is normal, is more than 20. He had a more than 30. His random blood glucose was 100. Serum cortisol was 90. So it was a less than 100, which is usually a threshold taken to say adrenal insufficiency. His ACTH was low. DHES was also low. T4 and TSH were normal. Testosterone was low. And he had a post-ACTH stimulation was 520 nanomole per liter. Despite being a normal stimulation after senectine, the patient has to be replaced because adrenal gland has not yet become atrophic. It's a very short duration has elapsed between ACTH deficiency and the clinical presentation. MRI SELA was normal. He was diagnosed with traumatic brain injury, panhypopit. He was treated with 3% saline with the aim to raise serum sodium by 8 to 10 milliequivalent per liter in 24 hours. He was started with hydrocortisone 100 milligram bolus followed by 50 milligram 6 hourly. LT4 was also started. He was watched for serum sodium, serum urine and osmolality and urine output. After these measurements, his serum sodium was normalized and the sensorium was restored back, but he had an emergence of polyuria and he had a rising sodium, which suggests there is an unmasking of central diabetes insipidus, which is not uncommon finding following TBI. So he had initially hyponatremia, but after putting on hydrocortisone and thyroxine, the serum sodium started rising. So that was a unmasking of central diabetes insipidus. That is not an uncommon finding after TBI. So adrenal insufficiency is an uncommon disorder. The primary adrenal insufficiency is much less common than secondary. The most common cause of secondary adrenal insufficiency is exogenous administration of glucocorticoids, and never forget opioids. Opioids also inhibit the hypothalamo-pituitary adrenal axis, particularly CRH, ACTH, and that also leads to the similar manifestation of adrenal insufficiency. Another important clinical point is that the hypocortisolemia is not synonymous with adrenal insufficiency, as patients on glucocorticoid use or quote-unquote abuse have hypocortisolemia, but they do not have a features of adrenal insufficiency. That's why someone is hypocortisolemic. We may not be adrenal insufficiency because the glucocorticoid use will prevent the sign of clinical adrenal insufficiency. Previously, people have used the term adrenal fatigue. It does not exist. And adrenal supplements to abrogate should be discouraged. And it's a life-threatening problem, and it has to be evaluated and managed by an endocrinologist. This is the prevalence of signs and symptoms in primary adrenal insufficiency, a data of 148 patients by Ross et al., and showed increase in pigmentation and abdominal and GI manifestations. They usually predominate, so nausea, vomiting, and weight loss and abdominal pain. The other symptoms like shock, anorexia, arrhythmias, diarrhea, they are lower. The monosymptomatic presentations are very important because you should have a very low threshold to make a diagnosis. These patients roam around the different departments in an institute. Like in PGI, we have so many patients going to different departments, something to GI, gastroenterologists, and sometimes to cardiologists, and sometimes to neurologists. So anorexia, nausea, and vomiting, this will be the only manifestation. Weight loss, syncope or disease spells, they may go to neurologist or ENT specialist. They may come with a medicine, internist, fever of unknown origin. One of the important causes of PO is, in endocrine causes, the PO, one of the important causes, adrenal insufficiency. Hyponatremia, they may bring an emergency. Unusual tanning on sun exposure, unexplained anemia, arrhythmia, and hyperglycemia. The clinical clues one should look for: the skin and mucosal pigmentation, the mucocutaneous candidiasis, hypotension and postural fall, pallor, goiter, latent signs of tetany because of hypoglycemia, vitiligo, other signs of AIDS, that is autoimmune polyclinic endocrine syndrome. There may be a loss of axillary and pubic hair in women, and you may have a orchidomegaly sometimes. That is because of the proliferation of ACTH-driven adrenal rest tumor in testes. The etiology of the primary adrenal insufficiency, acquired and congenital. Acquired is usually autoimmune or infection, sometimes infiltration, drugs like anticoagulants, ketoconazole and mitotane, and others like acute infection and APLA. In congenital, you have a CH, AAA, adrenal hyperplasia congenita, familial glucocorticoid deficiency, and adrenal leukodystrophy. So this is one of the patients who came with a vanishing adrenal mass. So he came with an adrenal mass and he had a features of adrenal insufficiency. Other adrenal was apparently looking normal, slightly bulky, but it was also diseased. And after the diagnosis which was made was a lymphoma of the adrenal gland. So this was a primary adrenal lymphoma, and this is again corroborated by the FNSC findings from this. And this, after the CHOP therapy, the mass completely, almost completely reversed. However, the adrenal function did not return to normal. This is the another congenital cause of adrenal insufficiency that we reported last year. That was a AAA syndrome, that is called as the Algo syndrome due to ACE gene mutation, with a rare association of amyotrophy, and this patient also had achalasia, alacrimia, and adrenal insufficiency. You can appreciate mucosal hyperpigmentation here as well. Then secondary adrenal insufficiency may be because of exogenous steroid use, cellular supracellular tumors, post-RT or TSS, lymphocytic hypophysitis, trauma, inflammatory disorders, drugs, and infections. And remember, the COVID-19 is also one of the important causes of secondary adrenal insufficiency, which we published last year. That the patients with the COVID-19, particularly those who required a ventilatory support, they had a more predisposition for a COVID-19 hypophysitis. Then this was one of the MRI cella, which is showing a completely empty cella with a central stalking position. So that was a feature after traumatic brain injury in this patient. Biochemical abnormalities, remember, hyponatremia is also not uncommon in secondary adrenal insufficiency. The classical teaching is that the adrenal insufficiency, only primary they do have a hyponatremia, while secondary they do not have. But in fact, it is not true. Even 1/3 of the patients may have a hyponatremia, and that is because of the decreased ADH catabolism or increased ADH secretion. Because of cortisol deficiency is associated with the increased ADH secretion and increased ADH action. That's why the hyponatremia is not uncommon even in secondary adrenal insufficiency. While in primary adrenal insufficiency, hyponatremia is because of aldosterone deficiency. So you can have a hyperkalemia, hypoglycemia because of cortisol deficiency, increase in PRA, hypoaldosteronism, and hypothyroidism. So these are some biochemical abnormalities which you encounter even in this. And why you are having a hypoaldosteronism in secondary, a long-standing ACTH deficiency can lead to ineffective priming of the zona glomerulosa. So that, because even the zona glomerulosa, it may be RAS dependent, but still it requires continuous ACTH priming for its growth and its maintenance and development. So that's why that is lacking. So that's why the hyponatremia is mainly because of ADH excess, but in the long run, you can have an adrenal insufficiency or hyponatremia partly because of the hypoaldosteronism. Then, is there any utility of estimation of free cortisol in adrenal insufficiency? Yes. Only patients on OC or sometimes if someone is on pregnant, then you may require and you have suspicion of this. Otherwise, usually you do not require the assessment of the free cortisol in adrenal insufficiency. Diagnosis is can be included by the anemia, lymphocytosis, and eosinophilia. Hyponatremia present in both. Hyperkalemia suggests fine. That's very important. Hypercalcemia is related to decrease in intravascular volume, but if you find hypocalcemia, then it is more likely to suggest a concurrent celiac disease or autoimmune polyclonal endocrinopathy syndrome. A paired morning cortisol, ACTH, and DHEA sample should be taken. 800-hour cortisol should be less than 100. Adrenal insufficiency more than 500 excludes. Between 100 to 500 needs additional testing. The cortisol assay, LCMS, if you use, it's a lower threshold for cortisol. So cutoff usually taken is a 500 or 550. Here it is around 400. 800 plasma ACTH of 100 picogram per ml is suffice. It has got a specificity of around 95%. The DHES should be less than 85, age adjusted, and decline in DHES is earlier than fall in cortisol. So you can use even a DHES as a clue to predict the future occurrence of adrenal insufficiency. The PSC-PR is useful in assessment of zona glomerular dysfunction in primary adrenal insufficiency. Other dynamic testing, insulin-induced hypoglycemia, that is the test. However, it is fraught with risk, and many endocrinologists even are scared not to do that. So people are usually doing a short synaptic test, whether 1 versus 250, both have got a similar outcome, and sampling time 30 and 60, again no difference in outcome. With a 1 microgram dose, you achieve a plasma ACTH of 1000. With a 250, it is around 100,000. But remember, plasma ACTH, whenever it is more than 100, and even you give a stimulus, the cortisol dose response curve is flat. So you already reached a plateau when the ACTH is more than 100. So in fact, when you find a more than 100, in fact, there is no need to do even a dynamic test. A peak response of 500 nanomole per liter is optimal, and 400 nanomole per with LCMS, and you may require a false positive co-centropin test if the patient has got a involvement of a pituitary insult within 3 months. Metabolic is not recommended. The treatment strategies, the dose are determined by the basal cortisol production rate and rate of an individual. Patients with PI, they require higher doses of glucocorticoids than secondary adrenal insufficiency. The dose pattern should follow the circadian rhythm. So higher dose in the morning and smaller dose in the evening. Mineralocorticoid replacement is not required in secondary, as zona is primed by RAS rather than ACTH, and adrenal androgen replacement is only required in women for maintenance of libido and ambisexual hair. The preparations, hydrocortisone and prednisolone, the doses are mentioned here, 10 to 20 milligram daily to be administered thrice a day. Prednisolone can be used as a single daily dose, 3 to 5 milligram. Prolonged T-half, that gives an advantage, and dose omission may not be alarming. And other replacements, mineralocorticoids, fluorocortisone dose is 50 to 150. Children are more resistant to aldosterone than adults. That's why they require higher doses. You have to carefully monitor for weight, edema, blood pressure, and post fall, and monitor potassium and PI. DHES is to be given in women 25 to 50 milligram daily. Oral GCs usually result in suboptimal quality of life, higher weight gain, metabolic abnormalities, and increased risk of infection. And whenever the dose of hydrocortisone exceeds more than 20 milligram, the probability of developing a metabolic syndrome is very high. The strategies to combat these adverse events, people have used protocol and plan. However, these are modified release hydrocortisone, but has not been they are not available as well. People have even used the continuous hydrocortisone administration for the same insulin metronic pump. There are some data, but again, it is more experimental and more just as a for research purposes rather than for routine use. Monitoring clinical by general well-being, quality of life, weight, blood pressure, stigma of protein metabolism. Biochemistry by sodium, potassium, glucose, serum cortisol, ACTH, DHES of not much utility, hydrocortisone day curve in challenging cases should be made. Special circumstances in the shift workers, the larger dose of GC is an awakening. The second dose should be given 6 to 8 hours later. In a pregnancy, there is a higher cortisol. You have to require a 20 to 30% increase in second and third trimester. And there is an increase in mineralocorticoids in third trimester, as progesterone is anti-mineralocorticoid. So this is the sick day guidelines you have to use in certain situations. So best is you shift to injectables whenever there is a moderate to severe illness. So to conclude, adrenal insufficiency is an uncommon disorder and requires a low threshold of suspicion for diagnosis. The secondary adrenal insufficiency is more common than primary. Hyponatremia is a feature of both secondary as well as primary. In a primarily is because of the aldosterone deficiency, while in secondary it is because of decreased ADH catabolism. All patients with hyponatremia require exclusion of EI. The short circuit test is a useful test and convenient to confirm adrenal insufficiency. Optimal supplementation with glucocorticoids, mineralocorticoids, and rigorous insistence on sick day guidelines is warranted. Thank you for the patient's hearing. And I'm again thankful to the organizers for giving this opportunity. And it also reminds me Mrs. Dash will be there. And it's happy to remember Professor Dash almost, I think, after a year. And I think this memorial oration will be now the legacy to remember the Professor Dash. Thank you.
Thank you.
Thank you so much. Go back and
And over there, hand over Professor.
Hello. Thank you.
Madam.
Thank you, sir.
Thank you, Dr. Sambit. I'm really privileged to chair this session, and I think I am the odd man out because most of the delegates are physicians, and being a gynecologist and surgeon, I will the single person over here. Anyway, today's topic, all we know it is about the polycystic ovarian syndrome (PCOS), and which is a quite common topic, and we are being gynecologists were coming across daily, and PCOS one of the leading cause of irregular cycles for teenagers, and the most common cause of infertility in married women. So today we'll be dealing with this PCOS and its management mostly. So about Dr. Sanjay Saran is the assistant professor in the Department of Endocrinology, SMS Jaipur. So, and along with his academic, he is also the Secretary of Endocrine Society of India of Rajasthan state. So he has, to his credit, he has more than 40 publications and 3 chapters in the international books also. So I welcome Dr. Sanjay Saran to deliver her topic.
First of all, I congratulate to organizer Dr. Sambit for this beautiful conference, beautiful meeting, and also I thanks to organizers for inviting me on this academic platform.
So now topic for today, it is therapy for PCOS, which one works? So right now we don't have any particular therapy for the PCOS, that particular drug for the PCOS. We usually treat the symptoms of the patient. So now the PCOS is considered as a heterogeneous disorder with multifactorial origin. These are genetic plus environmental factors which causes the disease. The most common form of chronic anovulation which is found. Other causes of chronic anovulation like non-classic CH, androgen secreting tumor, hyperprolactinemia, Cushing syndrome, glucocorticoid resistance syndrome, that should be ruled out before diagnosing PCOS. Now this is the assumed pathophysiology of PCOS, genetics and lifestyle or environmental factor that leads to hormonal changes. One of hormonal change is the increased androgen secretion. So that is the common pathophysiology behind this PCOS. And again, the insulin resistance is there that causes increased stromal content of ovaries, that again causes increased androgen biosynthesis and secretion in this PCOS. That leads to various symptoms of PCOS like hirsutism, acne, menstrual irregularity, and of course cardiovascular and metabolic disorders are also there. So this is the evaluation before we reaching the diagnosis to the PCOS. I'm not going in detail. Now these are various criteria. NIH criteria they have given in 1990, very old, hyperandrogenism or hyperandrogenemia plus chronic anovulation. Then the Rotterdam criteria came in 2003, two of the following like hyperandrogenism or hyperandrogenia plus chronic anovulation or polycystic ovaries on ultrasound. Then Androgen Access Society criteria came, they are saying again the same thing, they mix up the both of the two like hyperandrogenism or hyperandrogenemia, infrequent or irregular ovulation or regular ovulation and polycystic ovaries. Now come to the treatment of PCOS. As we know, there is no universal treatment for PCOS. Treatment must be individualized and it is symptom based treatment. Currently, there is no approved drug for the PCOS treatment. We have the various targets, various pharmacological agents which are having various targets on the pathophysiology of the PCOS. Now first come to targeting the insulin resistance and obesity in the PCOS. As we know in PCOS, the pathophysiology is moving around the insulin resistance and the obesity. So first is lifestyle management. Lifestyle management is the first line treatment in PCOS. As we know, weight gain increases the PCOS incidence of the PCOS, and again it adversely affects the health of in the patient of the PCOS, causes the metabolic and cardiovascular disorders. In the woman with PCOS, lifestyle intervention in the form of dietary intake or exercise, they improve the weight, metabolic, reproductive, fertility and quality of life and emotional well-being outcome in PCOS. Lifestyle management for weight loss, prevention of weight gain or general health benefits, they should be recommended to all the patients with PCOS. Now again, we don't have any RCTs that which kind of lifestyle changes are important for the PCOS, and dietary changes, which kind of diet is better for the PCOS patient. We don't have the RCTs on these issues. Then the effect of lifestyle management in the prevention of the weight gain or maintenance is compared to the compared to the weight loss in PCOS. We don't have how much of the weight loss is beneficial for the PCOS patients. Now again, the mental health and physical activity in women with polycystic ovarian disease, PCOS. So 6 out of 7 research studies, they have evaluated the mental health and quality of life in context to physical activity. And they have reported that the physical activity causes the positive mental health outcome in PCOS patients. Now again, the evidence supports that association between the PCOS and the poor mental health is very strong. Then in association with the PCOS and the low physical activity levels are also strong. So exercise commonly advised, as we know the physical activity, they causes better mental health and also they improve the PCOS condition in the most of the PCOS patients. Now lifestyle management training targeting the first weight loss in the patients who are already obese or overweight, and also preventing the weight gain in the patients who are having normal weight in PCOS. Now, weight loss should be targeted in the PCOS patients who are having this BMI more than 25, particularly in Western scenario, but in Indian scenario, it should be 23. Now, exercise participation, that should be around 150 minutes per week, and out of this 150, 90 minutes per week should be the aerobic and moderate to high intensity exercise to decrease the weight and also to change in the lifestyle and the mental health condition. Now come to the pharmacological management. So to decrease the insulin resistance, we have the two molecules. First is metformin, then thiazolidinedione. Metformin, particularly we know in the PCOS, the hyperinsulinemia is the main pathophysiology. So it is moving around that. So hyperinsulinemia, we decrease the hyperinsulinemia with the metformin. Again, it leads to decrease in the ovarian stromal tissue and also it decreases in the androgen synthesis and secretion. Metformin is having direct effect on the androgen synthesis, also indirect effect by the insulin, this hyperinsulinemia, decreasing the hyperinsulinemia. Now metformin, beside this, metformin also improves the better outcome as far as the cardiovascular problem or metabolic disorder is concerned in case of the PCOS. Now second agent is thiazolidinedione, where the pioglitazone is most commonly used. But the most of the trials are on the trozlitazone, but because of some issues with trozlitazone, now we are with the pioglitazone. So this is the ligand for the nuclear PPAR gamma receptor. Again, improve the action of insulin on the liver and particularly on the adipose tissues. So decreases the insulin resistance. So most of the evidence indicates that it reduces the insulin level that is mainly responsible for the hyperandrogenemia in case of PCOS. Now the therapy targeting the infertility in PCOS for the ovulation induction. So first is non-pharmacological therapy. That is the first line treatment in case of the anovulatory cycles or anovulation. So pharmacological, this non-pharmacological treatment we have already discussed, like lifestyle management, exercise programs for the patients, and particularly for the patients who are having obese or overweight. In those patients, weight reduction program should be there and lifestyle modification in terms of diet should be there. Now come to the pharmacological management of infertility in PCOS. So first drug is clomiphene citrate. So clomiphene citrate is a first line pharmacological agent to improve the fertility outcome in PCOS patients in anovulatory infertility or in other causes of this infertility in PCOS. Clomiphene is selective estrogen modulator with the both estrogenic and anti-estrogenic properties. So with the estrogenic property, if it is estrogenic property, it acts on the hypothalamus on the estrogen receptor, then again it decreases this negative feedback. So again it causes an increase in the GnRH and also increase in the FSH level. So the follicles which are in the dormant stage, they are not matured, they can get matured. So the action, mechanism of action is like that. So standard practice, it is administered from the for the 5 days from the day 2 or day 3 to day 7 or day 8. It is given in 50 milligram per day, then again it can be increased up to 150 milligram. After the 6th cycle of clomiphene citrate, we can say if the ovulation doesn't occur, then we can say this clomiphene citrate failure or clomiphene resistance cases. And obviously risk of multiple pregnancy is also there. Now again the metformin is also the drug which can be used for the ovulation in the patients of the PCOS. So it is combined with the clomiphene citrate. So it could be used alone for the increasing the ovulation rate, or it can be combined with the clomiphene citrate to get some better results. Now as the insulin sensitizing drug metformin and thiazolidinedione, they have compared. So if we are comparing with the placebo, so metformin is much better than placebo in terms of ovulation rate, in terms of pregnancy rate, in terms of live birth rate, not in terms of live birth rate or not in terms of miscarriage. Miscarriage and live birth rate are same with the placebo or metformin, but in terms of pregnancy rate is much better with metformin if you are comparing with placebo, or pregnancy ovulation rate is also much better with metformin. Then we compare the clomiphene with the metformin. So clomiphene in these RCTs, in these most of the trials we see in this meta-analysis, that clomiphene is better than the metformin in terms of this pregnancy rate, in terms of ovulation, but not in terms of miscarriage or in terms of live birth rate. So again, one thing is that metformin works better on the patients who are having BMI less than 30, not more than 30. If BMI is more than 30, metformin doesn't work on those patients if we are comparing with clomiphene citrate or placebo. Now come to the metformin plus clomiphene versus clomiphene alone. So here in this meta-analysis we see clomiphene citrate plus metformin combination is better than the clomiphene citrate alone. Here also in terms of ovulation rate, in terms of pregnancy rate, in terms of live birth rate, it is better than the clomiphene alone. But the problem again existing here, with the BMI more than 30, then it is equal to the clomiphene alone. Now again the questions are there, whether the addition of metformin to clomiphene citrate improve the birth rate in anovulatory PCOS patients with no other factors. We don't have the much data, though we have some RCTs only. Again, the whether there is difference in the effectiveness between the clomiphene citrate and metformin in PCOS anovulatory infertile women with body mass index less than 30 to improve the fertility outcome. So again, these questions are in the mind, still we don't have the data regarding that, robust data regarding that. Now come to the gonadotropins. So gonadotropins, they should be used as the second line drugs in case of ovulation induction in PCOS. Now they can be used in the first line drugs somewhere in the woman with polycystic ovarian syndrome who are drug naive or anovulatory infertile. Now if we compare the gonadotropin with the clomiphene citrate, obviously gonadotropins are better in terms of pregnancy rate, in terms of ovulation, but again the hyperstimulation syndrome can be seen in 0.1% of the patients with the gonadotropins. Now these are the factors this should be kept in mind, like cost of the therapy, intervention, expertise in the intervention, then degree of intensive monitoring in the patients, then implication of the potential multiple pregnancy with the gonadotropin therapy. Now come to the aromatase inhibitor. As letrozole and anastrozole are aromatase inhibitor, we are commonly using in case of the achievement of the pregnancy in PCOS cases. Now under the questions, letrozole and anastrozole, they should be used as one, we can consider them for the PCOS patients who are clomiphene resistant and in anovulatory infertile women with PCOS. Now the targeting androgen excess in PCOS patients. First, hormonal contraceptive pills, they are using as the first line treatment in the PCOS patient for the menstrual irregularity and hirsutism or acne or this bitemporal baldness. Now combined oral contraceptive pills is most commonly used drug for the PCOS with the this menstrual irregularities. They reduces the circulating androgen levels through the suppression of the circulating LH and stimulation of the SSBG level. The oral contraceptive pills can be used alone or they can be used along with the anti-androgens or metformin also. They can be considered to use in the adolescent girls also with the PCOS or in adult girls also, adult with PCOS also. So they can be, their specific type of any progesterones are also there, but they have not, societies are not recommending any specific type of progestin in case of this oral combined pills. Now again, it comes that when prescribing OCPs adult and adolescent with PCOS, at what time we should prescribe, it is not clear. Whereas OCP preparation, they have the similar efficacy in targeting the insulin, targeting hirsutism. So which is better, again, it is not clear. The lowest effective dose we should use with the estrogen or equivalent to natural estrogen preparation, they need to consider as the lowest effective dose. Then again, the generally limited evidence is there for the effective of OCPs. They again need to be seen with the various trials. Now come to the anti-androgens. So we are using mainly spironolactone, though cyproterone is also in use and finasteride is also in use. So spironolactone is aldosterone antagonist. It is structurally it is related to progestin. The most commonly used this androgen blocker for the treatment of hirsutism. It is effective for the abnormal hair growth associated with PCOS in non-classic CH also and idiopathic hirsutism also. Oral effectiveness is improved when we are combining it with the oral contraceptive pills. Again, apart from inhibiting the steroidogenesis, it acting as the androgen antagonist by inhibiting 5-alpha reductase enzyme also. With the problem with the spironolactone alone, if we are using the irregular menses or the irregular spotting can be there if we are using alone. So it should be used with the oral contraceptive pills. Again, monitoring of electrolytes and blood pressure is also required in case of spironolactone. Once we are increasing the dose, we are starting the dose, after 2 weeks we should go for the monitoring of electrolytes, and effectiveness of contraception should be there because it's teratogenic also. Again, now come to the cyproterone acetate. So this is again the different this anti-androgens. It compete the dihydrotestosterone or testosterone for binding the androgen receptor. It can inhibit 5-alpha reductase activity. Now finasteride, we are commonly using finasteride. It inhibits 5-alpha reductase activity used primarily for the treatment of prostatic hyperplasia, but can be used for the bitemoral baldness also and in PCOS cases also. Flutamide, because of hepatotoxicity, we don't use this drug. Now come to the surgical management. Surgical management, previously it was used at laparoscopic vase resection or drilling can be used. So they are having equal results or even better results than GnRH analogs. They have compared with GnRH analog only. So again, the cost of therapy expertise is required for the intervention. Then post-operative risk is also there. Then come to the bariatric surgery. So bariatric surgery is also considered as second or third line therapy for the fertility outcome in case of the PCOS when the patients are particularly obese. So thank you.
Thank you, Dr. Sanjay. Hello. Thank you, Dr. Sanjay, for a nice presentation. But over here, you emphasize mostly on the obese PCOS. What about lean and thin PCOS? Because nowadays we are coming across most of the girls not fatty or not overweight, but they are having their PCOS, irregular periods, and an ultrasound, also polycystic ovaries, and the biochemical markers also suggesting PCOS. Then how do you deal with this lean PCOS? And second question is, what is your view about this myoinositol, that's insulin sensitizer, and how do you relate metformin with myoinositol?
Yeah. So lean thin PCOS is very common nowadays. We see in our OPD patients are still lean and thin, but it is not there that only the obesity is there the cause of PCOS. As the pathophysiology we see there is increase in the androgen because of the ovarian stromal tissue increment, or that may be an environmental factor or genetic factor. There is no particularly one thing that the obesity causes hyperinsulinemia or that only causes. That is the one pathway of this pathophysiology, that is not the full pathway. Then again, as far as treatment in lean and thin is considered, the metformin works better in lean thin patients than in obese patients, as the various trials have shown that if the BMI is less than 30, then metformin works better. If it is more than 30, then it doesn't show good results in most of the patients. So again, the insulin sensitizer myoinositol, there are also some growing evidence are showing that it can be used in PCOS patients as it decreases the insulin resistance and decreases the insulin level. So it's there, but still we don't have the robust data, robust RCTs to compare the myoinositol with the metformin or some thiazolid indiones, though, so we can say it is better or it is comparable these drugs. So it's still it is off-label drug for this.
Exactly. One advantage of myoinositol is being it's non-gastric friendly. In metformin there can be some gastric irritability or other because patients knows that sir you are giving us metformin, it is being given in the diabetic patient. Am I diabetic? It is a common fear among the patients. So and one disadvantage is only the gastric irritability is there in some patients with metformin. So in that case myoinositol can be given. Thank you.
Yeah.
Now the house is open for any discussion and query.
Yeah, metformin, the disadvantage with metformin is the gastric intolerance, but nowadays we have the extended release metformin, so that is minimized gastric intolerance is there with the metformin, extended release metformin.
For how long and in what dosage you give metformin?
Most of the study are showing that metformin is given in 500 milligram thrice a day. And how long, it depending on the patient's condition, metformin can be given for the longer period, up to years. But in particular PCOS patients, when we are giving oral contraceptive pills and other drugs, we used to say that you should take at least for 2 to 3 years. Then later on we will decide. So depending on the patient condition.
Someone is taking metformin and incidentally she gets pregnancy. So what will be your recommendation?
Someone is taking metformin and diagnosed with pregnancy?
Yeah. Infertile patient taking metformin and diagnosed to have pregnancy.
So if the patient is taking metformin diagnosed to have the pregnancy, that is not a big issue. If we go through all the investigations, the patient is having IGT or increased blood glucose level, then continue with the metformin. If it is normal, then we can withdraw the metformin.
Exactly. We used to continue till 3 months of the pregnancy, then we can stop it.
Yeah, but actually for the pregnancy data, metformin is showing the increased ovulatory rate, increased pregnancy rate, but not showing increased live birth or miscarriage, doesn't have any advantage in miscarriage. So there's no point behind that we should continue the drug in patients who doesn't have any IGT or in diabetes mellitus.
Okay, thank you Dr. Sanjay sir for a nice presentation.
Thank you, sir. Thank you, sir. I would request you to please proceed to the presentation area for the momento presentation. For the next session, I would like to request Chairperson Dr. Sarojini Joshi ma'am, Senior Consultant Obstetric and Gynecology, Apollo Hospital, Bhubaneswar, and Dr. Pratap Kumar Mishra, Senior Consultant Endocrinologist, Capital Hospital, Bhubaneswar, to please come up on the stage.
Good noon to everybody, and from the outset I must congratulate the organizer and everybody, because today is the Mother's Day and they have planned it in such a way that Mother's Day, and it is the subject is oriented to gynecology, obstetric and gynecology. So I must congratulate all the mothers today. and thank you everybody. I think my co-chairman is absent, so I request you, I request Dr. Deep Datta to go for the session. The subject is hyperglycemia in pregnancy. It is, though it is our subject, so now it is also concern. So please start.
Thank you so much, madam. It's an honor to always come down from Delhi to Bhubaneswar, to the land of Lord Jagannath. A big thanks to Dr. Sambit for making me a part of this beautiful scientific extravaganza. Very happy Mother's Day to all the mothers here. Same to you, ma'am. And yes, today a difficult topic, management of hyperglycemia in pregnancy, is never possible with the support of gynecologists, because they manage these patients from the preconception phase, entire pregnancy, even in the postpartum phase. So this is a difficult topic because a lot of evolution has happened. Every year we get a new guideline, and certain subtle changes happen because our understanding of glycemia, and especially glycemia in pregnancy, is evolving rapidly. So when we talk of management of glycemia in pregnancy, our idea is to improve both the fetal outcomes as well as the maternal outcomes. So previously we used to call it the gestational diabetes mellitus, and now all the guidelines have become more inclusive. So they talk of hyperglycemia in pregnancy. So it is not only about new onset dysglycemia in pregnancy, it's also about managing people with pre-existing dysglycemia. It may be type 2 diabetes, it may be even young women with type 1 diabetes, they also become pregnant. So it encompasses the entire basket of increased blood glucose in pregnancy. We should also remember that it is not a very panic creating conditions. Many times women, they walk into a clinic that they have seen high blood glucose and they are stressed out, the husband is stressed out. So we should highlight and tell our patients and counsel them. Most of them do very well, they have excellent outcomes, and diet and lifestyle changes are the cornerstone therapy for managing hyperglycemia in pregnancy. Of course, there are patients who would need insulin, but it's not like every person, every lady with an increased blood glucose will need insulin therapy. So a management is all about understanding what are we trying to diagnose. We should be very specific regarding what are the diagnostic cutoffs. We should also be specific what are we trying to achieve once we diagnose. If we are using an intervention, be it a diet and lifestyle change, insulin or metformin or any other medication, whether are they really safe in pregnancy? If yes, how to use, how long to use, so that we can give the best outcomes to both the mother as well as the child. So for that we should know the burden of the problem in our society. So there are a lot of different meta-analysis has been published. There's a lot of ethnic variability. It is usually believed that around 1 in 10 women have hyperglycemia in pregnancy. So that's like around 10 to 11%. Of course, the ratios are really different from across the globe. What is important that there are certain risk factors we should need to know. So if a lady has had pregnancy previously and she had hyperglycemia in pregnancy, she has the highest odds ratio of again having hyperglycemia in pregnancy in the subsequent pregnancy. That's nearly 8 times the odds ratio. Similarly, prior history of macrosomia, prior history of strong family history of diabetes in family members, having metabolic syndrome or obesity. For the Asian Indians, for us the normal BMI is less than 23 and not 25 as for the rest of the world. So age also is a risk factor for hyperglycemia in pregnancy. So this is a slide which provides us the ethnic based or geography based prevalence of hyperglycemia in pregnancy. So all of the global numbers are only 14%. If you look in Indian data, it's like more than 20%. Just like 1 in 5 pregnancies will have some degree of hyperglycemia in pregnancy. The only part of the world which are doing worse than us is perhaps the Middle East and the Northern African countries, where like 1 in 4 pregnancies will have hyperglycemia in pregnancy. So how do we screen? So a lot of confusion there. First we were taught to do the initial screening 50-gram glucose tolerance test, and then in patients who are coming positive we do a proper 100-gram glucose tolerance test. Now gradually we have shifted over to a single standard 75-gram glucose tolerance test. So why this? Because first of all, calling patients twice is difficult. The more times we have to call patients for any intervention, more likely are going to be dropouts in the real world scenario. Again, if you have two different protocols, it causes a lot of confusion. Previously, we were told that we should do this OGTT ideally between 24 to 28 weeks of pregnancy. Now we know in real life they do not follow guidelines. Hyperglycemia can occur even in the first 4 weeks of pregnancy. It may be pre-existing. It can occur in the late first trimester also. So now the dictum is coming from a part of the world where 1 in 5 women are going to have hyperglycemia in pregnancy. The DIPSI guidelines and the Indian guidelines, they have recommended that at least in India, every pregnant woman needs a screening for their blood glucose. Whenever they come to healthcare professional for seeking help, I think blood glucose screening should be a mandatory part of the screening protocol, and 75 gram glucose tolerance test should be the investigation of choice for screening and not the 2-step 50 and 100. Why? We will look at the data subsequently, because the original, that the Carpenter-Couston criteria, which is the 2-step approach, that was devised by epidemiological studies focusing on maternal outcomes in terms of predicting the risk of long-term risk of diabetes in those women after pregnancy. But what we are trying to achieve when we are trying to diagnose and manage hyperglycemia in pregnancy is to improve the immediate maternal outcomes, that is decrease the need for cesarean section, decrease the risk for preeclampsia, decrease the risk for hypertension in pregnancy. And we are trying to improve the fetal outcomes, that is the fetal growth should be appropriate, should not be small for gestational age or even large for gestational age. The child should not have an increased risk of hypoglycemia in the immediate postpartum period or further risk of metabolic syndrome later in life. So, and the 75 gram glucose tolerance test was derived from the HAPO study, the landmark HAPO study, which was done in pregnant women in the large cohort of patients, more than 25,000 patients from 9 different countries, more than 15 different centers, and they actually looked for these pregnancy outcomes, whether we can really make a difference in improving the pregnancy outcome. If you see here, it talks of kids having body weight more than 90th percentile for that ethnic group. The need for cesarean section, the risk goes up more than 90th percentile. So the cutoffs which we got from for the 75 gram glucose tolerance, that is that a fasting blood glucose of more than 92 milligrams per deciliter, or a 1 hour blood glucose post glucose of more than 180 milligrams per deciliter, or a 2 hours glucose of more than 153 milligrams per deciliter. These patients are going to have a risk for the fetal and maternal complications more than 90th percentile for that population. So since it talks of the immediate pregnancy outcomes, the 75 grams of glucose tolerance test is more suitable and more robust to be used in clinical practice. Not to mention, it is a single test, easy to do, the chances of dropouts going to be much lesser. So I think all the guidelines have now gradually shifting themselves to the 75 grams GTT for diagnosing hyperglycemia in pregnancy. And there are even meta-analysis to show that in populations, in cohorts where they used the 75 gram glucose tolerance test and they picked up hyperglycemia in pregnancy and they managed them and followed them up, the pregnancy outcomes in terms of the maternal outcomes and fetal outcomes were much better than using both a two-step glucose tolerance test. So now we have diagnosed, the diagnostic criteria is not an issue, we have covered that. What to do next? So when the expectant mother walks into our clinic, we need to discuss the possible fetal and maternal complications and what are we trying to prevent, and we need to tell them don't panic, a good therapeutic diet and lifestyle changes is the cornerstone of management. So look at the BMI of the lady. She may be having a normal BMI, she may be underweight, she may be overweight. So discuss her weight. So there's a tendency in Indian society ki if the daughter is pregnant, make her eat as much as possible, because if the mother eats well, the child will grow well. So we need to discuss uncontrolled eating and overeating is not recommended. It is generally believed that an average pregnancy has a weight gain around 8 to 11 kilos. So we should go for at least, they try to gain weight in the first few months of pregnancy. Tell them sorry, the maximum weight gain for you is going to happen in the last trimester. First trimester you may even lose some amount of weight. Don't worry, don't panic, don't overeat. Look at the BMI. If the lady is already overweight, if her pre-pregnancy BMI was more than 30 or maybe 35, then there is no question of asking her to put on weight another 10 to 15 kilos. She will definitely land up into severe hyperglycemia in pregnancy. So in people who are already obese or morbidly obese at the start of pregnancy, even a very subtle weight gain or maybe a few kilos, 3 to 4 kilos is good enough. So these things needs to be discussed with the expectant mother. We Indians, whichever part of the country we are coming from, what unites us is the love for carbohydrates. In average Indian diet, we take around 60 to 65% of carbs. That's what the starch study and numerous other studies showed us. So sitting down with the expectant mother, telling that please cut down the carbs in your diet. We are very bad protein intakers, so we need to increase the protein content, which is further going to help the growth of the baby also. That would really help us in improving the glycemic control. Taking your gynecologist into confidence, if there is no issue of placenta previa, no issue of spotting, if she can walk, I think light walking inside the home. So many times you go out for walking only once or twice a day. A challenge which we see in hyperglycemia and pregnancy is to control the postprandial blood glucose. So a small walk inside the house for 10 to 15 minutes after the breakfast, lunch and dinner, that also really helps in taking care of the postprandial hyperglycemia in expectant mothers with hyperglycemia in pregnancy. So reduce carbs, increase proteins, increase physical activity if there is no contraindications are the cornerstone for managing hyperglycemia in pregnancy. And monitoring. It's a do-it-yourself project. If an expectant mother feels I'm going to get my lab glucose checked once a month or once in 2 months in pregnancy, she is never going to control her blood glucose in her pregnancy. She needs to get her own glucometer. She needs to be comfortable using the glucometer, and she needs to monitor, do a staggered self-monitoring blood glucose. It's not type 1 diabetes. We are not asking them to check blood glucose 6 times a day, pre-meals and post-meals. They can do staggered. So one day they can check a fasting post-breakfast, 2 hours post-breakfast. Next day they can check a pre-lunch, 2 hours post-lunch. The subsequent day pre-dinner or 2 hours post-dinner. They'll know. It's all about self-empowerment. They'll know after eating what their postprandial blood glucose goes up. They can avoid that. After eating what, their blood glucose is a better control. So a lot of individualization of the dietary approach. It's a continuous learning process for both the treating doctor as well as the patient across the table. The weight gain point we have already discussed. Now coming to the medical therapy. Medical therapy threshold for treatment is very low. It's because hyperglycemia and pregnancy, the treatment targets are more aggressive. We would love the lady to keep her pre-meal blood glucose less than 92 milligrams per deciliter, and we would love her to have her 2-hour post-meal blood glucose less than 120 milligrams per deciliter. There's a lot of confusion also. Many times patients comes to us, my other doctor has told me I should check my blood glucose 1 hour post-meal also and 2 hour post-meal also. 1 hour should be less than 140 and 2 hours should be less than 120. We have to be practical. We cannot ask the lady to prick herself twice after every meal. It's not practically feasible. So you make your own protocol for your own center or institute and stick to that. If you're using 1 hour, please stick to the cutoffs. It's less than 140. If you're using 2 hours, stick to less than 120. Telling the patient these targets are really strict. They are difficult to achieve. In the non-pregnant state, the targets are much more lenient, but we are trying to achieve this for better fetal outcomes and better outcomes of your pregnancy. And even if 1 or 2 values go out of the range, don't panic. Many times we get called in the night at 11. My entire blood glucose is fine, but my post-dinner has come 160. What should I do? So don't panic. If 1 or 2 values goes outside the range, it's okay. We are humans. We are not machines. Insulin is the cornerstone for management. Insulin is the safest drug, and basal bolus insulin treatment is the treatment of choice. No question asked in terms of managing hyperglycemia and pregnancy. In a prick-phobic society like ours, in a pregnant lady asking her to take 4 times the prick month, sometimes it becomes challenging. So many times we use pre-mixed insulin also. They also work pretty well in managing hyperglycemia and pregnancy. We cover the 2 largest meals, typically the breakfast or dinner with pre-mixed insulin. We have an entire basket of insulin. The conventional insulins are approved. If you talk of the analog insulin, the Lispro insulin is the short-acting insulin which is approved for use. If you talk of the longer-acting insulins, NPH insulin is very safe, approved for use. Glargine insulin, typically till recently it was not in the guidelines, although a large volume of data is available to show that it is safe in pregnancy. Glargine insulin, the dictum is if a patient is already on glargine insulin, we typically continue glargine insulin in the pregnancy. We typically do not start glargine for the first time in a new onset hyperglycemia in pregnancy. Detemir insulin is approved for use in pregnancy. The newer U300 glargine, there is not much data, so it is not recommended for managing hyperglycemia in pregnancy. The injection sites are the same for the pregnant or non-pregnant state, at least in the first and second trimester. In the third trimester, with the abdominal enlargement, Many women are not comfortable injecting on the stretched abdominal wall. They can happily inject on the thighs, the outer part of the thighs, because that is the less sensitive. Telling them about changing sides, rotating sides, change the needles frequently, that makes the injecting insulin so much more comfortable. It's a dynamic process. Tell your patients, if you are starting insulin in the first trimester, if the insulin dose starts going up, the requirement starts going up, don't panic. Tell them it's a physiological state of hyperglycemia. In third trimester, your need for insulin is really going to go up. So don't panic. Especially take your gynecologist into confidence. Many of these women might need injections, steroid injections for lung maturity in the child. So typically in those 48 to 72 hours, the need for insulin may go up by 10 to 15%. Don't panic. And again, it comes down gradually. When to go for delivery, I think that's a highly individualized decision for the gynecologist. Typically in these patients, whenever they are planned for delivery, in the intra or peri-op period, we use insulin infusions. When we talk of oral medications, I think there's a lot of confusion with metformin. Metformin is a drug which has stood the test of time. Dr. Saran in his presentation just now told many women with PCOS, they are already on metformin, they conceive, they can continue metformin in the first trimester of pregnancy and even later. Pregnancy is a state of severe physiologic insulin resistance. If many of these women, they end up needing 80, 100, more than 100 units of insulin per day, metformin makes a life easier. Metformin not only makes the endogenous insulin work better, metformin also makes the exogenous insulin which we administer work better. So they help us in keeping the total daily dose of insulin down. Other than metformin, all the other agents have gradually gone out of practice. Glibenclamide was recommended for use. The newer data which has come showed that in women who have used glibenclamide, the risk of fetal macrosomia, hypoglycemia is higher. Do not use glibenclamide. There are some anecdotal data of use of acarbose in alpha glucosidase inhibitors in pregnancy, but they are not recommended, should not use, and we are not routinely using for managing hyperglycemia in pregnancy. I think the postpartum workup is very simple. What to do? Look at what the patient was on pre-pregnancy. If the patient was not on any medication pre-pregnancy, most likely after delivery she will not need medications. If the patient was already on metformin or insulin in the pre-pregnancy, she will typically come down, the doses requirement will come down drastically to her pre-pregnancy dose requirement. Typically they need also some monitoring in the post-pregnancy state, and many of them with a good therapeutic and diet and lifestyle change, they can go off their medication, especially if they only had hyperglycemia in pregnancy. So I think I have crossed my time. Yes. So with this, I think I would like to end my presentation and take questions from the house.
Thank you, Dr. Deep Datta. Any question from the audience? Okay. So, from my side, I can tell you this much, that all the patients, I am in Apollo, but for me, my patients are little affluent type, so they can go for the test, etc. In earlier days, we are asking in first trimester, all the patients to take little glucose. Nowadays, it is denied not to take. That was given only because that during the first trimester they were having vomiting and loss of appetite, all these things. So they may go to hypoglycemia and fainting. So that is the reason why we are advocating glucose drink very frequently. But now you people are asking not to drink. But suppose my patient is a predisposing condition having, because now everybody is predisposing, I think, because with the modernization, civilization, education, whatever you name, the predisposing condition for hyperglycemia is more in pregnancy. Aging factor, PCOD, all these things. So, what is your suggestion? Should they take glucose? Is there any without testing? First testing also I have not done. So,
I agree with your point that yes, some of these women may have severe hyperemesis in the first trimester. But the thing coming from Delhi, where the prevalence of obesity is 80% in the general population, 80%. I'm not exaggerating. It is 80%. Almost all the women have metabolic syndrome. So routine use of glucose we cannot say, but you can ask them to take complex carbohydrates. They again check your blood glucose. They can take complex carbohydrates. Routine use of glucose, I think, should be discouraged in the benefit of the larger society.
Thank you.
Dr. Deep, Madam, I need to ask. If you look at the time in range of gestational diabetes or pregnancy, even in type 1 or type 2, those who are known type 2 diabetes patient, it's 63 to 140, isn't it? That is the time in range. Don't you think the 63 is quite a low level to keep TIR to 63 to 140 in gestational diabetes? What's your comment on that?
I agree with you. I think traditionally we define hypoglycemia any blood glucose less than 70 milligrams per deciliter. I think it should hold the same for pregnancy. When we try to achieve such aggressive control in pregnancy, almost all the women experience one or more hypoglycemia episodes. It is true. The episodes of hypoglycemia in pregnancy is much more than managing a simple type 2 diabetes, I would clearly say. So I think we need to be pragmatic. Going for 63 is, I would not recommend, I do not do in my practice. I think 70 to 120, 70 to 140 would be a more pragmatic approach. I agree with you.
Okay. Thank you, Dr. Zahid.
Thank you so much.
So, ma'am, I have a question. I had a patient referred to a physician from the periphery. The patient was an IVF patient with a twin pregnancy. She was taking this Fiasp, almost 106 units in divided doses, and Levemir 74 units in twice, morning and night. Still then the fasting glucose 3 times were around 200 and post meal were around 250 to 60. So I sent the insulin counselor, maybe the patient is not taking insulin properly, but the patient was taking insulin properly. Consulted dietitian is following the proper diet, just that she is not able to do exercise because she has been told by the gynecologist not to do it. How to control with so high insulin dose and so high glycemia?
True, we do come across such patients who are like, she's IVF pregnancy, twin pregnancy, she's the elderly primary most likely, she already has metabolic syndrome, she has to walk because there may be some risk also. So yes, we do come across such patients. So then we may have to change the insulin. Why not use a simple regular insulin? There is no advantage of using Fiasp in pregnancy. It's only for toddlers to be given after meals. You can change the insulin. You can go to NPH insulin. Sometimes it works great. Metformin really helps us in this scenario. They really help us in tapering down the total daily dose of medication in this time.
Can we give metformin till the delivery, or by 7th, 8th month we need to stop?
I'll discuss with you personally. We're going late. I'll come to you. Thank you.
Thank you, sir. It was really a very nice session. For the next session, I would like to invite our chairpersons, Dr. Kishore Behra, Associate Professor of Endocrinology, AIIMS Bhubaneswar, and Dr. K.B. Parida, Senior Consultant of Medicine and Physician to Honorable Governor of Odisha, Bhubaneswar.
Hello. So this session we have got FCPD, and the speaker is Professor Sujoy Ghosh. He is a Professor of Endocrinology of IPGMR, Kolkata, previously known as SSKM Hospital, Kolkata. You have heard him yesterday about the oral semicolonic excellent speech. Today I think he will give the excellent speech on FCPD. Please continue.
Thank you, sir. Good morning, ladies and gentlemen. At the very outset, I would like to thank Sambit again, because when he asked me what I would want to speak on for this topic, I thought I should speak on FCPD, because this is something which is very, very common, not just to my state, Bengal, but very common in Odisha as well. And I thought, rather than a didactic lecture on FCPD, let me present whatever little original work we've done on FCPD in front of this August gathering, particularly in front of Siddharth sir. So, Dr. Varghese is thought to be the father of pancreatic diabetes in India from Kerala, and he said that this was a disease where you had pain in childhood, diabetes in puberty, and death in the prime of life. And all of the data that we talk about, that a typical FCPD patient is going to be lean, thin, undernourished, will have severe exocrine dysfunction, malnourishment. The disease has actually undergone a lot of transformation. You know, the typical X-ray finding of the stone, the typical ultrasound finding of a dilated main pancreatic duct with calculus, all of that is there, and our traditional belief is that you will find this disease only in the young individual. You don't have to think of this disease if somebody develops this disease at say age 35 or 40, and that everybody will have low BMI and almost nobody will have diabetic ketoacidosis, and this is relatively an innocuous diabetes. That is, these patients will not develop complications, or they will likely to be less likely to develop complications. So we kind of thought of, you know, why don't we actually have a relook of what's happening with FCPD, at least in West Bengal. A lot of those patients in our cohort is actually from Odisha also, who have come to our place. So this is a prospective data that I'm showing you, which I have been trying to collate for the last 8 years or so. FCPD, as you know, is a disease which is defined as a disease which happens in tropical countries. Diabetes definition is same as that of ADA, and you have to have chronic pancreatitis with pancreatic calculi which have to be visualized, and this calculi has to be intraductal and not parenchymal, and you have to show those morphological abnormality either on an X-ray or ultrasound. Usually they will have pain abdomen. Remember, not all patients will have pain abdomen, and not all patients will have steatorrhea, and not all patients will have abnormal pancreatic functions, but these are taken, and you can have FCP. The diabetes might not necessarily happen. So a lot of our patients that are picked up in the pancreas clinic, they develop diabetes later on, and you have to have absence of other forms of pancreatic disease. So you can't include something like alcoholic pancreatic disease into this. So we've had about 5 or 6 publications in it. This is one of them where we've clubbed a lot of the data. And what we've tried to do in our publications is, you know, in any disease you tend to have a comparator group. So we've tried to have comparators of type 2 diabetes, we've tried to have comparators of type 1 diabetes, and we've had normal non-diabetic individual. So when this paper was published, we had a cohort of about 101, and we took about, you know, the actual FCPD cohort was much bigger, 180 patients, but for the sake of the publication, we selected out 40 kind of patients of type 1, type 2 and normoglycemic individual. Now let us look at the pathophysiological defect in FCPD. Now this is Diffronzo's slide which he talks about the ominous octet. Let us look at all of those facets, what happens in our FCPD cohort. So the first of which is, let us look at what happens to the beta cell function and C-peptide levels. So if you look at the beta cell function and the reserve of C-peptide, both fasting and stimulated, and you compare FCPD with type 1 diabetes and type 2 diabetes, obviously the type 1 diabetes would be absolutely insulinopenic, whereas the FCPDs would be more insulinopenic than the type 2 diabetic individuals. So straight away you have a disease where you have more degree of insulinopenia compared to type 2 diabetes. So that is about beta cell defect. Now what about the incretin effect? We are all using GLP-1 analogs, DPP-4 inhibitors. Would this group of drugs work in FCPD, and is there an incretin defect in patients with FCPD? So we essentially compared a cohort of type 2 diabetes with FCPD, and we measured GLP, we measured GIP, and we measured DPP-4 in the fasting state and 60 minutes post glucose load. This got published in the Journal of Diabetes, and if you look at the incretin effect, it is really incredible, the results. Now in controls you have normal incretin effect, and if you compare in type 2 diabetes, there is a impaired incretin secretion. That is, you see the GLP-1 levels are lower. But what about FCPD? It is not low. So the GLP-1 GIP response is not low in FCPD, and I'll explain why in terms of pathophysiology. Whereas the GIP is almost similar to that of a non-diabetic individual. So at least it is not impaired, But GLP, as you can see here, is significantly higher in FCPD compared to normal controls. And why did we measure DPP-4? So now that I have told you that GIP is higher in FCPD, you might come and tell me that this is because the DPP-4 levels are wrong, therefore the GLP-1 is not getting degraded. So when you are evaluating the incretin pathway, you actually have to look at everything: the glucose levels, the C-peptide, the GIP and the GLP. So here what I have at least clearly demonstrated is that there is no incretin defect in FCPD patients. So the incretin pathway of diabetes is intact in patients with FCPD. What about glucagon? In type 2 diabetes, normally glucagon level is increased, but we have shown that the glucagon levels are low in FCPD, telling us that the alpha cell is also gone, and that is the reason two things can be explained. One, the less likelihood of diabetic ketoacidosis, and two, when your patient is being treated for FCPD, you will see there is often fasting hypoglycemia. You are not needing high doses of basal insulin. That is because glucagon causes the liver to produce glucose via gluconeogenesis, so that bit is also gone. So that, as you can see here, the glucagon level in FCPD is lower than that of type 2 diabetes. I will come back to the implications of all of this, because the role of DPP-4 inhibitors and GLP-1 receptor analogs, therefore, in patients of FCPD remains relatively limited. So if you use a DPP-4 inhibitor in an FCPD patient, please do not anticipate that there is going to be a dramatic improvement in blood glucose levels. That's number one. Number two, in chronic pancreatitis, there are now studies of replacement therapy, pancreatic enzyme replacement therapy. Now, if you give for example, somebody's got alcoholic pancreatitis, and is also diabetic. If you give pancreatic enzyme replacement therapy, there is some improvement in blood glucose also. What is the postulated mechanism? That when nutrients get absorbed in the small intestine, it triggers secretion of GLP-1. So presence of nutrient is not a trigger for incretin. Absorbed nutrient is a trigger for incretin. So here I have already demonstrated that the GLP-1 levels are already high in FCPD. So with PERT therapy, we might have improvement in absorption of nutrient, but I do not anticipate any improvement of blood glucose. And what is the possible postulated mechanism of why is GLP-1 high in FCPD? Now, FCPD is a disorder. Just imagine primary hypothyroidism. The thyrocytes produce T3 and T4, and in the pituitary, the TSH stimulates the thyrocyte to produce the T3 and the T4. Now, if your thyrocyte is dead, the T3 and T4 will increase, the TSH will increase, but the T3 and T4 will not be able to rise. So there is a lack of negative feedback. So your alpha and beta cells are both dead, intestine is normal. So however much the GLP-1 is increasing in the gut, it will not cause any insulin release or any glucagon release. So that is the postulated mechanism that we have proposed in this paper. Now, one of the other things that you and I see a lot in FCPD is pancreatic carcinoma. Could this be one of the postulated mechanisms that uncontrolled, unabated action of GLP-1 in patients with FCPD could be one of the postulated mechanisms of carcinoma in FCPD? So I'll cross over from, so I've already talked about those bits. Now, there are other bits in the pathogenesis of diabetes, right? Particularly insulin resistance. So is insulin resistance a feature of FCPD? So these are our patients. We've compared type 1, type 2 and FCPD, and we demonstrated that there is no increase in insulin resistance in general in FCPD. Associated in insulin resistance, that's always possible. But as part of normal pathogenesis of FCPD, there is no increased insulin resistance in FCPD. So if you're looking at the hyperglycemia bit, I have tried to explain all of the possible pathophysiological defects in FCPD. Coming to the pancreatic exocrine dysfunction, we are all aware that a significant proportion of our patients will have pancreatic enzyme deficiency in FCPD. But how do you measure it? There are several tests that have been postulated, but in clinical parlance, the easiest is possibly to measure fecal elastase level. And I've tried to categorize the levels of deficiency. More than 200 microgram per gram is usually normal. So we've actually gone and looked at exocrine pancreatic dysfunction in type 1 diabetes, type 2 diabetes, as well as FCPD. And we have demonstrated that in patients with FCPD, the fecal elastase levels are grossly low. And if you look at degree of insufficiency, our FCPD patients had almost 100% severe pancreatic enzyme deficiency as demonstrated by the fecal elastase test. But when you took a history, 1 in 6 of them had subclinical steatorrhea. The rest did not have severe symptoms, telling us that in spite of such severe deficiency, the disease manifestation is not necessarily severe in all of our patients. What about the complication rates in FCPD as compared to other disorders of type 1 and type 2? So we've looked at the microvascular complications, the renal function, the peripheral neuropathy as demonstrated by the VPT test, and retinopathy as demonstrated by digital fundal photography. You can see that there is significant microvascular complications in the form of peripheral neuropathy. So it's a myth that FCPD patient will not develop complication. You will have to actually screen them in a similar manner as you would screen a type 1 or a type 2 diabetic individual. And when you are talking about cardiac autonomic neuropathy, significant proportion of our patients with FCPD had cardiac autonomic neuropathy. So telling us again that this is not an innocuous form of diabetes, this is not a mild form of diabetes, patients will develop similar complications. The periodontal disease, this is actually currently under revision in one of the journals. We've actually looked at periodontal disease in patients with FCPD, and it was shown, at least in periodontal disease, they seem to have slightly lower complication rates as compared to type 2 diabetes. That could well one of the reasons be that this is at shorter duration of disease and relatively younger individuals. Pancreatic carcinoma, again in our cohort, significant proportion had pancreatic carcinoma, so 100 times more likely to develop pancreatic carcinoma than general population. So that's another publication of ours. We've gone and done stone analyses and looked at the compositions of the stone, and the commonest stones that we have is calcium and silicon stones. We've gone and done electron microscopy studies of the stones, and these are some of the pictures of the stones, and I would actually want you to look at some of these organisms here. So this is a stone from a patient of pancreatic malignancy, and these are gram-negative bacilli which has been colonized on the stone. And why, and this is a closer view of that. And why am I just bringing this up? Now all of us know patients with gallstones have higher risk of gallbladder carcinoma, and I came across several papers in recent times to show that the stone actually helps colonization of certain bacteria, and it is these bacteria which are probably involved in the pathogenesis of malignancy in gallbladder stone. There are several papers now, including one recently in Nature. We have actually written up a project. If we get funding, we will actually look at patients, to look at the microbiome in patients of FCPD with carcinoma and without carcinoma, to say whether there is anything in relation to the microbiome alteration in terms of the pathogenesis. The other bit that we are continuing right now is a study of genetic analysis. We are looking at all of the genes. I'll quickly finish because I'm running out of time. So we found SPINK mutation in about 26% of our patients. The PRSS1 and the PRSS2, we found only PRSS1 in our cohort in about 15%. The CTRC in about 3%, and the CFTR mutation we could not find in any of them. And these are some of the gel electrophoresis photographs of our FCPD. So to summarize, I've talked about that there is insulin secretory defect, there is no insulin resistance, there is no incretin secretory defect but dysfunction, no hyperglucagonemia, and there is severe pancreatic exocrine dysfunction. Microvascular complications might be lower than type 2 but not to be ignored. Cardiac autonomic neuropathy is very common, periodontal disease is there but less than type 2 diabetes, and there is high risk of pancreatic carcinoma. I shall stop there and acknowledge the help that I received from everyone. Thank you very much.
Thank you, Professor Sujay Ghosh, for excellent talk. So, any question from the audience?
I really congratulate.
Yes, sir, it's on.
Congratulate Sujay for this excellent presentation. Well, it was the PhD thesis of great Padma Shri V. Mohan, and I had heard his presentation way back in 1987 on FCPD, and maybe after a lapse of decades, I'm listening to another similar presentation today. Congratulations, Sujay.
Thank you, sir.
You have gone much deep into the business and really illustrated many things. Just as a comment, Professor A.P. Panda, the founder professor of surgical gastroenterology in Odisha, he had a series of surgical treatment of FCPD cases. And where the C-peptide reserve was good, most of them reversed, diabetic state reversed to normal. That's the only comment I can give. And Professor Panda must have done almost 70 or 80 or 100 cases before his retirement, retired long since. I do not know if the legacy is continuing amongst our surgical colleagues or not. Thank you for the excellent presentation.
Just one comment, sir. You know, the patients that we recruited were from the endocrine OPD as well as from our pancreas clinic. And the point that you make is very, very valid. Because this is cross-sectional data, had I had the good fortune of a longitudinal study, you would have seen the patients that is coming from the pancreatic clinic are predominantly coming with pain abdomen and other things. They've not had the diabetes. Their beta cell reserves are better. Whereas when they come to our clinic, by the time they have developed diabetes, the C-peptide levels are gone. Very well taken. Right, sir. Point taken.
Excellent presentation, Dr. Sujay. You said that GLP level 1 levels are higher in FCPD. What's your comment if you compare somebody type 2 diabetes on GLP-1 receptor agonist? What is the difference in the level?
So this is still within, you know, physiological upper limits. When you're treating someone with GLP-1 injectable, that's supraphysiological. That will be at least 10 to 20 times than the level that I showed.
I have one question.
Yes.
Like, in which kind of FCPD patient will advise for stone extraction and which usually you don't ask for?
Right. So my teachers used to say the patient must earn the surgery. You should not probably jump in and go in for a surgery just because somebody has got stones in the pancreatic duct. So severe intractable pain, that would be one of the major indications. And actually compared to in the past, I think phrase procedure is done much less commonly now compared to in the past.
They are not prone for the
Right. So one of the mechanisms that is postulated to develop ketosis is hyperglucagonemia. Now I have demonstrated that the glucagon levels are gone. That is because in FCPD not only do you have beta cell dysfunction, you have alpha cell dysfunction, and that is why the glucagon is low. So that is possibly one of the major reasons why diabetic ketoacidosis usually does not happen in FCPD. But like sir was pointing out, that beta cell function might be preserved. In some patients of FCPD, you might have some amount of alpha cell preserved. At that point of time, if the beta cell preserve is already gone, the patient might actually present with ketoacidosis.
Because
Sir,
the chances of malignancy is so high, like we used to do in gallbladder surgery.
Right. So now we would, that's a very valid question that you asked. We don't have any prospective studies to demonstrate that if we remove the stone early, that we are able to prevent the malignancy. So one of the things that we wanted to do is the microbiome study that I'm talking about. If we can show that there is organisms which produce certain metabolites which are pro-carcinogenic, then the point that you're making that everybody with a stone, we will go and remove the stone. And remember, phrase procedure is relatively an easy procedure. Even though it's a pancreatic surgery, everybody will think that the pancreatic enzyme will leak and there will be abdominal problem. But phrase procedure is a relatively simple procedure and a safe procedure.
No, the procedure which was being followed here, I'm not a surgeon, not competent to comment. They have to treat the pancreatic duct, go to retrogastric, and anastomose with the small intestine. That was the procedure being followed after removal of the stones.
Right. But most commonly, at least our center, we are doing phrase procedure,
This was being
which is
practiced at SC Medical College when I was there.
Right, sir.
And definitely malignancy is a big scare. But before that, if you can cure diabetes by doing a surgical procedure and the child will grow normally, definitely it's more welcome.
Thank you.
I think because of shortage of time, we can stop here. Thank you for great presentation.
Thank you, sir. For the next session, I would like to invite our chairpersons, Dr. S.N. Swain, Associate Professor of Medicine, IMS and SAM Hospital, and Senior Consultant Physician, Emory Hospital, Bhubaneswar, and Dr. R.K. Goenka, Consultant Diabetologist, Kalinga Hospital, Bhubaneswar.
So today, one of the eminent speakers will be in the dais, Professor Siddharth Das, and the topic is also very special, that is proteinuric to non-proteinuric diabetic nephropathy. Now, most of the time we discuss about proteinuria, why the nephrologists, physicians and diabetologists, but non-proteinuric diabetic nephropathy is little discussed. So non-proteinuric diabetic nephropathy due to hypertension, obesity, hypertriglyceridemia, and the cause is nephrosclerosis, and which is very much there nowadays, and in type 1 diabetes is 20% and 40% in type 2 diabetes. To introduce that great scientist of our time, Professor Siddharth Das, who has elevated RSSDI to the national level, and he was the President, Research Society of Diabetes, twice, 2002 and 3, and he was the Chairman Scientific Committee of API 2003 after Professor B.V. Tripathi, and he is the
Thank you, Dr. Swai. I think I am very well known to the audience.
Because the new audience can know that who is Professor Siddhartha, the dawn of diabetes in India.
I am grateful to Sambit because of putting these two gentlemen as chairpersons. One is my student and one is one of my closest friends. And I'm indeed proud of Sambit. When I was a professor of medicine at VSS Burla, Sambit was a graduate student. And the past 2 decades or so, he has grown from strength to strength. He's one of the most brilliant endocrinologists, outstanding academician, and a par excellent organizer. Thank you, Sambit and Manas, for calling me here. Well, I chose a topic. Can I have the slides, please? Well, I always go in a reverse direction. When people go in a streamline, I always go in reverse direction. So I chose this topic, proteinuric to non-proteinuric nephropathy and diabetes mellitus, the paradigm shift. Because most of us think that albuminuria is sine qua non of diabetic nephropathy, but things have changed a lot over the past 3 and 4 decades. Well, diabetes mellitus is a pervasive cause of end-stage kidney disease in Western population. Nephropathy affects 20 to 30% of type 2 diabetics. Advanced renal disease attributable to diabetic disease counts for 44% in USA and 30% in UK. And the epidemiologic survey unequivocally showed that reduced GFR is more common among diabetic patients than in non-diabetic subjects. So it's a part and parcel of diabetic disease state, but also revealed that a large number of such patients will never show levels of proteinuria above the traditional definition of overt diabetic nephropathy, and we tend to miss this group of patients. And now the necessity on IDDM and UK pediatric type 2 diabetes or NIDDM have shown that tight blood glucose control prevents development of nephropathy. Monitoring of blood pressure and proteinuria along with tight blood glucose control should be practiced in every diabetic patient. I'll come to blood pressure subsequently. Now coming to the Indian scenario, way back in 75 to 78 there was a national study, a multi-nation study where Delhi AIMS was a part of it, and they showed depending on the duration of diabetes, 0 to 6 years, 10.7%, then 6 to 13 years, 23%, And if it's more than 14 years, 13.6% patients were diabetics and nephropathy. Significant albuminuria or serum creatinine more than 1.5 was then the definition for diagnosing diabetic nephropathy, way back in 1778. A similar study done in Ames showed that as per the duration of diabetes, the prevalence of nephropathy increased from 22.7, 28.2 to 40.2% in 86. And ICMR also showed that 15.4% males and 13.9% females had nephropathy. So nephropathy is a very big complication for diabetics in India as compared to coronary artery disease. Now, following the same method of ICMR, SC Medical College had conducted a study where we found that 12.2% of females and 5.3 for males and 5.3 for females had nephropathy with a duration of 0 to 6 years. And as the duration increased, 22.5% males and 7.5% females had nephropathy. And the brilliant study by the Indian Kidney Disease Registry by the Indian Society of Nephrology has shown that diabetes mellitus is the cause of kidney CKD in 38.2% of patients reporting to them. Now, this book was published way back in 1984. Next to Bright's disease, all of you know that diabetic nephropathy once upon a time was known as the Bright's disease. And next to it, if anybody has the largest contribution in the diabetic nephropathy, was Carl Erik Mogensen. He gave the classification grading of diabetic nephropathy. And it was published way back in 94. And in that book also, if you look at the definition of diabetic renal disease in insulin dependent or type 1 diabetic as it was called in those days, if you look at hyperfiltration, microalbuminuria, clinical proteinuria, their strong predictive value, the structural reason was still not known. Relation to pathophysiology, yes, not defined. And associated with other vascular lesions in type 1 diabetics, yes, and likely. So albuminuria is not only important for nephropathy, but is also important for general vascular disease. If you look at the NIDDM patient in the same book, it has become clear that the course of complications and implication of microalbuminuria differ in several respects between two types of diabetes. And here they are more related to endothelial dysfunction than nephropathy. So now coming to a diabetic nephron, what happens to the altered hemodynamics? If you look at the glomerulus, that is the afferent vascular dilatation because of hyperglycemia, high blood amino acid levels, and low sodium chloride delivery. So what happens, there is dilatation of the afferent vessels, that the increase in sodium chloride filtration, glucose filtration. Then in the descending loop of Henle, there is the increase in sodium chloride reabsorption and glucose reabsorption. Sodium chloride reabsorption is obligatory. Stage 3 in the ascending loop, decrease in distal delivery of sodium chloride because they are absorbed here. This leads to vasoconstriction of the efferent vessels in the glomerulus because of a decreased feedback. And so what happens ultimately, the afferent loop the artery is dilated and the efferent artery is constricted. This is the typical pathophysiology which happens with the diabetic nephropathy. Now, proteinuria, diabetic nephropathy and kidney disease. In an epidemiological study comparing secular trends in prevalence of diabetic kidney disease in USA across 3 window times, 88 to 94, 99 to 2004, and 2005 to 2008, they found there is an increase over time, 2.2% to 3.3%, but overall CKD increased from 14.9% to 17.7%, whereas albuminuria tending to decrease. This is a longitudinal observation in USA. Now coming to these observations, the same data test extend up to 2014 subsequent showed prevalence of albuminuria decreased progressively over time from 20.8% to 15.9%. In contrast, the prevalence of reduced eGFR increased from 9.2% to 14.1%. So this was the paradox, this was the disparity between loss of albuminuria or decrease in albuminuria, but loss of GFR. Now coming to the perspective intervention was proposed by not other than Carl Erik Mogensen. There are no longer any doubt that microalbuminuria is a major independent marker of poor prognosis. Obviously, reducing my albuminuria could be a goal for the distressed physician, Whereas is now in several studies has been documented that albuminuria can be reduced by antihypertensive treatment and optimized glycemic control. So not only we look at the glycemic control, but also the antihypertensive treatment, which has probably caused this paradigm shift. Now looking at the glycemic control of different studies, DCCT, EDIC, UKPDS, Advance and Accord, wherever there is a decrease in comparison between HbA1c 7.3 to 9.1, reduced micro and macroalbuminuria and overproteinuria. When you look at renal protection, definitely it was improved. If you look at HbA1c 7 versus 7.5, risk reduction of macroalbuminuria. So microalbuminuria and macroalbuminuria depended more on the glycemic control rather than primary defect in the kidney because of the mechanisms I have shown. Now proteinuric nephropathy in diabetic Indian scenario, the Chennai urban population study or a cure study, rural population study showed, they found that proteinuria was only present in 2.2% of cases, but microalbuminuria in almost more than 1/4 of the cases. The Chunampet study showed that diabetic nephropathy was seen in 20.3%, taking microalbuminuria as the guideline. Bikaner and North Delhi, 26.8%, 15.3%. The Cindy study of the multi-center clinical based study of newly diagnosed type 2 diabetes showed that newly detected diabetic mellitus, there was kidney, the microalbuminuria was found in 15% of patients. Now coming to microalbuminuria in type 1 diabetes, the Mumbai study, microalbuminuria is more common in males in older individuals, and microalbuminuria is a marker of progression of nephropathy in type 1. Look at the type 2 diabetics was found to be a marker of generalized vascular endothelial dysfunction. In our own study, if you look at the type 2 diabetics, the urine albumin excretion reduced over the period of time with good glycemic control from 280 to 90 and even 190 to 80. So good glycemic control and blood pressure control definitely reduces microalbuminuria. Now coming to the paradigm shift. What is the shift in the paradigm? Historical trends showing improvements in glycemic control over the time in large database and a widespread use of antagonist of renin-angiotensin system decrease in the prevalence of glomerular lesion. So microalbuminuria is a marker of glomerular lesion and allowed the emergence of other types of renal lesions affecting the institution and vasculature. That is why cause of progressive renal damage without triggering proteinuria or producing just mild or moderate increase in the levels of markers. So this is the paradigm shift. Now I alluded before paradigm that proteinuria is a necessary step. It has been found that is not the necessary step to make a diagnosis of diabetic nephropathy. Microalbuminuria and type 2 diabetic patients found to be a marker of generalized vascular endothelial dysfunction. Recent studies by Agarwal et al. Published in JAPI have shown that 17.5% newly diagnosed diabetics with microalbuminuria had hypertension. So unless we attend to both, microalbuminuria may continue, and it doesn't mean, and this is a very important slide, I beg your kind attention. Two different phenotypes of proteinuria. This is classical phenotype, the blue one, and these are non-proteinuric phenotypes. If you look at the classical one, and the proteinuria to develop end-stage renal disease takes a very long time. If you look at the non-proteinuric curves, normal albumurics, they develop loss of GFR much early. Microalbumurics, they have the loss of GFR is still early. So now the attention has shifted from this to this because this can be controlled by antihypertensive and good glycemic control. This is not a marker of endothelial dysfunction, but this is definitely a marker of rapid damage to the kidneys. So the National Diabetes Federation and the International Society for Nephrology, including 30,000 type 2 diabetic patients from 33 countries, found that the overall prevalence of micro and macroalbuminuria was 51, 39, 10% respectively with wide racial diversity. The absence of proteinuria, a reduced GFR is observed in about 1 diabetic patient out of 5. So 20% you will find have no albuminuria. Proteinuria cannot be considered as the marker of diabetic nephropathy without quote. Proteinuria in diabetics has been seen as an indicator of glomerular lesion in the diabetic patients with CKD. Proteinuria is a distinguished feature of glomerulonephritis. In type 2 diabetics, non-proteinuric diabetic nephropathy kidney disease is more frequent than proteinuric kidney disease. However, substantial research efforts are still needed. End-stage renal disease via mechanism pathways other than proteinuria has been established. The risk factors are for proteinuria to non-proteinuric diabetic nephropathy that might trigger a progressive decline in the glomerular filtration rate in the absence of proteinuria, or hypertension, obesity, and hypertriglyceridemia. Hypertriglyceridemia. This is always thought to be innocuous bystander. We always focus on cholesterol and glomerular hyperfiltration and alternation that is not confined to diabetics, being commonly seen also in elderly stages of hypertension. Now, we did a studies of markers of atherosclerosis, including insulin resistance in patients with chronic renal failure, not necessarily diabetics. And what we found, the comparison of various parameters between the three groups, non-diabetics, CKD, diabetic CKD, and healthy controls revealed that insulin resistance, beta cell dysfunction, dyslipidemia, hypertriglyceridemia, C-reactive protein, uric acid, and carotid intima-medial thickness were significantly higher among CKD patients than controls. Further, there was a greater degree of insulin resistance and beta cell dysfunction in diabetics than in non-diabetics. Now, coming to reabsorption of albumin escaped from the glomerulus filter by the tubulin-megalin complex in renal tubular cells, set into motion a nephrotoxic pathway. They activate the ROS. They enhance the synthesis of nuclear factor kappa B. Nuclear factor kappa B is a pro-inflammatory protein which is normally suppressed, and when it is high means it triggers inflammation, intracellular inflammation. Upregulates the endothelin-1, transforming growth factor or TGF beta, ultimately leading to tubular interstitial atrophy and fibrosis and renal function loss. Here you don't get any albuminuria. Now, coming to the markers, when you look at the glomerular pathology, we get albumin, microglobulin, etc. If you look at the interstitium, the markers are, the biomarkers are alpha, antitrypsin, TGF beta, etc. Look at the proximal tubule damage, these are the markers. Loop of annuli damage, osteopontin, uromodulin are the marker, or the time cell protein. If you look at the distal tubules, osteopontin and copectin are the markers. So, in nutshell, albumin, alpha-1, beta-2 microglobulin, and cystatin C are markers of glomerular damage. When there is no glomerular damage, these markers will not be found in urine. Interstitium, the markers are alpha-1 antitrypsin, TFG beta-1, monocyte chemotactic protein 1, VGF-1, NT-proBNP, etc. Proximal, loop of Henle, osteopontin, distal tubule, osteopontin. So, besides looking at microalbuminuria, we have to shift and evaluate for the level, status, or expression of nuclear factor kappa B and reflecting regarding activity of cytokine cascade. Again, this is one of our own work. We look at the genetic study, looking at the molecular biology of association of nuclear factor kappa B gene polymorphism with inflammatory markers in type 2 diabetes patients with or without renal involvement. It's a busy slide. I'm just showing you this genotype frequencies of nuclear factor B gene polymorphism, healthy controls, diabetes without nephropathy, and diabetes with nephropathy. If you look at this type of polymorphism, insertion was highest with diabetic nephropathy. If you look at deletion was highest in normal healthy controls, and if you look at diabetics without nephropathy, even if this was higher, this was not higher than in diabetic nephropathy. So, completely different polymorphism was found in those developing nephropathy and those not developing nephropathy. So, the epilogue, the paradigm shift in understanding diabetic kidney disease, accumulating data suggests that proportion of CKD patients without proteinuria are substantial. In a survey made in framework of 3rd National Health and Nutrition Examination Survey, as many as 37% of patients with GFR less than 30 had no albuminuria. This is also true for a condition like type 2 diabetes, where proteinuria was seen as an obligatory step in the pathway conducive of the kidney failure. Among patients with type 2 diabetics with GFR less than 60, included in the study, 30% were non-albumuric. The last slide. Glomerulonephritis are most often proteinuric disease. The incidence of end-stage kidney disease due to glomerulonephritis plateaued in 1990s and since then has declined. So, where the glomerular disease has declined because of use of ARBs and ACE inhibitors and good glycemic control, the other mechanisms causing damage to the kidney has taken off. So microalbuminuria or proteinuria is no more a telltale marker for diabetic kidney disease. Markers of interstitial involvement leading to non-proteinuric diabetic nephropathy has to be evaluated by an early stage. Strategies for monitoring and management of non-proteinuric diabetic kidney disease has to be established with consensus. More exhaustive genetic study in different population groups will guide the future management of diabetic nephropathy. I'm a retired man, so the challenge goes to all my youngster students here who are now brilliant teachers and brilliant researchers in different fields to take over this and delineate the situation in our country.
Thank you, sir. Thanks a lot for again teaching us.
And last but not the least, salute all the mothers, reverend mothers on Mother's Day.
Thank you very much, sir. As usual, again, these are the lights from a teacher only that can show us path for future research. I think this was known to everybody that not all diabetic renal disease are proteinuric. So that's what sir has told. And we are, I think this even staging are all of DKD is done on the basis of proteinuria. So that has to be redefined in the present lights. And we now open the topic for the questions from the audience.
I think it's lunch time. Okay, thank you everybody.
So thank you everybody and Professor Das for his eloquent and excellent presentation, and there is no questions on the floor. It is very crystal clear to everybody. Thank you again. Thank you.
Thank you, sir. I would request our chairpersons and speaker to please proceed towards the presentation area. Sir, Goenka sir, presentation, moment. Now moving on to the next topic, may I request the chairpersons, Professor Dr. Dayanidhi Meher sir, Professor Department of Endocrinology, KIMS Bhubaneswar, and Professor Dr. Prabhat Kumar Thatoi sir, Professor and HOD of Medicine, Government Medical College and Hospital, Keonjhar, to please come up on the stage.
Good afternoon. Namaskar. After the extensive talk on diabetic nephropathy, diabetic kidney diseases, now this is the time for, management of diabetes mellitus in special population, particularly on DPP-4 inhibitors, something related to kidney diseases and etc. So, may I request my second?
Yeah. For this, we do have a wonderful speaker, Dr. Hitesh Chakrabarty. He is consultant endocrinologist, Narayana Super Speciality and Multi Speciality Hospital, Havada, Rabindranath Tagore International Institute of Cardiac Sciences, as well as Amri Hospital, Kolkata. He was formerly assistant professor, Department of Medicine, Calcutta Medical College. He is a proficient speaker in different conferences and scientific forum. Now I welcome Dr. Hitesh.
slides have Good afternoon to everybody. It's a holy land. I have just stepped in here, so my pranam to all my seniors and my good wishes to all my colleagues. So my topic would be diabetes management in various special populations. At the very outset, there is nothing to be disclaimed at your customs, but there is a disclaimer that medical science is an ever-changing field, so whatever I am saying today is valid only for today's date, because one fine morning everything may change. So I carry two thank you slides with me every time. One is obviously, the first one is for the organizers, and here my special regards to Dr. Sambit Das, with whom I am having incremental friendship over the years. And the agenda of discussion in short would be covering on the elderly population, as my chairperson had already said, on diabetic kidney disease, on hepatic impairment, and a little bit of talk on glycemic variability. Because special populations may actually mean many things to many people, but because the title has already mentioned Glyptons, so obviously pregnancy and type 1 diabetes are going out of the ambit. And obviously the other classes of drugs which we could have discussed is also out of today's agenda. So coming to elderly first, because it is very important, we must give respect to our elderly, then only the society can advance. That is what our ancient Indian heritage has told us. So just as if you wear a very tight or a loose pant, you cannot walk properly. Similarly, the benefits of tight glycemic control should be weighed against the risks and the realities of an individual situation. And priority should be given to achieving the best quality of life. Now, who is an elderly? That is an important question. So there is no general agreement on the age at which we actually take a cutoff. Some developed countries say more than 65, Medicare eligibility say again 65, United Nations say 60, and who study in Africa have said even 50. So that's a problem. So my definition for today is whoever is 10 years older than the eldest in this conference will be elderly. So whoever actually qualifies for that, please don't get angry with me. So the unique issues in the elderly are manifold. That older person with diabetes are at higher risk than those without diabetes because of various comorbidities, the functional disabilities, the depression because of the disease or multiple injections that the patient has to take, the falls and fractures, and obviously the cognitive impairment, and also the dexterity problems in the hands in giving insulin, taking medication. Some patients actually take same medicine twice or even skip medicines, think that I have already taken it. So there are various considerations to be taken into account before we actually treat an elderly patient. It is easy to treat a young patient, just hand over a prescription, but for elderly there are many issues which we need to address. There are certain issues like polypharmacy. A patient who comes to an endocrinologist like me is given 4 drugs from my side, 3 drugs from my cardiologist friend, 2 drugs from my nephrologist friend, 2 drugs for some other medications. So long list of medications are there. What we need to keep in mind that polypharmacy is a problem. So we have to keep in mind whether drug-drug interaction is creating the problem in a particular patient or not. The other issues are obviously the multimorbidities, the autonomic neuropathy existing, maybe the higher risk of hypoglycemia, which I would be touching upon in the next few slides in a little bit of detail, infections, osteoporosis, and even cancer. So all these issues actually complicate the management of diabetes in an elderly population. If you look at the various classes of drugs, this is an exhaustive list. What we need to mention here is that among the Glyptons, because I'm talking of that here, the sitagliptin and vildagliptin do not usually show a lot of drug-drug interaction. So this is a little bit safe in this population because the patient is already on polypharmacy medications. When the patient is on some other classes of drugs, we often need to shift them from those classes of drugs to another safer classes of drugs. Like, say that, take the example of sulfonylurea. It is so commonly used in India, in all parts of the country. We often find that this causes hypoglycemia and other issues. So in those circumstances, maybe we need to shift an elderly patient from sulfonylurea to a relatively safer group where their hypoglycemia chance is less. Let us talk of SGLT2 inhibitors because it has so much noise in the market now. That also has a lot of issues in the elderly population, whether it would act because if the GFR is coming down. Obviously, I am talking of the anti-hyperglycemic action because the pleiotropic benefits may persist at lower ends of GFR, but the anti-hyperglycemic action may not occur because if it is not filtered, then it will not reach the receptors. So common age-related tolerability issues, if we look at all the molecules that we use, the Glyptons do not have any specific age-related tolerability issue. Now, talking of hypoglycemia, this is very important. The issues that are important in this context are obviously the falls that we see so common in elderly, need for hospitalization or care, the cost issues, which obviously because in India we have to pay out of our pocket. Fear of hypoglycemia itself is a big deterrent to use of medications, and sometimes patients themselves under titrate medicines just fearing a hypoglycemia because they have just faced it in the near past. Quality of life is disturbed in certain circumstances because of repeated things, because there may not be a lot of caregivers at home. Everybody is busy now, so the children may not be able to give so much time to their parents who are suffering, and uncertainty about severe risk. So when we are actually focusing on the hypoglycemia in elderly, we need to understand that hypoglycemia itself may be a little bit of challenge to diagnose in the elderly. The symptoms may be non-specific, easily misdiagnosed. We talk of stroke, vertigo, or even visual disturbance. It may be misinterpreted as a dementia-related symptoms like agitation or behavioral change. This is very common, which comes to us referred from psychiatrists. Atypical presentation like confusion or passive delirium, little warning or unawareness of autonomic symptoms, both because of the senility as well as due to the neuropathy. Now, if we talk of DPP-4 inhibitors versus sulfonylureas in the real world, what we see, the summary of the slide is that Glyptons were associated with lower incidences of various events in both elderly patients with history of CVD or without history of CVD. So this part has to be kept in mind. Now, effects of hypoglycemic agents on fracture risk, because I pointed out fracture is a very important thing that we have to keep in mind, that glitazones have actually, the thiazolidinediones have some problems with that, because we know that they tend to shift the progenitor cells from the PPAR gamma pathway to the RUNX2 pathway. So the fracture risk is actually increased because adipocytes are increased and osteocytes are reduced. SGLT2 inhibitors also had certain signals with some fractures, but now those are largely cleared. Now, if you look at the better treatment adherence than the conventional alternatives, the Glyptons definitely were associated with better treatment maintenance and lower discontinuation than sulfonylureas or the TZDs. If you look at the comparative efficacies of the DPP-4 inhibitors, this is important because we are talking as a class, not as a molecule here. So there are definitely some commonalities between them. Just as there are 5 children in a family born out of the same biological father and mother, there will be some features which they will share among themselves, there will be some features which they will not be sharing, they will be unique in certain respects. But the unique feature among all the Glyptons is that their efficacy in reducing HbA1c is quite moderate. It is about 0.5 to 0.7 or 0.8. So that can be seen across the class. Now, question is durability. This is very important. You give a drug that reduces HbA1c and sugars, it creates a miracle, the patient is happy, but after some time it loses efficacy. It doesn't usually happen. The durability studies with various Glyptons have showed that it persists over a period of time. Now, let us just talk about the interval trial there where vildagliptin was used. The individual glycemic targets are achievable with vildagliptin without any tolerability issues in the elderly population. What they concluded is that the number of patients reaching their individual targets was higher in the vilda group than in the placebo group, independent of the baseline characteristics. And lastly, because we are talking of the elderly population, the safety and tolerability was similar in the vilda and placebo groups with low incidence of hypoglycemia and no emergence of new safety signals. Last but not the least, this line is important. I am quoting this from the standard of care ADA 2022, that DPP-4 inhibitors do not reduce or increase major adverse cardiovascular outcomes. So this one is important. And lastly about this, in the elderly population, we have kept flexible glycemic targets. In other populations, we say that we have to keep the HbA1c around 7, and if possible without causing undue hypoglycemia, it should be around 6.5. But in these populations, we have to keep it little bit relaxed, because the risk of hypoglycemia, the more hypo and hypercycling, these issues may be there in the particular patient. So you can see that if the life expectancy is not much, we keep it much more relaxed at a higher threshold of HbA1c, while those patients who are relatively stable, not many comorbidities, having a better life expectancy, in those populations we can keep around 7.5 or 7. Coming to the next part of the topic is obviously the kidney disease aspect. Now, CKD monster definitely has two heads that we see in two aspects, that there is a proteinuria aspect and the lowering of EGFR. Nowadays, we all have this app in our smartphones, and during our rounds, we need to put the EGFR, because many drugs have to be modulated, modified according to the EGFR present in that particular patient. Now, two things needed to be done here. Number one, you cannot use all drugs with all liberty in diabetes with CKD. In those circumstances, you have to avoid certain drugs that might cause any harm, and you can select specific drugs that preserve renal function. This second part will not be discussed because SGLT2, GLP-1 come more here, so I'll just be skipping that. The important slide, take-home message for all physicians is this slide, that when we are starting from the left end of the spectrum to the right side, which are the drugs that are able to filter out to the rightmost end? Not all drugs can be used. As the EGFR declines, we need to actually modify or even omit or edit the prescription so that certain drugs have to be removed while some can be continued. According to this, if you look at the Glyptin family, linagliptin can be continued till the end. So it is one of the molecules which is pierced to the right end. Other molecules may need to be adjusted. When I'm talking of Glyptins, I'm just quoting this, that most of the Glyptins are secreted renally. Only linagliptin goes through the liver aspect. That is why it is used in renal failure. Now, I quoted this from the Endocrine Clinics of North America journal, that other Glyptins also can be used if you properly adjust the dose. So according to the EGFR, you can actually use other molecules as well. If we look at vildagliptin, the product insert from the innovator brand also says that the maximum daily dose is 100 when the EGFR is up to 60, but if it dips below that, you might need to adjust it at a maximal daily dose of 50 milligram. You can still use this molecule. Studies of Vilda in patients with type 2 diabetes and renal impairment, obviously the efficacy part is well established that it reduces blood sugar, so efficacy part is not at question. The third part of the presentation is the hepatic impairment. This is a little bit dicey. The thing that is to be understood is that the pharmacokinetic and safety profiles of DPP-4 inhibitors are generally good in patients with compensated liver cirrhosis, but data on patients with decompensated liver cirrhosis are limited. And DPP-4 is upregulated in patients with chronic liver disease. So this may be an option how we can explore the use of DPP-4 inhibitors. And DPP-4 inhibitors may be useful in patients with NAFLD and chronic liver disease, but the patients must be monitored for cirrhotic decompensation and hepatic failure in patients with cirrhosis. And DPP-4 inhibitors are considered weight neutral, carry a low risk of hypos, but they have the added advantage of being oral agents. And DPP-4 inhibition by specific inhibitors are demonstrated in several animal models of NAFLD to attenuate hepatic steatosis. Now, we need to know where not to use. So, obviously, there are certain circumstances. We will talk of saxagliptin because it is adverse signal in hospitalization for heart failure admissions. Vildagliptin also has some problem in some greater variety of liver dysfunction. If the SGOT, SGPT goes more than 2.5 or 3 times upper limit of normal, in those circumstances, we actually cannot use. But the bottom line of this slide should be that in severe impairment we are using Child-Pugh score. In that situation, no oral agent should be used. It is actually insulin that should be used. The last part, a few comments on the glycemic variability is that there are some data on gliptins, and obviously vildagliptin also has good data on glycemic variability. And when we compare the variability issue vis-a-vis sitagliptin, here we showed that, saw that Vilda and Sita improved glycemic variability, but Vilda induced better circadian glycemic control than the sitagliptin arm. And if you look at the time in range improvement with vildagliptin and sitagliptin, Vilda significantly increased the time in range by 24% versus sitagliptin was about only 9.8%. So, if you look at the MAGE also, here we see it is highlighted here that for the Sita arm it was non-significant, for the Vilda arm used 50 milligram twice daily, it was significant. So, several things come out of what we had discussed, that significant improvement in glycemic variability is noted, better circadian glycemic control provided you are using twice daily, significant increase in time in range is noted, reduced postprandial excursion and improved postprandial insulin secretion is noted, and more suppression of glucagon, this is one of the unique features of gliptins, in the interprandial period, finally helping patient to achieve better glycemic control. Now, whenever a discussion of gliptin comes, obviously we have to talk of the flozins as well, because it is a very close competitor and is a huge fight in the market. Now, efficacy of SGLT2 inhibitors is similar across the races. Gliptins in Asians definitely have shown to show better responses than gliptins in Caucasians. Some of the adverse effects with SGLT2 inhibitors, like use in warm, humid climates, it may be a problem, but once you prescribe a gliptin, you can be relatively safe. Even if the patient comes up after 3 months or 6 months, nothing much need to be monitored. And some of the adverse effects may need urgent or medical attention with the SGLT2s, while you may not need such things with gliptins. So it is like investing in a mutual fund versus a fixed deposit, or you are cruising on this type of road or this type of road. When you are using a gliptin, maybe your journey will be a little bit smoother. And diabetes is a lifelong journey. It is just like a Swayamvar Sabha. When you are choosing a medicine for your patient, obviously you will try to give the best to your patient. It is a 10-year journey. My last slide is this, that it is a child with cuts and bruises. There are errors and omissions, there will be trials and tribulations, but it is just close to adolescence. The use of gliptins in India has been only close to 16 or 15 years. So maybe we have not yet reached the peak of the growth, so gliptin era may have just begun. Thank you.
Thank you. Thanks, Dr. Chakravarti. Now this is open to all. If any question, one question. Yeah, yes. Mike.
Thank you, Hridis, for your nice talk. No, I just want to draw the attention of this gathering now. As you have already talked about the elderly before, the diabetes in the elderly. Yes. So you have already shown all the data and all the evidences. You have shown one slide of ADA also, where what are the targets of diabetes management, that is the targets. One thing I want to just add here, I think most of us are not doing as per the ADA recommendation, that whenever we get a patient of type 2 diabetes more than 65 years of age, so at the first point we should also do the cognitive function assessment. That is a mandatory. I think none of us are doing, not only that, every year we have to also do the same. So that is one point I want to add here, and I think we should also practice that, because there are various different charts which we can do it, but we are not
Lack
doing
of time, we do not actually contribute. The scores are there, but we do not implement it, right?
Yeah.
This is well taken up, sir.
Yeah, we're dealing with gliptins. Now, I think more than 5 years we have been with teneligliptin. So, there is no data from India or anywhere in the world to compare? I didn't find any data.
So, what's your question?
Teneligliptin.
Yeah.
In more than 5 years we have been using extensively.
Yeah, we are using it.
Vida become cheaper.
Yeah.
So, no data available to compare.
Now, in renal failure also, now there are some data, but from small studies that we can use in renal failure as well, teneligliptin. Small studies are there.
So, nicely pointed out. We have covered in a special population like glycemic variability, elderly, CKD, etc. But one special population is low socioeconomic population. So poor. So poor man's gliptin, once it was launched, it is teneligliptin, which
I think we are increasing to that list every day. Maybe we'll adding to the list this year also with another gliptin.
Yeah, there are some studies showing beneficial effect of DPP4 inhibitors in improving BMD and sarcopenia in elderly population.
Yes. For sitagliptin also, I didn't include that. For sitagliptin, there are some studies to show that even cognitive impairment and these osteoporosis scores, they are improving.
Thank you.
Now, any question? No? If there is no question, we will wind up here. Okay. Thank you.
Thank you, sir. I request the chairpersons and the speakers to proceed to the presentation area. For the next talk, I would like to invite our chairpersons, Dr. Sayantan Rai, Assistant Professor, Department of Endocrinology, AIIMS, Bhubaneswar, and Dr. Sushant Kumar Sethi, Senior Consultant Medical Gastroenterologist, Apollo Hospital, Bhubaneswar.
Good afternoon, everyone. At the outset, I am thankful to Sambit and congratulate him for organizing this meeting amid cyclone alerts. God is gracious, I must say. So we are talking non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease, or NAS in particular, non-alcoholic steatohepatitis, was thought to be a benign condition until last 2 decades. But as of now, we know it's the leading cause of not only chronic liver disease or cirrhosis of liver, but also hepatocellular carcinoma. And It is in fact the #1 indication for liver transplant in USA and UK. Come next decade, NAFLD probably will replace alcohol and infection in India as well. Now the $1 million question as of now is non-alcoholic fatty liver disease, whether it is a hepatic manifestation of metabolic syndrome or it is a pathogenic determinant of metabolic syndrome. So let's listen this from Dr. Soumik. Dr. Soumik Goswami, you can introduce.
Good afternoon. I take the pleasure to introduce the speaker, Dr. Soumik Goswami, who is faculty at Department of Endocrinology, NRS Medical College, Kolkata. He has several publications in national and international peer-reviewed journals, and he is an erudite speaker. Over to you, Dr. Goswami.
Thank you. Very good afternoon to everyone, and I'll begin my presentation with a sort of audience poll question, like we had in KBC, Kaun Banega Crorepati. So do you feel that patients with diabetes need to get their platelet count tested routinely? If you think it's yes, raise your hand. If you think it's no, please do not raise your hand. Time starts now. Okay, so I think about 7 or 8 people out of at least 60 have raised their hands. Let's go on to the presentation. And before I go into the presentation, I'll tell you a short story. Vishwanathan Anand, our chess champion, was traveling to Kerala by train, and this was after he had turned professional. There was an elderly gentleman sitting next to him who didn't recognize him and asked him, "What do you do?" He said, "I play chess for a living." The elderly gentleman told him that in India, sports is not a good profession. To play chess for a living, you need to be Vishwanathan Anand. So I just told this story because we are living amongst NAFLD. There's NAFLD all around us, but the problem is that we are not recognizing NAFLD, just like this elderly gentleman failed to recognize Vishwanathan Anand. Studies have shown worldwide 25% of the population have NAFLD. In India, certain studies have shown up to 40% of our population might have the primary stage or the so-called steatosis. Some of this steatosis progresses to non-alcoholic steatohepatitis, inflammation, hepatocyte ballooning. Long-standing steatohepatitis leads to fibrosis, and advanced fibrosis leads to cirrhosis. And given the huge prevalence of steatosis at this point of time, over a period of time, we are going to get to see more of NASH and more of cirrhosis. The underlying pathophysiology extremely complex. We still don't know the entire thing, but we do know that the common soil of insulin resistance plays a role, both at the level of the liver as well as extrahepatic tissues. Insulin resistance has a lot to do with the pathogenesis of NAFLD. Now, whom to screen for NAFLD? The answer is simple. Every patient with type 2 diabetes or every patient with metabolic syndrome or obesity has NAFLD till proven otherwise. Studies have shown that in diabetes or metabolic syndrome, 80% have NAFLD. So all your patients with diabetes or metabolic syndrome or obesity, please screen for NAFLD. Do the SGOT, SGPT, do a ultrasound, please screen again also because, not only because of the huge prevalence, it's an entirely asymptomatic condition. You pick up advanced fibrosis without any symptoms and your patient is going to go downhill unless you screen for NAFLD. Coming back to the question with which I started, platelet count. A platelet count is standard of care when you are doing a screening for NAFLD to look for fibrosis. There's a simple calculator called a FIP4 calculator. The ADA recommends this calculator. All the major societies recommend this calculator. You do a AST, you do a ALT, AST, you take the patient's age, you take the platelet count, you have simple apps, you can also go to the Google, the websites, calculate the FIP4 score. Why is it important? It is important because if the FIP4 is less than 1.3, you are pretty happy. The patient does not have significant fibrosis. If the FIP4 is more than 2.67, refer the patient to a gastroenterologist. There's every chance of the patient having significant fibrosis, and anything above 3.25 is a very strong indicator for underlying cirrhosis. So If there is one message, I think, which my presentation puts across today to this august audience is, please, please do a FIP4 in all your patients with diabetes and metabolic syndrome. ALT, AST, platelet count, age, look at the value and then decide what to do. If it's between 123 and 2.67, you can do a fibro scan to look for underlying cirrhosis. When we talk of NAFLD, our focus is often like in a tunnel vision. We think of the liver. The reason why most people die in NAFLD is not because of hepatic failure or hepatocellular carcinoma. Most people die in NAFLD because of cardiovascular disease, the commonest cause. The second most common cause of death in NAFLD is cancers, particularly breast cancer in women and colon cancer in men. There's more of osteoporosis, more of depression in NAFLD. It's actually a multisystemic disease, a part of a multisystemic disease that we are looking into. And when we talk of insulin resistance, when we talk of metabolic diseases, weight reduction is the key, healthy diet is the key. Any hypocaloric diet which causes you to lose weight is helpful. 5% weight loss, steatosis comes down. 7% weight loss, steatohepatitis comes down. 10% weight loss, even fibrosis starts coming down. If you talk of isocaloric diets, calorie non-restricted diets, then a Mediterranean diet with a lot of fruits, vegetables, with a lot of extra virgin olive oil is something which is also helpful. Interestingly, coffee drinking has been found to be beneficial. At least 2 cups of coffee, preferably 3 or more cups of coffee, is helpful in NAFLD. Sugary drinks, fructose, is something which is a strict no-no in NAFLD. When it comes to India, we know that proteins are costly. Carbohydrates, refined carbohydrates are a cheap source, economical source of energy. And this also could explain some of the huge prevalence of NAFLD that we get to see here, because low protein diets, either by altering the gut microbiota or by reducing the generation of small chain fatty acids and odd chain fatty acids at the level of the liver, could contribute to NAFLD. In animal models, feeding them high protein diets have been found to be beneficial. We await human studies. Exercise, any exercise is beneficial. Even if it doesn't cause weight loss, it will improve NAFLD, it will reduce cardiovascular risk, and importantly, as I said, NAFLD is a multisystemic disease. So osteoporosis benefits are there, depression benefits are there with exercise. Now when we talk of weight reduction, we automatically think of bariatric surgery being a solution, but it's not that simple in NAFLD. Mostly, bariatric surgery benefits patients with NAFLD, but there are some studies which show that it could lead to a worsening of fibrosis in some patients as well. It could also lead to worsening of overall outcomes in some patients as well. So you need to choose your patients carefully. According to guidelines in Asian patients, if lifestyle modification measures have failed, if the BMI is more than 30, in the absence of significant cirrhosis, in the absence of significant perioperative risk, you can also consider bariatric surgery. Now what about pharmacotherapy? We love to give our patient pills. Vitamin E has some data in patients without diabetes in NAFLD, but the problem with this data is that it mostly reduces the liver enzymes without improving non-alcoholic steatohepatitis. And the other problem is that meta-analyses have shown that vitamin E is associated with an increased risk of all-cause mortality, an increased risk of prostate cancer, and increased risk of hemorrhagic strokes. What about pioglitazone? With pioglitazone, the data is somewhat better. It does lead to resolution of NASH. However, the resolution of fibrosis is not great with pioglitazone. It also improves blood glucose levels. The problem with pioglitazone is the risk involved, because we know that with pioglitazone, there's weight gain, there's fluid retention, there could be precipitation of congestive cardiac failure, increase in fractures due to osteoporosis. So the bad risk profile with pioglitazone again does not make it a popular agent in the treatment of NAFLD. And with vitamin E and pioglitazone, I think the main problem is that if you go by the guidelines, they can be used only in patients with biopsy-proven NASH. And the problem we know is that a liver biopsy is extremely difficult to get, even in a tertiary setup, even in an advanced setup, leave alone in a routine clinic. So practically, vitamin E and pioglitazone have their data, but they cannot be used in a day-to-day setting. So what are we left with? Do we have anything to use? The good news is that in India we do have something to use, and we have been using saroglitazar for quite some time for the treatment of atherogenic diabetic dyslipidemia. Evidence comes from the Evidence 4 trial. This was a trial which was not done in India, but done exclusively in the United States of America, 20 different centers, where they looked at the primary outcome, which was a change in ALT, which did come down. They looked at liver fat content, which did come down, and they looked at it with something called MRI proton density fat fraction, which is a very good modality. They also looked at fibrosis using FibroScan as a secondary outcome, which also did come down. After this data, we would still be interested in looking at data one in Indians and data where a biopsy was done, because that's the gold standard when it comes to treatment and its effect. This was a trial which looked at Indian data, which looked at biopsy-proven NASH. Saroglitazar was given, the patients were followed up for a year's time. After a year's time, a second biopsy was done to look at resolution of NASH. And they looked at resolution of NASH using a score called the NAS score, the non-alcoholic fatty liver disease, or the NASH score. An improvement of more than 2 points in the score was considered to be significant, and as is clearly seen, with the use of saroglitazar in a biopsy proven NASH study, there was nearly 2.5 times greater improvement compared to placebo. So this trial met its primary outcome. If you look at several secondary outcomes of this trial, there was improvement in liver function in terms of improvement in the in ALT, AST, gamma glutamyl transferase, ALP levels. The icing on the cake was an improvement in lipid profile as well, because we know patients with NAFLD often have associated atherogenic lipid profile. We know that today saroglitazar is approved specifically in India for the treatment of non-alcoholic fatty liver disease with associated comorbidities. The comorbidities could either be obesity, could be type 2 diabetes mellitus, could be metabolic syndrome, or could be dyslipidemia. And since these are the people in whom we are actually going to screen for NAFLD, practically every patient in whom we screen and get NAFLD has an indication for the use of saroglitazar as far as India is concerned. And it's not only the drug controller, but also august bodies of Indian experts who have recommended the use of saroglitazar both in atherogenic diabetic dyslipidemia as well as in non-alcoholic fatty liver disease. I'll touch upon some of the current trials that are going on with other agents. There are 8 different classes of agents which are being tried to look at for improvement in non-alcoholic fatty liver disease. If you look at the bottom 3, the studies have been terminated, they have not shown results, the sponsors have gone away. If you look at the ongoing studies, there are studies ongoing with something called obeticholic acid. I would like to tell you that obeticholic acid at this point of time is not approved for use anywhere across the world. The problem with obeticholic acid is that it causes pruritus in up to 50% of patients. It increases the LDL levels in up to 20% of patients. So the US FDA has asked for more safety data. It's not approved for use anywhere. In the same breath, I would like to say that ursodeoxycholic acid is also not approved for use anywhere. Please do not use ursodeoxycholic acid in NAFLD. There's no good data supporting its use. Agents which have promise include lanfibranor, include the GLP-1 receptor agonist, include the coagonists, and there is something called resmetirom, which stimulates the thyroid receptor at the level of the liver to improve NASH, as well as it also causes regeneration of the hepatocytes as well. Futuristic therapy, there are certain genetic defects which could directly lead to NAFLD, one of them being PNPLA3 mutation. So if you have a therapy against this mutation, it could improve NASH, and that has been shown in small studies, but I think these are therapies of the future. When we talk of gut microbiota, modulation of gut microbiota indirectly, why not modulate it directly? Why not give a fecal transplantation or directly implant good gut microbiota? These have been tried in certain studies. Or why not give probiotics to improve gut microbiota? These have been tried in certain studies and the results have been good, at least in the preliminary studies, but of course we need more evidence. Now when I talk of NASH, as I said, or NAFLD, liver disease is only a small part of the story. Most of these patients die of cardiovascular risk. So screen for diabetes, look for hypertension, look for dyslipidemia, and if you have diabetes, it's preferable to use drugs like SGLT2 inhibitors or GLP-1 receptor agonists where there is some data, at least preliminary data for improvement. Screen for cancers, ask your patients to go for their routine immunization. Again, when it comes to non-alcoholic fatty liver disease, since I spoke of it being more than the liver, disease beyond the liver, saroglitazar improves not only non-alcoholic fatty liver disease, but also improves cardiac risk factors like improving blood glucose and improving the atherogenic lipid profile. The last few slides, if you have diabetes and if you have NAFLD, what about metformin? These patients should definitely get metformin because earlier observational trials have shown, and this again is a trial in 300 individuals with biopsy-proven NASH, that those on metformin in diabetes and non-alcoholic fatty liver disease have greater survival and possibly better hepatic outcomes as well. Statins again are a group of drugs with which we should have a very low threshold for initiating in patients with NAFLD. The leading cause of death, cardiovascular disease. So if you have the slightest indication for the use of statin, you should use a statin, and possibly, I wouldn't say it should be used in all patients with NAFLD, but there are studies going on which have also shown preliminary evidence of benefit to the liver as well, beyond benefit to the lipid profile. So the final message should be that our perspective with NAFLD is wrong. One, we have not recognized that NAFLD is a disease. We screen for diabetes, we screen for hypertension, we look for obesity, but if you look at worldwide figures, our perspective should change. NAFLD is much, much more prevalent than these conditions. Screen for NAFLD, do an ultrasound, do the ALT-AST, do the FIP4 in all patients with diabetes. This should be the most important message of today's discussion. Do not look at the liver only, manage cardiovascular risk factors because that is where most of your patients are going to suffer. All patients with NAFLD should go for good lifestyle modification, diet, exercise, reduction of body weight, but as we know, these are easier said than done. Lifestyle measures fail in most of our individuals. So I think the final answer lies in adding saroglitazar. It has data in biopsy-proven NASH, it has approval in India, and it not only improves liver parameters, but improves blood glucose and improves the atherogenic lipid profile as well. Thank you.
Thank you, Dr. Soumik, for an excellent talk. See, as a hepatologist, I struggle every day to treat once a patient of diabetes along with liver enzyme dysfunctions they come. As you rightly mentioned, we cannot do liver biopsy in each and every case, but we are in search of an ideal drug which would reverse the fibrosis and which would improve the cardiovascular dysfunction. Having said that, two, three things you have told. One thing is obeticholic acid is very much available in India for last 2 to 3 years. The pruritus is a problem, but it is to the tune of 24%. And it has been also said that once you reduce the dose in second trial, the pruritus is much less. That is one. Second, metformin and all other drugs that has been shown, though they improve the liver enzymes, but the fibrosis is not reversed. Fibrosis, for reversing fibrosis, two drugs as you mentioned, one is saroglitazar and semaglutide, liraglutide. So they are the drugs probably, they are aiming for improving, fibrosis. So nowadays we would look forward, and now this is open for discussion, for question and answer for the audience. Yes.
Yeah, Dr. Soumik, you have mentioned about the FIB4 score for calculating NAFLD, but what about the NAFLD fibrosis score, NFS? That I usually do.
That's actually a more complicated score. It needs more parameters to be included. It's not that that's a better score than FIB4, because if you look at the American Association of Gastroenterologists or liver diseases, they say you do either of these two scores. I find the FIP4 score to be simpler. You need lesser parameters, and for a general audience who practice in busy settings, you might get only 3 or 4 minutes for a given patient. The FIP4 score is easier to do and has good positive and negative predictive value. I'm not saying the other score cannot be done. It's as good as the FIP4 score. It takes more time, needs more tests, more parameters to be included.
No, same thing. That LFT and your platelet count.
But you need to put in about 6 parameters, I think. Here there are 4
At the same time,
parameters.
you'll be getting the BMI value also for the
So you can do either of these scores. I'm not saying you cannot do the other, but I do the FIP4, and most associations say the FIP4 is good enough.
Okay.
It's easy to do.
Another thing is that by serially following the LFT of that patient, you can predict whether the patient has developed cirrhosis, because by the time patients develop cirrhosis, the AST becomes more than ALT. That is one clue.
Yes, so that's very important. Usually we get to see elevation of the SGPT values more than the SGOT values, but it's usually up to 250. Anything more than 250, you should think of other liver diseases as well. With progression of fibrosis, and as the patient progresses to cirrhosis, the platelet count starts coming down. The SGPT remains more or less same, but the SGOT might start changing at that point of time. So these are changes that might occur. Those are clues as well.
Yeah.
Exactly. Normal also.
Maybe normal, but
so I think that's a very
in a patient
important message.
One sub point
in a patient with transaminated NFLD, when there is reversal of ST-ALT ratio.
Even patients with steatohepatitis, 50% of them may have normal AST-ALT. So we don't have an ideal screening test, but we should screen with whatever we have.
And if the patient is having transaminases at the baseline, then it's easier to predict.
But 50% might not.
I have one question, Shomik.
Yes, Shan.
Do you think the change of nomenclature from NAFLD to metabolic dysfunction associated
fatty liver
will
disease
help more for better awareness, screening and management?
I think it has a more positive sound to it. Non-alcoholic fatty liver disease, you're putting in alcohol and you are saying it's a negative sort of diagnosis. If you don't take this, then you have this. Metabolic dysfunction associated fatty liver disease is more of a positive diagnosis. It has a positive connotation to it. So I think that is important. The other thing which we need to keep in mind is that just because someone consumes alcohol on a regular basis does not mean that it's always alcoholic fatty liver disease. It could be a mixture of both alcoholic fatty liver disease as well as non-alcoholic fatty liver disease. It could be a mixture of both. So MAFLD is the more appropriate term now.
And one comment, Shomikda, the non-invasive test for fibrosis, the scores, I think that probably these scores actually are less sensitive for South Asian population as compared to the Caucasian.
Yes, one, it's less sensitive for that. The other is that as you age more than 65 years, the specificity of these scores start coming down. So some authorities have said that if you are more than 65 years, then you take the FIP4 cutoff as 2 instead of 2.3. So there are variations, but I think the most important message is that we are not screening for NASH or not screening for NAFLD. We are not doing the FIP4. All these scores have their pros and cons, but we should at least start beginning with whatever we have in our hands.
Yes, I think like we do screening for microvascular complication, we should be proactive
like we
and
screen
start.
for albuminuria, retinopathy, creatinine.
We should
screen for NFL.
Any other question?
Again, there are some several limitations of fibroscan also. That is not useful.
Exactly. So someone with a narrow rib space, someone who is obese. So all of these have their limitations, but my message is we can talk of limitations only when we start doing this. We talk of side effects of SGLT2 inhibitors after we have used them.
So gold standard.
We are not screening for NASH.
Yes, gold standard still is biopsy.
Liver
Once in
biopsy.
biopsy you see inflammations or inflammatory mediators are there. They are given 3 points. And for ballooning, it given 2 points, and fibrosis it is given 3 points. Total 8 points. Out of them, if 5 or more, you can stamp the definite NASH.
Exactly.
So having said that, this is histopathology or biopsy report, and it is not possible each and
Sir,
every
even
day
in
to
your
biopsy.
center, I think it's difficult
So
to get a
our aim
liver
is to
biopsy. So
actually to pick, and if you are suspecting somebody, you can do AST-ALT level, platelet ratio, so that at least you can prevent chronic liver disease, transformation of chronic liver disease from NASH to CLD, so that hepatocellular carcinoma and death can be prevented. So that should be the take-home message. Any other question? If there is none, thank you very much, audience, for active participations. Thank you, everyone.
Thank you, sir. I request you to please move to the presentation area. We will break for lunch now. We'll assemble at sharp at 2 p.m. We have a lot of interesting practical sessions left. So please assemble at 2 p.m. sharp. Thank you. Hospital, and Dr. Sandeep Sahu, Assistant Professor of Endocrinology, High-Tech Medical College, to please come up on the dais.
Or shall we wait? We'll start. So, warm good afternoon to all. So, after the lunch, hello. So, warm good afternoon to everyone. So, after the lunch, we have an interesting session lined up here. So, we'll be talking regarding management of osteoporosis. So, this is a global health actually issue, which not only leads to significant morbidity and mortality, but it is poorly taken care of. And many conferences, including physician conferences, do not address this particular issue. And there is a significant management gap in actually what should be the targeted therapy for osteoporosis. If you look at ortho colleagues, they just treat the fracture, but they don't treat the cause. So that very patient again lands up with a second fracture within the next 4 or 5 years. So that is the issue currently plaguing our healthcare system. So I would invite Dr. Kishore Kumar Behra sir to deliver his talk regarding management of osteoporosis. I think he needs no formal introduction. He is well known to everyone. Currently, he is an associate professor at Department of Endocrinology and Metabolism at AIIMS Bhubaneswar, and he has several number of publications in reputed medical international and national journals. He is a widely acclaimed speaker and is frequently invited to many guest lectures across the country. So I think with that introduction, I will ask sir to start his deliberation.
Thank you, Soim, for this kind introduction, and just post-launch session, so people are still coming. Without wasting much time, this is a very interesting topic, and the osteoporosis is also a disease actually mostly found in older population and post menopausal lady, and is a great concern about the day-to-day life. And you will know if you have a osteoporotic fracture in the hip joint, probably the life expectancy over 1 year is reduced by 20%. And the osteoporosis is a skeletal disorder and compromised of bone strength, increased risk of fractures. And in the left side, you see the normal bony architecture, and bone strength reflects the integration of the two main features, that is bone density and bone quality. If these two are problem, then you develop the osteoporosis. And the osteoporosis, how we will define? According to the WHO criteria, and the bone mineral density of a young population of 35 years old compared with that of the population concerned, the population whom you are checking the BMD, and it is categorized if you are having a T-score of -1 or above, it is normal. If between -1 to -2.5, it is osteopenia, and osteoporosis is less than -2.5. And it has been shown that not only the osteoporosis, even the osteopenia, also there is increased risk of developing fractures. And this is how we, whom to treat: women of age 65 or men with 70 years old, and younger if you have a rheumatoid arthritis, you have taking steroid or any risk factor, then you go for a DEXA. And the T-score is -2.5 in the lumbar spine, total hip or femur, or hip or spine fracture, clinical or radiological. Radiological means when your people has come and you have seen, or clinically when the patient comes to you with any other symptoms and you find there is a compression fracture, or you have a T-score is -1 to 2.5 with FRAC score of 10 years, risk is more than 3% for hip or more than 2% for major osteoporosis fracture, you will go for a treatment. And this is how the calculation of the FRACs, it is having various risk factor like parameter you assess and put in a in this, and you can find out what is the risk factor for developing osteoporosis. And these are the approved drugs which can be used for the treatment of the osteoporosis. But due to this time constraint, I will be talking about this alendronate. This is a bisphosphonate, residronate, that is, and zoledronic. Zoledronic is the third generation, and ibandronate also third generation. Alendronate, residronate, this is the second generation, and etidronate is not much of data, so I won't be discussing here. And denosumab, these all drugs are the anti-resorptive drugs, and teriparatide is the only drugs which is available for, it is an anabolic hormone. And I will be touch upon regarding dual anabolic and anti-absorptive drug like rozusumab, if time permits. And this is the how the time taken for the osteoclast to to destroy the bone, and the osteoblast will take at least 3 months to put the new bone. So that is called the remodeling. And this is a trial which is called FIT trials, which shows about the alendronate which has been given, and it is shown in the woman with existing vertebral fracture and woman without existing vertebral fracture. You can see there is a improvement of the bone mineral density and the improvement of the fracture. And what happened in that FIT trials, when this treatment is extended for 5 years follow-up or more than 5 years, you can see there is a clinical improvement of the fracture incidence in the clinical spine, but there is no improvement in the morphometric spine fracture or non-spine fractures. So that's the question, whether how long you will give the alendronate for the treatment. The next is coming the zoledronic acid, which is given once in a month. You can give 5 milligram of zoledronic acid. Sometimes you can give once in a year or once in a 1.5 years. And it has been shown that it also improved the bone mineral density and decreased the fracture risk. And this is the trial which shows that there is no difference between the placebo and the zoledronic group. And you can see here the cumulative incident of fracture in non-vertebral fragility fracture, symptomatic fracture, they all improve clinically if you compare with that of the placebo. And also it's also prevent the decrease in height, zoledronic acid compared to placebo. And the most important thing is that the use of zoledronic acid also it decrease the incidence of the cancer and decrease the incidence of death. Then coming to the denosumab, is a new molecule which gives we give once in a 6 month, and this is the mechanism of action. It is a rank ligand antibodies, and the rank ligand is expressed in the osteoblast and rank is expressed in the osteoclast. So rank ligand, when attached to the rank, there is a stimulation of osteoclast and that leads to osteoporosis. When this denosumab attached to the rank, there will be no stimulation of rank ligand with the rank, so that will prevent the osteoporosis. And you can see this is the freedom trials, which having the 2 groups. One is the placebo, another one is the denosumab for 3 years, followed by placebo, and another 3 years of denosumab for another 6 years. And what we found here, there is, you can see, this is the total 6 years of denosumab. From the baseline, there is improvement of the lumbar spine BMD, improvement of the total of BMD around 21% and hip 9%, and also the femoral neck is 9%, and 1/3 of the radius around 2.7%. But you can see here, this is the placebo, followed by, if you give the denosumab, there is also improvement of the said BMD, but it is less than, statistically less than if you continue the denosumab for the longer duration of time. And this is shows the incidence of new fracture, long-term follow-up of this denosumab. We can see the freedom trial 1 year. There is long-term denosumab having decreased fracture risk of new vertebral fractures, even in the non-vertebral fractures, but you would see the virtual twin placebo, there is an increase in the non-vertebral and vertebral fracture risk. So the Freedom Extension 10 years data shows sustained low fracture rates, steadily increased bone mineral density, persistent reduction of the bone turnover, and no increase in adverse event over time. But there is some report of that is mandibular necrosis has been reported, and that the problem is we will be discussing why there is need of sequential treatment of the osteoporosis. We will discuss in further slide. And coming to the anabolic hormone, that is teriparatide, PTH of 134 amino acids, when you used in a different dose like 20 microgram and 40 microgram subcutaneously, there is increase of reduction of the risk of new vertebral fracture around 65% and 69%. In addition, there is a significant 53% and 54% reduction in risk of the non-vertebral fractures, and treatment with teriparatide result in significant increase in BMD at various sites like spine, total hip, femoral leg, and total body, and decrease in the distal radius and shaft of the radius. So it is quite effective. Then this is the abaloparatide. It is a synthetic peptide having 136 amino acids, and it can be used daily subcutaneous, and only 2 years it can be used approval, because long-term use causes the osteosarcoma of the rats, but not proven in the human beings, and it should be followed by the anti-resorptive therapy. And this is a abaloparatide when compared with that of the teriparatide, it show in every point of time the abaloparatides having a significant increase in the bone mineral density in comparison to teriparatide, and in various regions like total hip, femoral, and lumbosacral spine. And what is important is, in this slide has been shown that the primary endpoint in new vertebral fractures is statistical clinical improvement of the abaloparatide, and also when teriparatide when compared with the placebo. And the major osteoporotic fracture has been also improved, but which has been not seen, but there is no difference between the abaloparatide and teriparatide, but there is a difference between teriparatide, and there is no difference even also teriparatide with the placebo. So the abaloparatide is better in achieving the primary endpoint. The side effect is here, the contraindicated in the skeletal eradication, Paget's disease and metastasis and upon epiphysis, and it rarely causes hypercalcemia. So it is quite effective and can be used for the prevention of the fracture. And next is important, which has been not approved yet in ADA, in American, and so it's still awaited for the approval. So the mechanism of action is that this is a WNT pathway which stimulates the FISLT and LRP5/6, and that stimulates the catenin pathway, and that causes osteoblast to increased bone formation. And the sclerostin is a which secreted by the osteoclast, which inhibits, so it prevents the bone formation. So if you will design an antibody which can inhibit this sclerotin, then there will be more increase of the bone formation. So it is a dual agent. It has got some anti-resorptive function also. So the molecule is known as rimozumab, and it is 2 subcutaneous injection once a month for 12 months it can be used. And you can see here it is shown in every point of time, 3, 6, and 9, 12 months we can see there is a improvement of the BMD in comparison to alendronate and teriparatide. So the problem is what is the concern now? In the current evidence it shows that in all the armamentarium for the treatment of the osteoporosis, there is an increase in BMD in varying degree, and reduced vertebral fracture about 40 to 80%, and reduce of non-vertebral fracture of 40%. But the concern is that even if you use the alendronate or bisphosphonate for a quite long duration, and there is not of having a side effect. So are associated with rare but severe side effect that increase the atypical femur fractures, and you can see this depends upon if you use the odd ratio is increased more if the duration of treatment is more than 5 years. And you can see this is a trial which shows that after denosumab treatment, you stop the denosumab, then there will be sudden decrease in BMD and there is increase in bone turnover marker. This is a trial which is a 24 months denosumab followed by no treatment, and another one is the placebo, that is for 24 months and 24 months. You can see here, after you stop the treatment, there is marked decrease in the bone mineral density. So that is the one concern, and there is a marked increase in the resorption marker, C-telopeptide and N-telopeptide. And it also been shown that when the zoledronic acid has been given after the denosumab, irrespective of the time, did not fully prevent the BMD in patient of discontinuing the denosumab. And also this is one study which shown that if you give the anabolic hormone after 30 minutes followed by the follow-up 50 months, we can see though there is a preservation of the BMD, but still there is a decline, but it is not significantly, I mean, there is a decline of BMD, but it is still it is maintained to have the BMD over another 30 months. So the sequential therapy is important because to understanding long-term effect of the individual agents and understanding the effect of stopping the drugs and understanding the properties of specific drugs transition. So that's why there is a study which is called, and this is the sequential osteoporosis therapy which shows the switching from the bisphosphonate to teriparatide, BMD increases are blunted in comparison to de novo teriparatide, which is shown, and in the 18 months if you change from alendronate to teriparatide, there is a mild increase of BMD, but it's not very persistent. So the evidence from the data switch study, which having the 3 arm, we can the 83 patient, we have a 20 completed teriparatide, denosumab, and 24 combination. Then this is 24 months followed by teriparatide. You can give denosumab, you can give denosumab followed by teriparatide, or you combination of 2 followed by denosumab. So what this study shows, I will take only 2 minutes. So if you will give the teriparatide followed by denosumab, there is maintenance of bone mineral density and reduce fracture risk. And you can see here, if you will give the combination followed by denosumab, you can have the maintenance of the BMD. And the worst is combination denosumab teriparatide therapy followed by denosumab alone result in largest 4 years increase in hip and wrist BMD. In post-menopausal osteoporosis, switching from the teriparatide to denosumab, BMD continue to increase, whereas switching from the denosumab to the anabolic, there is a progressive bone loss. On when you are giving the sequential, probably you should not give the anti-resorptive followed by the anabolic hormone. That is the takeaway message from this. And this is another study which shows that when to choose a anti-resorptive agent, it depends upon how severe is the osteoporotic. It is a T-score is minus 3.5, minus 3, or minus 2.5. And you can see if you will give the alendronate, there is a alendronate have a 50% likelihood of achieving the BMD, but if you will give a denosumab followed by alendronate and denosumab followed by denosumab, they have a better likelihood of achieving the BMD than the alendronate itself. So in summary, the single drug osteoporotic drugs have a many limitations, including waning efficiency and increased risk of adverse effect. Transition from anabolic to anti-resorptive treatment result in either BMD maintenance or gain, as well as sustained fracture reduction. Switching from bisphosphonate to anabolic also result in further BMD gain, but the increase are blunted versus the de novo. Shifting from the denosumab to anabolic treatment result in increased bone remodeling and rapid bone loss and should be avoided. Thank you for the patient hearing.
Okay, sure for that kind lucid presentation. And the house is now open for any questions regarding osteoporosis or its management.
Thank you, Dr. Behra, for your talk. Excellent. Now, in our common practice as a physician, what we do on DEXA BMD. We get a result. There is a T score, there is a Z score, and there is the density of calcium as per square centimeter. That we are not taking into account very much. Now, when it is less than minus 2.5, well, we start a course of treatment, bisphosphonates, high calcium, and vitamin D3. How long to continue? We are continuing for 1 year. I don't know what is your recommendation. Now, after at the end of year, 1 year, well, more than 50% of the patients, they do well, fine. But after 1 year, again, when you go for a DEXA BMD, there is no change in T score. It is still the same. So what could the possible cause, and when to shift for teriparatide, and what is the indication and the biomarker, like that calcium, that density of calcium as per BMD, that will give an indication to start teriparatide. If so, how long? And how to monitor?
Okay, there is one question, but there's a multiple question to answer. So first of all, I will say, when you are doing the Z score, T score, we are comparing to that of a healthy individual of 35 years. When you are doing the Z score, you are comparing the 35 years old with that of the 35, 40 that means the same age you are comparing. So when the T score is minus 2.5, and you have the first line of treatment is always the anti-resorptive, because it is widely available. You can choose the alendronate, you can choose the zoledronate. There is a little bit of difference. If you will give a alendronate, you can give 10 milligram per day, or you can give 70 milligram per weekly. It should be taken 1 glass of water, and you should not take any food at least half an hour, and you should not bend forward because it can have a reflux esophagitis. When you are given the drugs and suppose there is no improvement of the BMD, so there may be first things is whether patient is taking or not. So you have to check the compliance. Second thing is, before you start the bisphosphonate, you have to check whether their vitamin D sufficient or insufficient. If they have a vitamin D insufficient, then probably the chance of improvement of BMD may be less, so you have to give the vitamin D and calcium. And all the trial they have given the vitamin D and calcium, which I have shown in the zoledronic acid, and we checked the BMD once in a, at least not before 1 year, but at least 1 to 2 years once you can check. Suppose once you given there is no improvement, you may continue. If there is a deterioration, probably you can switch over to anabolic treatment. But what I have shown here, if you will give the denosumab followed by anabolic hormone, probably that is not good. That is, you should not give that. So if you want to the standard of care practice there, even says that if you have a severe osteoporosis means you have a fracture and T score is minus 2.5, you start with the anabolic hormone, then followed by you give the anti-resorptive hormone. That is the best treatment is available.
I think that answers us.
Yes, axial fractures, vertebral, non-axial, these limbs or other areas. So is it that any bisphosphonate work, or there are some classifications?
Okay. So if you will see the data about alendronate, the ibandronate is only studied in vertebral fractures, and also the PTH teriparatide mostly of vertebral and very rarely non-vertebral fractures. So alendronate, zoledronic acid and denosumab, they can effective, I have shown in the 6th slide that it can affect in all the 3 sites. The most important sites for the fractures and which increase the mortality is the hip fracture, that is the non-vertebral fractures. So alendronate or zoledronic acid, probably we choose zoledronic acid because it is a very easy, and you can the compliance is not an issue because you want to give once in a month or once in a year or once in a 1.5 years. So that it is very safe, but prior to you give that, you have to give some paracetamol, and sometimes we give hydrocortisone because they have some acute reaction. So, and it should be given at least 30 minutes in 100 ml of normal saline. So that should be taken up care, and vitamin D, calcium should be given prior to the treatment.
I think with that we can close the session. We are running a bit late.
Thank you.
Thank you, sir. For the next session, I would like to invite chairpersons, Dr. Debadarshini Sahu, Assistant Professor, Department of Endocrinology, KIMS, Bhubaneswar, and Dr. Arun Chaudhary, Professor and HOD, Department of Endocrinology, KIMS, Bhubaneswar.
Hello. Hello. First correction, I am not the HOD of KIMS, I am professor of KIMS. So that's a correction to be made. Professor and head of the department is Dr. Dayanidhi Meher. Okay. And I have joined KIMS as professor in endocrinology only 2 months back. Prior to this, I was in SCB as associate professor. Okay, now today's presentation is regarding approach to a patient of hyperprolactinemia. Now, hyperprolactinemia is a very common, relatively common endocrine problem which come across day-to-day life that comes to endocrinologists, gynecologists and physicians. Now, the problem with hyperprolactinemia is an enigmatic hormone. If you look at prolactin, is an enigmatic hormone because right from the levels, multiple hormones which affect prolactin, they increase, decrease according to it also changes according to the level of estrogen, progesterone and all that. And the assay sensitivity and specificity and change in assays, how to interpret a prolactin report, whether you need to do which type of sample, what time it has to be done, and that's all important. And many times what problem occurs with prolactin is just increase of prolactin doesn't say that you should treat it, because Ipsita will touch all that points, when to treat, when not to treat, and what will happen when patient has symptoms of hyperprolactinemia but doesn't have high prolactin levels. Sometimes the patient has high prolactin levels without any symptoms. Some other drugs, some other hormones which are given which can increase the prolactin level. So the major problem which was done with prolactin level is anyone who sees a high prolactin level starts cabergoline without finding out the reason why is the prolactin raised, whether actually a cabergoline treatment is required or not. So the approach will be told by Dr. Ipsita Misra, and Ipsita doesn't need any introduction as such. She is a brilliant student. She was my student in SCB. Now she is the faculty member of SCB Medical College,
I'll
Cuttack.
always be, sir, your student.
And she is doing a very good job as a teacher now, and she is a hard task master. And the other things you can see there, I don't want to introduce Ipsita. Everyone knows what Ipsita.
Thank you, sir. Thank you very much. Good afternoon, everyone. So we'll go to the topic directly without wasting any time. Okay, the practical approach to hyperprolactinemia. Already, sir has made my job very easy. He has summarized everything. So one of the most common endocrine disorder which is encountered not only in the females where the reported incidence is around 30 for 1 lakh population, but also in the males. If you look, the reported incidence is around 10 per 1 lakh. And if you look into the treatment part, ever time treatment taken by a male is up to the tune of 30 per 1 lakh and in a female 90 per 1 lakh. Most common age of where the females are affected is between 25 to 35 years. Now, routinely prolactin is not a hormone which is advised at any go. So there are some particular scenarios where a prolactin is commonly requested. Most commonly in a females if they are encountering with menstrual irregularities like amenorrhea, oligomenorrhea, infertility in both the sexes, galactorrhea mostly in the females, males do not present with galactorrhea commonly, sexual dysfunction in either sexes, gynecomastia in male, in a suspected pituitary mass lesion, suspected pituitary dysfunction. Now the other two indications are not routine uses, but there are some scenarios where you need to individualize. Suppose somebody is taking antipsychotic drugs, whether you need to do a prolactin at the baseline or do you need to monitor, and these needs individualization to do whether you need to do or you do not need to do. So this is the society guidelines where the etiology of hyperprolactinemia is grouped basically under three headings: physiological, multiple drugs, the pharmacological and the pathological, which is again segregated into the etiologies associated with the hypothalamic pituitary stalk lesions, pituitary lesions per se, and multiple systemic disorders. So in the physiology we know most common it is the pregnancy and lactation followed by stress. Pharmacological causes, multiple drug use, especially in our scenario the neuroleptics and the prokinetic uses, OCPIL uses, and the pathology when you segregate into the three groups, some disorders involving the hypothalamic pituitary lesion, pituitary lesions such as prolactinomas per se, whether micro or macro, and other lesions involving the cellular area, and multiple systemic etiologies, especially the chronic medical diseases like chronic renal failures, chronic liver disease, PCOS and hypothyroidism. Now apart from these three broad segregations, the society has not included two major issues where prolactin can be elevated, that is the analytical and the idiopathic causes. So these are very important because analytical issues needs to be interpreted to decide whether we need to give a treatment or do not need to give a treatment. Now we diagnose a state of hyperprolactinemia. The society says that to establish the diagnosis of hyperprolactinemia, a single measurement of serum prolactin above the upper limit of normal confirms the diagnosis as long as the serum sample is obtained without excessive venipuncture stress. Now though the recommendation is of a single sample of serum prolactin at any time of the day, but some group of researchers do believe that due to the oscillations and the pattern in which prolactin is secreted throughout 24 hours, and if you do a sampling during the daytime which is probably not concordant with the clinical scenarios and you get a value something between 50 to 60, then reconsider whether you need to do a sampling once again or not. So apart from the venipuncture stress, definitely breast stimulation, exercise, food intake do interfere with the prolactin values. So these factors need to be considered. Now the earlier concept was to take a pool sampling, that is you take samples frequently at around 20 to 30 minutes interval, 3 samples and then do the estimation. But now even it has been found that the sensitivity of a single elevated serum prolactin from one sample which has been done in proper dilution is sufficient enough. Now the routine assays which are now being used are the automated immunoassays, and they use a two-site immunometric or a sandwich principle assay principle. Immunometrics are the most commonly used, and these modern assays are now found to be free from the cross-reactivity of related molecules such as growth hormone and placental lactogen, and most of the assays are standardized to the WHO third international prolactin standard of 84/500. Now this is important because we all know that in prolactin physiology, though the major part of prolactin is contributed by the small prolactin, that is the monomeric ones, to the tune of 80%, one thing is that which is may interfere in the assays, that is the big prolactin of 150 kilodalton. Normally it contributes to 8 to 10% of the prolactin values, but they do cause problems. So that is the scenario. Suppose you have a patient who has got very elevated prolactin values, comes to you with the report and is absolutely asymptomatic. Keep in mind that probably she may be having the macroprolactin part which is interfering in her assays, which is giving a very falsely elevated values. So the diagnostic gold standard for macroprolactin estimation is the size exclusion chromatography, but it is difficult, time taking, not routinely available, followed by gel precipitation which is equally good to set, But most commonly, which is being used by most of the labs these days, is the PEG precipitation method, where the patient sera and the PEG sera in equal volumes are incubated together to determine the macroprolactin. The macroprolactin is then calculated by the formula of the total prolactin, which is first obtained in the first sample, minus the free prolactin by the total prolactin. And to diagnose microprolactin, a PEG precipitation ratio of more than 60% or a post-PEG prolactin recovery of less than 40% is used. Now here there are some controversies, like suppose you get a PEG recovery value of macroprolactin between 30 to 65%, then this is classified probably as intermediate and may require further analysis with the SEC methods to diagnose macroprolactin. So the other opposite end of the spectrum is when you have a patient who has got full-blown manifestations of elevated prolactin with menstrual irregularities, galactorias, other features of hypogonadism, but you are getting a prolactin value on the lower side and it is not matching to your clinical scenario. So here comes the possible interference of the hook effect. Now what happens is when the prolactin values are very high, they are very, very high, so there is a problem with the signaling antibody capture part, and this leads to a poor signal generation and ultimately it gives a falsely low values. Now this is not a common phenomenon. This usually occurs when we are dealing with the macroadenomas or the giant prolactinomas, where we expect that the prolactin values will be in thousands, but we get a low value. So this is important because we need to decide the line of management, and this can be overridden by diluting the patient's serum sample to the tune of 1:100. Now other pitfalls in the assays is especially when use of biotin, same that as it interferes with the thyroid function test. It has been found that if you give a biotin dose of around 500 microgram per liter, the prolactin can come down to as low as 30 to 33%. Heterophilic and human anti-mouse antibodies do interfere, but these days the manufacturers take care of this. So ultimately to be kept in mind is that none of the assay is completely foolproof, and interferences should be considered when the prolactin results are discordant. And if you get such a scenario, then do reanalyze the sample, use other methods to get accurate results. So now next, moving on to the multiple pathological causes and how we can approach. Now we all know that in the prolactin physiology there are three important regulators of prolactin. The inhibitory, most importantly, is the dopamine, and the stimulatory is the estrogen and the TRH effect. So TRH effect, to understand this is very important because primary hypothyroidism, one of the mostly commonly encountered scenario where we can get elevated prolactin values. So not only in the overt hypothyroid cases where the prolactin can be elevated with manifestations of prolactin excess, especially in females, this can occur up to the tune of 50%, but also in subclinical hypothyroidism cases, it does manifest with hyperprolactinemia, and patients, they can have symptoms. So this has been reported to the tune of 20 to 30%, and we also see in our routine OPDs that subclinical hypothyroid females present with features of hyperprolactinemia. So here do not overzealously treat them with any dopa drugs, rather treat and correct the hypothyroid state. Now dopamine, most important, is the D2 antagonism, which causes a elevated prolactin state, and this occurs when we use neuroleptics and prokinetics. Now the question arises that how probably high prolactin can go when patients take these drugs. So it has been found that they can go as high up to 350 Ng per ml. So if you have a suspicion that patient is still harboring any lesion in the pituitary but is on the drug, because it's very difficult to switch over the drugs in these group of patients, then do the imaging. If you find a normal pituitary, and then depending upon your patient's clinical scenario, you may consider treatment. D2 agonism, yes, this is very important, and we all extrapolate this when treating the prolactinomas, both micro and the macro, and it is well known that the D2 receptor expression acts through the PIT1 expression on the lactotrophs, and we exploit this. So before going to the carbacolin uses, this is a small review. Microprolactinomas, we know that females are most commonly affected, and the prolactin values are elevated to the tune of hundreds, but not very high, not beyond 150s or 200s, and mostly they present with hypogonadism. Macroprolactinemia with the lesion size usually between 1 to 2 centimeter, with both sex predilection being equal. prolactins is relatively higher, can go up to thousands, and along with hypogonadism, they have mass effects. Now, if you look into the giant prolactinomas where the lesions are more than 4 centimeter, usually the males are affected, and here the prolactin values can go up to 10,000s, and along with hypogonadism, the mass effects predominate. Now, when we extrapolate the carbagoline use, some important considerations is when we treat a microadenoma, the question comes, when do we stop the drug therapy? So, the society recommends 2 years, but then you can individualize in 12 to 18 months. But it does so happen that once you stop the drug therapy after probably 18 to 24 months, females prior to entering into if they have not married, if they have not yet born children, then it can so happen that the prolactin values can again surge up. So now the school of thought says that if it is a small lesion, then probably surgery can be taken up because you do not know how long you need to treat these group of females. Maybe until they go into the menopause, you may need to treat. Now the next question comes, remission after pregnancy, small micro lesions. So once they become pregnant, we stop the drug therapy, and it has been seen that following the childbirth, lactation, approximately 1/5 of those females, there is no surge in the prolactin values, and the lesion values do not increase in size, so probably pregnancy is one hope that for these smaller lesions. Now, postmenopausal age implications are usually not known, and for these small lesions, the exact implication of the moderately elevated prolactin values, whether they need to be treated or do not need to be treated, is still questionable, and usually they are not treated. Now, if you look into the considerations of macroadenomas and giant prolactinomas, so what are the goals when we treat these patients? Normalize the prolactin, decrease the mass effect, and restore eugonadism. But usually in the macroadenomas and the giant lesions, eugonadism is not restored very easily in either sexes because the concept of chronic functional LH suppression does exist, and maybe in a female you need to give OC therapy if the amenorrhea still persists, and for the males you need to give testis therapy if hypogonadism persists, and if the issue of fertility arises, you have to use other set of modality for fertility induction. So predictors of response is most of size dependent rather than being gender dependent. And if we see that the prolactin values are not normalizing or the tumor size is not shrinking down to 50% after adequate drug therapy for a year or so, consider that there could be resistant prolactinomas where you need to alter the line of management to either a surgical therapy or a radiotherapy, causes being decreased D2 receptor isoform expression, could be cystic lesion, and importantly, two things needs to be considered, especially in the younger patients where you see that you're treating a prolactin excess state and there is a lesion which is not coming down, then think of GH co-secretion and ACTH co-secretion, though the clinical manifestations of GH excess and ACTH excess will not be overtly present. And usually these lesions, they need to be treated for a longer time, probably lifelong, especially if you have the chiasma and the cavernous sinus involvement, and you need other assisted modalities of treatment like surgery or probably radiotherapy for these groups. So the long-term concerns when we use these drugs, most importantly cardiac valvulopathy, initially the concept was probably this can occur, but if the cumulative dose of cabergoline is restricted to 300 milligram, then we unlikely to have any cardiac lesion. So beyond 300 milligram cumulative dose, echo evaluation and involvement of the valve parts needs to be considered. The other one, apart from peritumoral fibrosis, optic nerve herniation, CSF rhinorrhea, pathological gambling, one needs to be considered about the impulse control disorder. So if you have a patient who is on drug therapy and is trying, probably is too ecstatic and is saying that everything is well and fine, then keep in mind and ask the family members that how he is behaving in the family, because exaggeration of impulse control disorders does occur. Now, the last but not the least is the estrogen mediated effects where we get prolactin excess state, most commonly OC pills and PCOS, where it is this hyperestrogenemia which stimulates and gives rise to elevated prolactin values. So do not overzealously treat them with dopa drugs and rather try to consider management of the PCOS per se or withdrawal of the OC pill therapy and further reassessment. Now, prolactin values increase but not to the values in the tumorous ranges. Rarely, FSH secreting pituitary adenomas can also present with hyperprolactinemia stage, so must be kept in consideration. And in certain group of hypogonadal men who are given testotherapy, this aromatization to estrogen and giving elevation of prolactin in males has been found, so a consideration of using non-aromatizable testo preparations for those males needs to be done. So this is one interesting scenario, idiopathic hyperprolactinemia. You have ruled out each and everything. You have ruled out systemic causes. You have ruled out tumorous lesions, but still prolactin is high. Proposed etiology being antibodies against the pituitary. And now this group is something, if the patient is symptomatic, if especially a female either with menstrual irregularities or bothersome galacturia, then consider treatment. But usually these are, females are resistant to dopa drugs and you need to keep them on the lowest possible drugs till the prolactin is normal for a longer duration of time or probably until they want pregnancy. And if the patient attains normal prolactin on the lowest possible drug, the drug can be discontinued, and it has been seen that around 30 to 40% of patients presenting with idiopathic hyperprolactinemia can have a normalization of prolactin after a couple of years of therapy, probably 1.5 years. So now the question comes is, how do we suspect our etiology of hyperprolactinemia from the prolactin values? So if you look into the drug category, primary hypothyroidism categories, usually the prolactin values do not increase beyond 100. And you can suspect a tumor lesions if the prolactins are high in the ranges of hundreds. Microprolactinemias, even at a prolactin values of 50 to 60, also they have been reported to be harboring microprolactinomas. But studies say that usually the average values of prolactin which does not go in microprolactinemias is not beyond around 180 to 190 ng per ml, but it can be on either end of the spectrum. And the larger tumors, yes, in hundreds to thousands and maybe in 10,000s. So just to sum up, how we go further with the management part, so excluding everything, the secondary causes of hyperprolactinemia, whether it's a microadenoma or a macroadenoma, decide the therapy, and we know that the first line of treatment, if you are harboring a cellular lesion, a micro or a macro, is the dopa agonist therapy. I'll just take 1 minute. So, and accordingly, you need to titrate the drug depending upon your patient scenario. If your patient has drug intolerance, then you may need to further decrease the drug or go for other modalities. And if the prolactin is normalizing by 4 weeks of therapy, continue the medication, repeat the prolactin after 4 weeks. If it is a small lesion, I'm imaging after 1 year, and then further depending upon what is the sex of the patient and how the patient is behaving, you need to go further. For a larger lesion, definitely along with the dopa therapy and monitoring, if the eugonadism does not restore back, then you may need to consider to use sex steroids in both the sexes. And if it is a female or a male, for during the fertility part, when it comes, induction with various drugs for the fertility issues needs to be considered. So that is all I hope.
Hello. I think the presentation was excellent, madam.
Thank you.
And now the house is open for questions, but before that I will just ask one question, madam. In first trimester, one patient was referred to me, and with the gestational age of 14 weeks, and she had complained of spontaneous galacturia, and a prolactin level was done by a gynecologist. It was around 400, ma'am. So at what level in first trimester will we suspect a prolactinoma?
So there is no guidelines, no consensus at what level in a first trimester of pregnancy you need to do. As I told that first of all, there are analytical problems, reconsider that. And in the first trimester also at 14 weeks when the estrogen has gone up, depending upon the sensitivity to the lactotrophs, it could have gone up. So anyways, if it is 400 and if the patient is complaining of galacturia at this point, already 14 weeks has been crossed. So depending on, you need to consider whether the drugs could interfere with the pregnancy part or not. But right now they say that pregnancy outcomes with either group of drugs, whether bromocriptine or carbapenem, is almost equivalent. So you may or may not need to consider the drug therapy if you can do a imaging at that point, and if there is no lesion, then wait and watch. If you do a imaging and there is a lesion and this patient is still insisting, then you can consider depending upon the scenario.
Is there any pregnancy specific trimester cutoff, ma'am?
No. No.
Okay. house is open for questions.
They said do not do a prolactin in the pregnancy. I don't know why the gynecologist first.
Actually, ma'am, I went to an article.
We got a patient, she's a medico last week in the OPD. She's a known case of PCOS since last 5 to 6 years on OCPIL therapy along with metformin therapy, which she complained of some hypomenorrhea problem. She went to a gynecologist and the gynecologist said that do a prolactin level. She's on OCPIL and the prolactin value, I remember it was 162 ng per ml done in some lab, I do not know exactly what. Now this, we all know that OCPIL, it causes an increment in prolactin, but what I went through some reviews was these drugs, if you have, and the prolactin values usually do not go beyond 50 to 60. So when she came to me and the value is 162, apart from everything, you need to have a consideration in your mind that maybe or may not be. So we have discontinued her drugs, probably repeat prolactin after a couple of weeks, see how it goes, and then consider for imaging or do not consider for imaging.
Actually, I went through one review, ma'am. It is published in Neurology, in pituitary, ma'am. It was like that in first trimester, the cutoff will be 4 times the upper fold of normal prolactin level in females.
But there is no consensus from the Endocrine Society as of yet.
On that, and in this
we should not do a prolactin.
Absolutely,
if somebody
sir.
is having
Absolutely.
pregnant, you should not do. And in recommendation says also it is only if a microprolactinoma, then even also in macroprolactinoma, it's a microprolactinoma, even a fundus examination or field chatting is not mandatory because it's not going to be macro, it's very chance of very less. If it is a macroprolactinoma, you have to do a fundus and the field analysis. If you are sure that he is having field cutoffs, then probably you can ask for a MRI without contrast, and if it is problematic and is the deterioration of the vision, then probably in the second trimester you can go for a surgery if indicated. But there is absolutely no indication for doing a prolactin if somebody is having pregnant.
And one more thing, in galactorrhea, idiopathic galactorrhea accounts to 40 to 50% in galactorrhea. So that female who came to you, it could be idiopathic also.
Question? Any other question from the audience? No. I think that's all, and they have understood everything. A passing comment here is the drug-induced hyperprolactinemia, which is very common in this part of the country after levosulfuride has come into picture. Lot of patients you will see taking some DAS-L, LL, they must be taking that, and we have an idea that the prolactin levels in drug-induced doesn't go beyond 200, but it's not a fact. Practically, you must have seen that many patients with taking levosulfuride, this group of drug, will have prolactin levels much higher than 200. So that becomes very difficult. So anytime when you have a prolactin level, please ask about levosulfuride, and if they are taking any of the PPIs and levosulfuride, you can stop it and reassess after 4 to 6 weeks. That will take care. Domperidone, the amount raised with levosulfuride is much more than domperidone. So that's it. Thank you very much.
Thank you, ma'am. Thank you, sir. I request you to please proceed to the presentation area. Next, we have a panel on adult immunization. I would like to request Chairperson, Professor Dr. Lisa Sarangi, ma'am, Professor, Department of Community Medicine, High-Tech Medical College, Bhubaneswar. And the panelist, Professor Dr. Srikant Dhar, Professor of Medicine, PG Department of Medicine, IMS and Some Hospital, Bhubaneswar, and Dr. Santosh Swai, Associate Professor of Medicine, Sri Jagannath Medical College, Puri. I will be moderating the session. So this panel on adult immunization, we thought it is a very practical thing and upcoming thing because we know about pediatric immunization, but adult immunization has not picked up that much. So through this platform, we wanted to ensure and to spread awareness regarding the adult immunization. First, I would like to ask Dr. Lisa Sarangi ma'am, why is immunization essential in adults? We know about pediatric immunization and it is so common, but being a professor of community medicine and the in charge of the immunization center at Hitech, why do you think immunization is essential in adults?
Yes, that's a very good question. Immunization in children is very popular, but I can see many reasons for immunization of adults. But 4 common reasons what I see is that immunization has been implemented since 1978 to be very precise. But those who are born after 1980, their immune response has started declining. So right now they're adults and they're into the middle age. So their immune response has started declining. That's the first and foremost reason. And then there has been a lot of antimicrobial use by the doctors. So antimicrobial resistance has also been increasing, and lot of unhealthy lifestyle practices which is leading to lot of non-communicable disease like obesity, cardiovascular diseases, and these are leading to all the comorbid conditions which has led to more of morbidity and mortality, particularly in influenza and pneumococcal pneumonia. And finally, one more important reason is lot of travel and globalization. So these are the 4 common reasons what I see that this is the most important reason why adults need immunization at the current scenario.
Thank you, ma'am. So indeed what the points which you touched upon are very practical points and which we encounter in day-to-day life. Now coming to Dr. Dhar, sir, in your opinion, which are the essential vaccines which every adult should take regardless of their comorbidities? We know people with comorbidities, they are generally immunocompromised, but a young, healthy adult. So what are the essential vaccines they should take?
Yeah, that's a good question. I think Dr. Lisa has already put some words about the pediatric population and their vaccination in adults, which we hesitate to give vaccination. So many diseases which are preventable. If you can sum up, numbers are many. I summarize them from A to Z. A, hepatitis A, hepatitis B, C, cholera, of course COVID this time, D, diphtheria, pertussis, tetanus, influenza, Japanese encephalitis, yellow fever, typhoid. So many diseases are preventable, but in adults probably the numbers which I have said, like influenza, the predominant of HPV infection, the diphtheria again you can control that, tetanus you can control, and all these numbers which I have shared, Japanese encephalitis can be given including typhoid. So these are the agents which are now doing menace in the community, like HPV I have said, hepatitis B I have said, A I have said, and recently COVID. So these vaccinations should be included in the adult population regardless of the comorbidity if it is indicated. So we should be along with the guidelines to know which are the vaccine has to be given to population, adult population maybe 18 years of old, and those who are not been vaccinated earlier or earlier been vaccinated needs a booster dose note. So we should follow a proper guideline. Even the pediatric guideline, there is a IAP guideline, also an American guideline. We have to check out everything and have our national guideline for adult, which is we are pending. Probably that will be a good thing ahead to be started. I have mentioned in the earlier, we are neglecting the adult vaccination.
What I understand, sir, we should be vaccinated against the communicable diseases, and the maximum number of communicable diseases possible against which the vaccine is available. But then again, we do not have a definite formula for everyone. It should be individualized according to the person, according to the age, according to the comorbidities and the previous immunization status. Thank you, sir. Now coming to Dr. Swain, why is adult immunization not so popular in our country like pediatric immunization? What is the lacuna according to you?
Well, the first thing is that there is no strict national guidelines, except for the two sorts of tetanus toxoid in pregnancy. There is no national guidelines for other vaccinations. Second, like COVID vaccination, the government ensured and enforced some like to produce the second dose vaccination. So in this case, also vaccine hesitancy is the factor, cost factor, missed opportunities. These are the number of factors which lead to the less popularity of the national guidelines. So plus there is no data of the vaccine preventable diseases in India. So the composed data, if you have the data, there's this number of vaccines, if we given, can prevent the disease, we can get it popularized. And also the awareness of the healthcare personnel and the patients and the publics also required for that popularization of the adult immunization.
So to summarize what you told, sir, it is the first is lack of knowledge. Lack of knowledge, then comes cost, then vaccine hesitancy. Pediatric, no child goes on their own, but they are forced to take the vaccine, but that can't be done with the adults.
If you allow me, even I would like to add a point here. When we started at adult immunization, we wanted to start adult immunization in high-tech also. The first and foremost and the major hurdle which we faced is that we lacked a guideline, because there was RSSDI, there was IMA which had their own guideline, there was GSI, they had their own guideline, IAOS, they had their guideline. So which guideline to follow? So unlike in pediatric age group, we have a Government of India guideline. We didn't have a individualized guideline for all the patients, for all people, adult people, we didn't have any guideline. So that guideline is lacking in this population. So probably if we get some certain guideline, it can be
only there are
standardized throughout
some
India.
consensus of different societies.
Yes, yes.
And hesitancy is the key, as you have seen in COVID vaccination.
Yes, sir, definitely. Now coming to the first proper vaccine, influenza. Ma'am, recommended dose is every year. Why is it required to be taken every year unlike any other vaccine? Some of the vaccines we need to take once in a lifetime, but influenza, we have to take a prick every year.
If we understand a little bit of microbiology behind this, the influenza vaccines are actually targeted on the surface proteins. There is hemagglutinin and neuraminidase, which we know from our earlier MBBS this thing. So there are around 18 types of hemagglutinin and 9 types of neuraminidase, and they permutate and combine to form these strains every year, and they are new every year. So what the expert group has done, every year they predict that there are 4 strains which are going to circulate throughout the world, and then they predict and they come out with 4 strains, and those 4 strains actually are prepared as vaccines. The companies, they come as vaccines with those 4 strains, and hopefully they'll be protective. At least if not 100%, 70% protection will be, with that prediction 70% protection can be got. But every year it has to change, provided till we get something into the nucleic acid. If we get any antigen, if we get any protection for the inside of the virus, then only we can get a vaccine which will be effective throughout a lifetime, or probably for 10 or 15 years. But for now we are doing a vaccine only for the outer protective layer. So that is why we need it every year once.
That was very crisp and clear, ma'am. Thank you. Now, Dhara sir, how many types of influenza vaccines are there, and what is the difference?
At present, the subunit vaccine are prevalent. Earlier you can say there are so many vaccines like subunit, total vaccine, live attenuated, which is nasal, but not been used the subunit vaccine which is tetravalent or trivalent. Earlier it was trivalent, now Dr. Lisa has said this is quadrivalent, and northern hemisphere 1, southern hemisphere 1. So these 4 variety of influenza which are prevalent, they have been taken into account, like Cambodia, the Phuket variety, and Victorian, Austria. The 4 variety they've been chosen, and they have been accomplished for a vaccine which every year we get through, and probably the quadrivalent vaccine, the quadrivalent vaccine is now which is available and should be given every year before the season starts. Usually this is September, they say, according to the WHO, but before the rainy season start, probably it should be used 2 weeks prior to that. So this is the vaccine which is available nowadays for influenza infection.
The nasal vaccine is the live vaccine, but it's not very common and not very popular. Earlier we had trivalent, but now only quadrivalent is available, and as ma'am told, according to the prevalent strains. Thank you, sir. Now, Dr. Swami, is influenza vaccine helpful in the COVID era? And do you think, along with the influenza vaccine, a yearly COVID vaccine should be recommended for everyone?
Well, after the influenza vaccine, there is a boost in the innate immunity, which is the primary first line defense against any infections. So, studies like European Congress, one paper was presented. They had the study that though had not taken the influenza vaccine, there is chance of 20% more risk of hospital admission to ICU and emergency department admission. So, the recommendation is given that influenza vaccine may be given yearly. But still in this year, we are not taken the...
The hospitalization rates decreased by 20%.
One study says that the hospitalization is 6.1 versus 12, almost half. And the progression of the disease also even half. Those who have taken vaccine, this is a recent study you can see.
And the second part of the question, every year we have been taking a COVID vaccine, we have taken the 3rd dose. So do you think it should be a part of the adult immunization program? If at all a program like this is launched by the government?
Now probably in a year or so we'll be getting a quadrivalent vaccine like that of influenza virus, combining all 4. It is in the pipeline, probably this year or so we'll be getting that. And the guideline may come up ahead and that may be included. This is the early time to say about that.
Yeah, it's true.
Thank you, sir. Now coming to next, pneumococcal. Dhara sir, how many types of pneumococcal vaccines are present and what are their characteristics?
Now there are 2 prevalent vaccination, PCV, the 13 and 23. You know, one is protein vaccine, one is the carbohydrate vaccine. The PCV, the most useful one, the 15 one, this is the conjugate vaccine can give maximum immunity. You might be saying that this 23 is better because it is covering 23 varieties of pneumococcal strain, but that 13, but the robust antibody production in 13 gives is a better role to play. 23 can be given, but it has got a lesser immunity status, and probably the 5 year or so it may come down. And according to the indication, probably you are going to give which one to give, whether this is Pfizer or the Pneumovac 23.
Thank you, sir. Swami sir, in which category of patient, as sir told, 23 and 13 should we prescribe? PCV 13 and PPSV 23.
So as he told that PCV has a more efficacy, PCV 13 can be given more than 65 years old, and the PPSV 23 from 19 to 64.
Okay, mainly in immunocompromised we need to, because in pediatric...
But in comorbid conditions, both the 13 and 23 can be given.
Pediatric only PCV 13 is given, so immunocompromised state, same with elderly population. I think the new guideline is more than 50. Rather, last year it was 65, now it has come to 50.
The guidelines has not come up yet. Probably they are declaring this year this should be cut down to 50. 2 more vaccines are also available, 20 and 15. But that can be given
not
after
for
18
adults.
years. But it is for adults above 18 years, but not been instituted in the guideline.
Okay.
Probably they are working on this because of some constraint.
Okay, sir. Thank you, sir. Lisa ma'am, what is the dosing schedule of both the variants 23 and 13?
Yes, since there are 2 vaccines, 2 types of vaccines as was told by Dr. Dhara and Dr. Swai, 23, PPSV 23 and PCV 13. So PCV 13 causes more antibody response. So that should be given first. If you ask me, that should be given always first. It should be followed by PPSV 23, and that schedule should be, the gap should be a 1 year, full 1 year. Even if a patient has taken PPSV 23 first, then also give a gap of 1 year. But in this scenario, since the patient has taken PPSV23 first and then after 1 year has taken PCV13, again give another dose of PPSV23 after a gap of 5 years from the earlier dose of PPSV23. So that 5-year gap should be maintained. So this is the dosing schedule of PCV13 and PPSV23. So if to repeat, because this is a little bit confusing because
I'll say it, ma'am. PCV13 should be given once. Then followed by 1 year PPSV23 and PPSV23 repeated every 5 years. No need to repeat the PCV13.
It should not be repeated every 5 years. Only once it should be repeated after 5 years.
Like a booster dose.
But provided if it is given earlier than PCV13.
Okay.
If it is given later than PCV13, no need of repeating it.
That counts only beyond 65 years.
Yes.
Probably it is the borderline is 65 years. Somebody has used the PSP 23, then you give the PCV because one shot can give lifelong immunity, but because it is not covering, only 13 strain has been covered, another few left. So if you give another one starting from the previous dose, 5 year ahead, you give a better coverage. But 5 year is the key for practice.
And my dear esteemed panelists also, I would like to also share something. GSI, RSSDI and IMA and IAOH, these 4 organizations in India have asked 50 years. SCPI, yes, and CDC, they have asked 65 years. So there are again so many contradictions and so many age groups which are mattering here. So it has to depend on the physician, it has to also depend upon the patient, whether they are willing to take, whether they are asking for at 50 years, whether they are asking, whether we suggest that if he is a smoker, if he is an asthmatic, we should go ahead and we should give a dose of PCV13.
We should look into the comorbidities,
yes, definitely.
And then decide. Post 50 years we can give it.
We should.
Thank you. They are coming up this guideline, this probably in 2 months or so, it will be reduced to 50 year rather than 65 year.
Yes.
Now hepatitis A and B, Dr. Swine, is it recommended for everyone or do you recommend it in specific set of patients?
For hepatitis B, it is recommended for all adults, and also special recommendations like chronic liver disease and metabolic disease like diabetes and cancer, CKD. But for hepatitis A, it is optional, particularly risk factors like the patient taking regular plasma concentrates like sickle cell hemophilia and infected with other hepatitis virus also is an indication, and awaiting liver transplant or post liver transplant we can give the vaccine.
Thank you, sir. Ma'am, what would be the dosing schedule of hepatitis A and hepatitis B?
For hepatitis A, it is at 0, that means the start of the dose, and after 6 to 12 months, the second dose. And for hepatitis B, it is 0, that is the starting of the dose, and then after 1 month, and then after 6 months from the day 0. So these are the 3 doses.
But if we need to get a quick antibody, we can give it in 2, 0, 1, 2 also.
Okay.
Second month onward, you can give them
To achieve a rapid antibody.
Yes.
And every 5 years, we can repeat the antibody titer.
Antibody titer can be repeated.
Sir has already answered. Is there a need for a booster dose for hepatitis A or B?
For B, this is important, as he has already said. We should know the normally study says that with 3 sort of vaccine, as he has said, it is around 18 year of immunity you are getting. But for all practical purposes, you should see the antibody. The normal range is 5 to 12. If it is beyond 12, it is normal. Guidelines say if it is less than 10, probably you should get a booster vaccination. Same shot, single shot you should take. For B, for A, this is not available. Single shot is enough. And in pregnant ladies, you can have if they are not been immunized earlier. But no booster shot for hepatitis A.
Do we need to check for the titer every year or every 5 years? Is it recommended?
Yeah, it is should be done, especially those who are
in healthcare workers, those who are exposed.
Ideally, they said that if there are no comorbidity, should not check. But if you are having some risk like the healthcare professional, those who are risk factor for hepatitis B infection, or they may have transfusion ahead or some immunocompromised set, they should go for antibody status. If it is less than 10, go for a shot.
Thank you, sir. Now coming to HPV, the most important of the vaccines, and in adults it is quite less used. Ma'am, how many doses are recommended, and which is the age group in which it should be given?
So I'll answer the second part first. In which age group? Ideally, before the girl is sexually active, it should be started. So perhaps 9 to 12 years is the best time to start the vaccination, but it can be given from 9 to 45 years of age. The recommendation is from 9 to 45 years of age, and 3 doses are given. So basically there are 2 vaccines, Cervarix and Gardasil. Throughout world, there are 2 types of vaccines that are available. So those 2 vaccines are given. Cervarix is 0, 1 and 6, and Gardasil is 0, 2 and 6. So these are the months. 0 dose is starting dose, 1 month and 6 months, or Gardasil is 0 month. 0 is starting dose and 2 months and 6 months.
Can I add?
Yes, sir.
Gardasil 9 is available not in India, where 9 strains are available, which we are using is 2 strains, 16 and 18.
16 and 18.
And probably when 4 strains are, we are using 6 and 11. Now Gardasil 9 is available, not available in India. That is a better one. It will cover 9 strains, but yet to find in India.
Thank you, sir. So is it only for girls, or can boys also take it?
Yeah, they can take it. Guidelines said below 21 years they can say, because the anorectal carcinoma probably 30 to 50% is HPV indicated. Oral cancer around 25% it is. This
but
is
in India,
But
is it
not
approved?
recommended.
In
Only
India,
in Australia it is approved.
This is not
US
recommended.
also, ADA guidelines say, US guidelines say, but India, boys, it is not.
It is not recommended in India, but it is worldwide, especially in USA, they are going for this primary vaccination also in males.
Last question, there are 2 variants. It's written trivalent, the bivalent and the quadrivalent. Which is preferred in the Indian setting, the Cervarix or the Gardasil?
As the quadrivalent that Gardasil has, in addition to preventing cervical cancer, it has also potential of preventing anogenital warts. So it should be preferred.
Better to go for it. Now I think the price difference is also quite less. Earlier the price difference was quite high, but now it has come less. So if I summarize our talk, vaccines are important in adults because, as ma'am told, immune response has become less, antimicrobial resistance has increased, unhealthy practices, travel, then essential vaccines, influenza, pneumococcal, hepatitis A, B, HPV and COVID for now. And it is not so popular due to lack of knowledge, lack of guidelines, cost, vaccine hesitancy. Influenza recommended every year, only quadrivalent is available now. It enhances the lung immunity, so it is beneficial in COVID. In pneumococcal, 2 types, 13 and 23. 13 is for more than 50 years. The guidelines will come in 2-3 months. PPSV 23, 19 to 64, and as ma'am told, it should be repeated 5 years, but that dosing is there. PCV 13, then after 1 year 23, then after 5 years 23 again. Hepatitis A and B, basically hepatitis B is recommended for everyone, particularly healthcare professionals or anyone who has hepatic disorders. A dose is 0 and 6, B dose is 0, 1 and 6, but 0, 1 and 2 can also be given. Booster is required if titer is less than 10, as sir mentioned. HPV, 3 doses, 0, 2 and 6 for Gardasil and 0, 1 and 6 for Cervarix. 9 years to 45 years, 9 to 11 years, I think 2 doses are required. Then beyond 11 years, 3 doses are required. Only for girls in India, also but recommended for boys also outside India in Australia and USA. Bivalent is enough for India, it covers all the strains, but quadrivalent, as sir told, is better because it prevents the anal warts. That was all from the panel. So in case you have any questions. Okay. Thank you, sir. Thank you, ma'am. I request you to please proceed to the presentation area. Now coming to the next session, may I invite the chairpersons, Dr. Kishore Kumar Behra sir, Associate Professor, Department of Endocrinology, AIIMS, Bhubaneswar, and Dr. Subhash Ranjan Behra, Consultant Endocrinologist, Capital Hospital, Bhubaneswar, to please come on the stage.
Hello, good afternoon everybody. Today this is the last session of Edu Feast. So for this we have with us the renowned endocrinologist of Odisha, Professor Dr. Jashree Swai. She is now serving as a professor in Department of Endocrinology, IMS and some hospital. She has many publications in national and international journals, and she needs no further introduction as she is one of the best endocrinologists of Odisha. So I may request ma'am to start this session, please. Thank you.
Thank you, Chairperson. Good afternoon, everybody. This is the last talk of this conference. So my topic is effect of hemogliflozin on glycemic variability, REMIT GV study. Before going to this topic proper, I would like to highlight something regarding this glycemic variability and postprandial hyperglycemia and the meal pattern of Indian meal pattern. So as we all know, glycemic variability is the fluctuations of the blood glucose level over a given interval of the time. That means inter-day variation and intraday variations. It may be this long-term glycemic variability or short-term glycemic variability. Long-term glycemic variability may be they are fasting blood glucose, postprandial and HbA1c. And if you look to this short-term glycemic variability, these are the time in range, standard deviation, coefficient of variance, mean average glycemic excursions, and mean average of for daily difference. These are the so many parameters are there for this short-term glycemic variability, and we generally measure it through this continuous glucose monitoring. And then what is this need for glycemic variability in our clinical scenario, and what is its implications? So if the two persons are having A1C level of 8 is present and somebody is presenting with the complaining of a repeated hypoglycemia, and if you will go for this CGMS monitoring, you will find there is hyperglycemia and hypoglycemia which is present most of the times those persons who is presenting with which complaining of a hypoglycemia. So we should address these fluctuations of hyperglycemia and hypoglycemia. As we all know, this glycemic variation is related to the cardiovascular mortality. So the treatment, our anti-diabetic agent should be directed against these fluctuations so that we will have a better outcomes. Then we all know the glycemic variability is related to these vascular complications through as somebody is suffering from the hypoglycemia. He may have the cardiovascular autonomic dysfunctions, thereby landing in the increase the cardiovascular event. And again, if there is very much fluctuations, the patient may land in the severe hypoglycemia, which is again deleterious effect. And it is well correlated with the microvascular complications and macrovascular complications. And if you, we all know postprandial blood glucose, role of postprandial blood glucose in A1C. Apart from that, postprandial blood glucose is an independent risk factor for the cardiovascular disease, and there is a linear relationship with that of the risk of the cardiovascular death, and it is a good predictor of the cardiovascular related and all cause of the mortality, whereas the post fasting blood glucose, they do not have these correlations. And again, for that things, our aim should have a good glycemic control, along with that the good postprandial blood glucose controls. While talking about the postprandial blood glucose control, we should measure the post breakfast, because of that the highest glucose excursion is there in post breakfast in comparison to the lunch and dinner, and it is more consistent, and there is less variation in day to day variation in the post breakfast blood glucose. Again, studies have shown that if you are taking more amount of the carbohydrate food with dinner, you may have the post dinner blood glucose rise, and it is well correlated with the cardiovascular event. So this is the scenario why how our postprandial blood glucose is important for us. And again, coming to this, what is the pathophysiology of the post glucose excursions and cardiovascular event and other things. If you have a post glucose spike, you may have these inflammations and oxidative stress, thereby it increases the endothelial cells dysfunctions. And here they have incorporated a new term, that is vascular failure. And if you have this hypertension, diabetes and dyslipidemia, you may have these inflammations and that is oxidative stress, and which all lead to the endothelial cells dysfunctions, thereby increased smooth muscle cells proliferations and plaque formations, which subsequently lead to the instability of this plaque, rupture of this plaque and thrombus formations, thereby lead to the cardiovascular event, that is myocardial infarction and strokes. So it is collectively known as these vascular failures. So the journeying from the vascular dysfunction to the vascular failure, the role of postprandial blood glucose rise has a major implication here. So our anti-diabetic agent we should direct our anti-diabetic agent in such a way that it will minimize the postprandial rise, so that it will minimize the vascular event and vascular failure. Apart from that, if you look to the dietary pattern of the Indians, the meal pattern, the dietary pattern of the Indian, I would like to quote a study, famous study, STAR study. It is by this Professor Sasanka Joshi and al. Published in the BMJ in 2014. Here they include 800 study populations in this study, and these are from the 10 centers from this reputed endocrinologist and diabetology center across these five regions all over India. What they found in this study, that we Indians are very fond of taking carbohydrate diet, and our diet content approximately 60% to that of the 70% carbohydrate, and we are using more of carbohydrate in our energy as comparison to the Western country. They are using more proteins. So that is another interesting fact from this STAR study was that there is no much difference between this carbohydrate intake in diabetic population and non-diabetic populations. So and also we are using more carbohydrate in comparison to the Western populations, and also recommended carbohydrate for these Indians. So again, there is a systemic review regarding the diet pattern of Indians, which is published in the British Nutrition Journal by the Green and al. in 2016, which shows that this meal pattern of these Indians, by this particular meal pattern, we have more metabolic syndrome, we have more insulin resistance, and we have more early beta cell destructions. And the meal pattern affect this glycemic variability, which include these postprandial excursions and hyperglycemia, particularly in Indian diabetic patient, and we should adapt our treatment accordingly to minimize these postprandial excursions, so also the cardiovascular event. So, in this context, I would like to elaborate one study, that is the REMIT-GV study. It is the randomized control trial to compare the effect of REMO versus DAPA in 24-hour glucose profiles assessed by the CGMS in Indian type 2 diabetes patients. Particularly, it is the part of the REMOLUTION study, which is a real world study and it is ongoing trials. And the REMIT-GV study is also the data in file. And the rationale of this REMIT-GV study is that the twice daily regimen of the remoglipogins, it has been shown to provide this effective glycemic controls when compared with the dapagliflozin, and this data from the phase 3 trials. But the impact of the glycemic variability due to the twice daily regimen of the remogliflozin is not known. So, the remogliflozin twice daily regimen can potentially offer this better postprandial control in Indian diabetic patient. This is the rationale of this study. Coming to this study designs, it is the open label randomized 2-arm parallel study. Here 75 patients are included in this study, but they have analyzed 65 patients and study duration is 6 weeks. And type 2 diabetic patient, those who have these uncontrolled blood sugars and previously on monotherapy with metformin or dual therapy with metformin and DPP4 inhibitors are included in this study. And in one arm they have given the remogliflozins twice daily, and in other arm they have given these dapagliflozins. And the study, these centers are Care Hospital Hyderabad. Dr. Bipin Sethi is one of the principal investigator of this study, and along with that 4 other reputed centers these studies they have taken this study. So, as inclusion criteria, adult type 2 diabetes more than 18 years with A1C level more than 7, less than 9 included in the study, and those patients are with monotherapy or the dual therapy with the DPP4 inhibitor, and along with that they are compliant to these dietary regimens. These are the inclusion criteria. And in exclusion criteria, any acute event that is decay or honk or cardiac arrhythmia or ACS, or those patients in the GFR less than 60, and along with that anemia, pregnancy, lactation and hypersensitive to the drugs are excluded from this study. This is the study flow. In first 14 days they are doing this CGMS, and the last 13 days they are doing this second phase of this CGMS. In first 4 days they have given these drugs after 4 days of this continuous glucose monitoring. That means first CGMS monitoring was 14 days, second CGMS monitoring was 13 days, and the first 4 days baseline CGMS monitoring, and the drug has been started after 4 days. So, what is the objective of this study? That means to evaluate the glycemic profile of remogliflozins and to compare the glycemic profile of remogliflozin with that of the DAPA, and to evaluate the safety and tolerability of these both molecules. This is the primary and secondary objective of this study. Then coming to the demographic characteristics, it is at par, the populations under this REMO and this DAPA is at par on this baseline characteristics. Coming to that of the CGMS glycemic parameters, there is no difference between the two groups. If you compare the glycemic parameters of the baseline with that of the phase 1, that means CGMS monitoring of day 1 to day 4 when compared with that of the day 5 to day 14, the baseline versus the phase 1, in case of the remogliflozins, there is all statistical significance difference is seen except the coefficients of variance. And if you look to the dapagliflozins, particularly the mean postprandial glycemic excursions and 1 hour postprandial blood glucose levels, there is not much statistical difference seen in case of the dapagliflozin. So, in phase 1 analysis, and the remogliflozin is better reductions in all glycemic parameter when compared with the dapagliflozins. And coming to the phase 2 analysis, that means baseline versus the phase 2 analysis, all these parameters are favorable for the remoglyphogins, but if you look to the dapagliflozins, there is a TIR, that is a significantly improvement in the TIR, that is good for the remo and the DAPA, but if you look to the MES, mean amplitude of glycemic excursions, and also that of the mean postprandial glucose excursions, 1 hour PP and 2 hour PP, there is not much change. So there is no statistical significant difference. So remo is scoring over the DAPA in this phase 2 analysis. But these are the inter-group variation. If you are intra-group variation, if you look to this inter-group comparison between the remo and the dapagliflozin, there is not much difference between these two groups and no statistical significant difference. So again, if you analyze the individual parameters, glycemic parameter, what we have monitored in continuous glucose monitoring, particularly TIR and HbA1c and mean postprandial glycemic excursions, the particular TIR, there was a significant improvement in the baseline to the phase 1 and phase 2 in case of the remo and the DAPA, but there is no statistical significance difference when you compare the two groups. So similarly, other postprandial glycemic parameter, there is good reduction is seen in case of the remo and the DAPA, and statistically significant difference is maintained in case of the remo for the mean postprandial glycemic excursion, 1 hour PP and 2 hour PP. So statistical significant difference is here. And again, that is mean postprandial glycemic excursions baseline versus the phase 2. There is a difference, statistically significant reductions in these parameters seen in case of the remoglyphogin group at breakfast and also during the dinner. But in case of the DAPA, there is only difference seen in the dinner. This is the major difference between the remo and the DAPA. And also, that is 1 hour parameters, statistically significant difference seen in case of the remoglyphogin in breakfast, lunch and dinner, which is not seen in case of the DAPA. So, when you compare the 2 hour parameters in breakfast, lunch and dinner, here there is statistical significant difference seen in case of the remo in both in breakfast, lunch and dinner, but in case of the DAPA, we are getting this benefit in breakfast and lunch, but in breakfast and dinner, when lunch we are not getting anything. So if you look to the mean change in continuous glucose parameters profiles across the 24 hour during the from the baseline to the phase 2 trials through the entire study periods, there is more reductions in the glycemic parameters seen in case of the remoglyphogins as compared to the DAPA. And again, decrease in the blood sugar after the dinner is more in case of the remoglyphogin as compared to the dapagliflozins. So to summarize this REMIT-GV study, there is significant improvement in the TIR and reduction in HbA1c level with the both group, and there is a significant improvement in the postprandial glycemic parameters in term of mean postprandial glucose excursions, 1 hour PP, 2 hour PP seen in case of the remo group, which is not seen in not significant in case of the DAPA group. Again, significant improvement seen in the all meal, which is seen breakfast, lunch and dinner in case of the remo group, which is not in the DAPA group. Only benefit are seen in the DAPA group, 2 hour blood sugars in the breakfast and dinner, and there is no adverse event like hypoglycemia seen in case of the and hypoglycemia is at par in both groups. So to summarize my presentation, that the main objective of any anti-diabetic treatment, it should address the A1C and also the postprandials, also that the glycemic variations parameters like that of the TIR, coefficient variance, mean postprandial glycemic excursions and other parameters. So our main goal should address both the things, A1C and other glycemic variability parameters. As we know, we Indians are very fond of this taking carbohydrate food. Our postprandial blood glucose is very high, and postprandial blood glucose is related to that of the cardiovascular event. And and in REMIT GV study, remogliflozin there is improvement in A1C, TIR and MACE. So it is similar to that of the dapagliflozins, but the postprandial parameter, the postprandial glycemic parameter like that of the mean postprandial glycemic excursion, 1 hour PP, 2 hour PP, there is a statistically significant improvement seen in case of the remogliflozin, which is monitored through the continuous glucose monitoring, and it is not seen in case of the dapagliflozin. So remogliflozins might be a better in reducing the glycemic variability and better in controlling the postprandial glucose excursion, so that by prescribing that we will modify our postprandial glycemic excursions and our cardiovascular event. So thank you for your patience hearing. If there is any questions, I will be happy to approach.
I have questions. I think the first hour, 2 hour and postprandial, which is not significant, I think, because have they calculated the power of the studies, sample calculation?
No, it is the pioneer study. It is the actually that is Remolitions is a real world evidence study, and REMIT GV is a part of that Remolition study. They have taken only 33 patients in this study, and in both arms, 33 both arms, total study population is 65. So power of study, how to estimate the power of study, which is the first in this category. So it is a continuous glucose monitoring, and it is very difficult to take a large number of this population in the for this continuous glucose monitoring. So 35 is not a less number for continuous glucose monitoring.
So it is, I mean, it's very hard to say that probably the dapagliflozin is not doing good with, I mean, 1 hour, 2 hour. I think maybe a large population studies to have, and we can have a conclusion.
Definitely, large study is needed for conclusion of that, and A1C control is at far, TIR is at far, but a first hour PP, 2 hour PP is more control in case of the remogliflozins, and they are claiming that it is because of the twice daily, it is the dose schedule, and night control of blood glucose is more in case of the remogliflozins. That's why they are claiming that it is more beneficial in cardiovascular, controlling this cardiovascular event.
I think the cardiovascular benefit you can say over a period of few months.
Remo don't have
the say few years together. So my last question is it better to use remogliflozin twice daily rather than using dapagliflozin once daily, because the cost is almost equal?
No, you have so many benefits of the DAPA. You can compare these things like this, the two molecules like this. We know this dedicated CVOT trials is with these dapagliflozins. That's why we are catching that in REMO we are getting extra benefit of these postprandial blood glucose controls, and we are getting this extra benefit. So we will get these cardiovascular benefits. That is the reason. And REMO don't have these dedicated cardiovascular outcome trials.
Any question from the audience, or we'll wind up the session? Thank you, Professor Joyce Swami, for excellent deliberation. And with this we end this session, and we invite Sambit for dais for next session.
Thank you, sir. Thank you, ma'am. That was the last session. Now I request our organizing secretary, Professor Dr. Sambit Das, for the valedictory function.
Thank you, Mahesh. And every good thing has to end, and we are at the fag end, and this is the valedictory function. So I first of all I thank the hotel Mayfair, Mr. Chidanand, Mr. Ali, Anil and team for giving this wonderful hospitality. I must thank Saroj and team for giving the backdrop and all. Audiovisual team, Chubby and team, they have really done good. Pharmas, the function cannot happen without the pharma support, and I must thank pharmas like Microlabs, Novo, Novartis, Eris, Lupus, Lupin, Zydus, Intas, Cipla, USB and Abbott. My sincere thanks to them. Without them we could not have done this function. Definitely I must appreciate our help from advisors like Alok sir is there. He has always been a constant support. SR Patnaik sir, CC sir, Pitambar Prushti sir is the co-organizing and he has always stood beside me. And Jayant Panda sir and Abhay bhai has always been like big brothers and they have helped me. So last but not the least, I must thank 4 people who have really done wonders and they have really helped me, and I must ask them to come over the stage. First is Dr. Mahesh Rath. So Mahesh has been there from beginning to end and he has conducted all the things. Mr. Shamim was there and who has been there for 2 days, and he has arranged all the scientific program and the CVs and all. I must thank Aditi. Where are you? So Aditi has done the third party and she has the Casa Eventos has done wonderful job. I must thank from our Endeavor team Ramesh, who has always been there. Where is Ramesh? So he has been managing the event. So I must take a photograph with all of them. So I must thank our team, our Endeavor team who is sitting there, and our Apollo Sugar team who have always supported and were always there for the function, and I'll take a separate photograph with you all. And with that I'll thank, and the function cannot end without the support of obviously the faculties, and this time there were almost like 18 national faculties and another 20 local faculties, and they did deliver it very nicely, and thanks to the delegates who have always been there. So thank you all. I must thank my friends also, like Jayashree madam, Ritesh and Sunil Kota, who have always helped me. Thank you, thank you. So my Endeavor team has done. must thank Ankit, who has been, and the RX event team. Thank you, thank you. Special thanks to you. Somehow I have written, I missed that. Aajo, aajo. Saroj babu. Chala, asa support.
It will be unfair ନାଇଁ ହଉ କିଛି ଦରକାର ନାହିଁ ଆଜି ଏଡୁ ପ୍ରୋଗ୍ରାମର କମ୍ପ୍ଲିସନ୍ ବେଳେ ଭ୍ୟାଲିଡେକ୍ଟରୀ ବେଳେ ଡକ୍ଟର ସମ୍ବିତ ସମସ୍ତଙ୍କୁ ଧନ୍ୟବାଦ ଦେଲେ ନିଜ ଛଡ଼ା ତେଣୁ ମୋର ଏଇଟା ଆଜ୍ ଦି ଅଲମୋଷ୍ଟ ସିନିୟର ମୋଷ୍ଟ ଇନ୍ ଦି ଏରିଆ ମୁଁ ଭାବୁଛି ଏତେ ବଡ଼ ୱଣ୍ଡରଫୁଲ୍ ଏକାଡେମିକ୍ ପ୍ରୋଗ୍ରାମ ଯାହା ଡକ୍ଟର ସମ୍ବିତ and his team have gathered and created and completed so efficiently with a smiling face, he deserves a standing ovation by everybody. May God give you enough strength, knowledge and wishes to continue this academic events and journey that you have been continuing. We are proud of you. Thank you.